I hope you can hear me. Hello? Roshan, can you hear me?
Yes, sir. Can hear you.
Yes, sir.
Okay. At the outset, may I thank Roshan and the team from the Ministry of Health for organizing this, what I consider as an extremely important program before you start the most important part of your career as a doctor for young interns. And also Gayan, thank you very much for coordinating on behalf of our beloved College of Surgeons of Sri Lanka. Well, as I think I've been already introduced, those of you who don't know me, my name is Mohan Silva. I'm a surgeon, and I was working in many hospitals in this country before I came to this center, and then I've retired now. Now, what I thought was in this program, I'm going to share with you some of my thoughts and experiences, which I think will help you to get the best out of your internship. In fact, I would like to tell you my first day of internship, long time ago. I was an intern to Professor Navaratna, who was an illustrious professor of surgery at the Faculty of Medicine, Colombo, and senior lecturer at the time was Professor H. Sharifdin, who eventually took over and retired as a chair in surgery in Colombo. So on the first day itself, I was getting ready for the ward round next day. Those were the days where we have to tell the consultant everything that is going on in the ward about your patient. So I was not ready, and I started the ward round at 8 p.m. on the first day of my internship without anyone else. And by 11 o'clock, I found someone who's lying in bed, a young man who was assaulted. And to cut a long story short, I found that he's got hemoperitoneum, which was very worrying, but at the same time exciting. I rang Dr. Sharifdin, and he immediately came to the theater by 11 o'clock, and he had a gush, belly full of blood due to a rupture of a subcapsular hematoma of the spleen. And I learned for the first time how to do emergency splenectomy on that night. So as a youngster, I'm sure some of you will have this experience. I found surgery a fascinating field because of the challenging nature of surgery as compared with all other specialties in the field of medicine. I'm not downplaying the other specialties, but surgery is certainly a fascinating field. And I actually had the glimpse of this experience when I was a third and fourth year student. I used to go to the accident service, in the old accident service in Colombo, and used to work till late in the night, putting plasters, suturing wounds, giving locals, assisting surgeons who were young surgeons for laparotomy. So it was actually a fun more than at the time, but it really got us into this where we are today. So I was thinking what to tell you. I think the first thing I want to tell you is that in reflecting back on my career, in the medical faculty in Colombo, and I'm sure a lot of you have come from various medical faculties in Sri Lanka and also many prestigious medical faculties abroad, what I thought was, looking back, I actually, during the medical faculty time, what I learned was mainly the science of surgery, more than the art of surgery. It's the science of surgery. And but it's during the internship that I actually learned the actual art and the craft of surgery. So what do I mean by the art and craft of surgery, which I learned during the internship? Well, to me, it was a set of skills, which I learned during the 1 year, that is the first year of internship. What did I learn? I learned to diagnose. I learned to perform procedures. I learned to communicate with the patients, the relatives, all my colleagues and the nurses. And also I learned how to work as a professional in a team of professionals in surgery. So how did I learn all these? Well, I thought I learned these things, these skills, during my ward rounds, when I clerk patients, when I perform procedures, small minor procedures like collecting blood or giving a lumbar puncture or something like that, And when I help my senior colleagues, the SHOs, the registrars, those days there were no senior registrars, to manage critically ill patients and also critically injured patients, which was really a excitable times of our life as intern. So to me, thinking back, actually every patient was a learning tool and a challenge, if you look at it that way. So from whom did I learn these skills? Well, first from my consultant. I think you're aware that at the end of the 6 months of your internship in surgery, your consultant, that is a consultant surgeon under which you're going to work, has to sign what is called the Certificate of Good Standing regarding your performance. That is for the purpose of Sri Lanka Medical Council. But that's not the only reason your consultant is important to you. The main reason is that he or she may be your best learning tool to learn all these skills which I mentioned. Of course, you will not see your consultant every minute, every day, because they are busy people. So you must try and get the best out of them when you meet your consultant. That is during the ward rounds, in the operating theaters, in the surgical clinics, or in the endoscopy unit. But to get the best out of their experience, you must impress them with your performance. So what actually happens in practice? What actually happens in practice is that during the first few weeks, your consultant is going to observe you. Not that it just happens subconsciously, automatically, to find out who you are. In my opinion, most consultants all over the world, this is true, are impressed by 7 qualities of the intern. First, your punctuality. When the consultant arrives into the ward, if you come after him, that doesn't give a very good impression about you, because you should be coming at least half an hour before him and just check everything that is going on in the ward so that you're ready to report to him the issues that is going on in your ward. And also, whenever you get a call from the ward in the most unsocial hours, like 2 o'clock in the morning or early in the morning, from the nurses, they are the guardians in the ward, you should respond so that you will be responding to emergency calls. So that's very punctual. And before you know, that information has gone to your consultant that this is a new intern, he is very responsive, he will respond to our calls, et cetera, et cetera. And that's very helpful. Secondly, your approach to your work responsibility. Approach to your work responsibility. What do I mean that? I remember when I was a post-intern appointment, first appointment to Kegal Hospital those days, years ago. I came from a prof unit in Colombo, and then I walked in there on the first day, and I found that the consultant is going to come soon. And there were about 20, 30 beds, and I just did a quick round so that I understand, because by that time I was experienced, and I thought I finished the job. And the nurse looked at me and said, Dr. May, flow patients left. And I found that flow had about 70 patients on that day. So that is a type of work, sometimes you might be confronted. So what I meant by work responsibility, when during the ward round, when the consultant tells you, well, can you organize a chest X-ray for this gentleman because he has to go to the theater tomorrow? He's got dyspnea on exertion. I think it's better to get a cardiological opinion on this patient. And this patient looks anemic. I would like to get the hemoglobin before you list this patient for surgery, and at least 2 units of blood. All these, everything is going to be continuous about different patients. So just imagine that you have got 40 to 50 patients, sometimes more in some peripheral units. At the end of the ward round, you can't recollect, even the best of minds can't recollect all those instructions and information and things about different patients. So it's very important that the intern should have a small book in your pocket, so that whenever something comes, you make a small note on that, so that once the consultant leaves, you are inundated with various responsibilities you've been given, but you all made a small note so that it's easy to follow. So when the consultant notices that whatever he tells you, that you're recording it, so you're writing it in a way you can understand, that's very impressive, so that you become a responsible type of doctor. Then you are reliability. So All you have written all this, have you actually done it the next day, ward round, or let's say in the theater, or wherever it is? So have you performed the task? Have you reported the task back? Say, sir, his chest X-ray shows a small shadow, so I took the X-ray to the X-ray department, and they're worried about TB, that type of thing. So you're reporting back, and whether you have followed that up. Now, these are qualities of good interns, and consultants will really be appreciative of that. And that, again, is a lot of learning tools from every patient. Then fourthly, your enthusiasm to learn. Sometimes the consultants and the senior registrars tell you certain things you don't understand because it's too complex or too complicated. Always ask. Internship is time you can ask any dumb question. They will not scold you because you're still in the learning tool. You're still not a complete doctor because you get the registration from Sri Lanka Medical Council. Once you get cert, you get a good standing, and that's the time you become a fully fledged doctor. So you're still allowed to ask dumb questions. I'm saying in jovial terms, dumb. Any question which comes to your mind, you should never think that, shouldn't I ask that question? You might think that I don't know my theory, that type of thing. No, you don't have to worry about it. You just have to make those things sorted out, because once you become a fully fledged doctor, you can't ask questions from other people like that. And fifthly, your honesty. All of us do mistakes. All the consultants do mistakes. Everyone in life does mistakes, but you should be honest to accept responsibility. So, accepting the responsibility of mistakes is not a big issue. It's important that you understand that is the honesty of a personality. And the consultants will really appreciate. So you say, sir, sorry, I forgot. I wanted to get ECG done, but unfortunately, because of this, I couldn't. I'm sorry, it won't happen again. That type of thing. That's perfectly okay. And then your kindness. Now, your kindness is something which people will appreciate or will observe without you realizing that they are observing. And that's a very, very important attribute of a good doctor. All over the world, good doctors are kind, compassionate, empathic doctors. So that will be displays of your behavior right through. And it's important that you learn this, if you don't have that much, from certain colleagues of yours who you will very clearly displaying the empathic personality. I've had superb interns, including the one who just introduced me, and they are very well known in the society for those important attributes as good doctors because of their kindness, compassion, and empathic approach to patient care and care in life altogether, and the way you communicate. Now, the communication is extremely important for doctoring, and it's a subject beyond the scope of this speech, so it will take time. So your consultants has had many interns before you, so you will pick up. They will pick up who you are very soon, much faster than you think. So you have to make your consultant your best teacher and your best mentor. Unfortunately, because of your behavior, you can make him your policeman too, and that's not a very good start. Depending on the hospital, there are many other doctors you might be meeting, the registrars, senior registrars, in university you need professors, senior lecturers, all these, and they're very valuable learning tools for you. And you meet other consultants, nephrologists, neurologists, cardiologists, they all come to the wards. But one of the most important group of people for surgery is anesthetists. Anesthetists are extremely important, very valuable learning tools. They are the best people for you to learn critical care and applied physiology during your internship. The best person is a consultant anesthetist and a junior anesthetist, and you learn a lot from them. But treat them nicely. They can make your life miserable as well if you don't do your job. And you meet them in the ICU settings, in the theaters, when they come to the ward for pre-operative assessments. Treat them very nicely and kindly. In return, you get lots out of them. And better not to give any bad impressions to the anesthetist, because that bad impression will be immediately transmitted to your consultant. And that's not very good for you, for your certificate of good standing. Of course, different people have different personalities, so you have to get the best out of even the people who are considered difficult. It is an art. So I told you this technique, 7 qualities I mentioned. Then you have nurses. Why do I keep the nurses separate? Because they are the most important in a ward. led by the ward sister and the matron. They are a closed shop. They're extremely valuable teaching tools and learning tools. Remember, you are going to be with the nurses 15 hours a day, not with your consultant or the junior doctors. So you can learn a lot out of them. But they have seen enough interns before you, and they're going to see enough interns after you in the same unit. Generally, when I speak to the nurses, and you have to treat them like professionals at your same level, and they will treat you that way in return, and you learn a lot from, and to adapt yourself into the system much easier. In their mind, sometimes nurses say, we used to classify the junior doctors or the interns as good, bad, and ugly. It's extremely rare to have ugly in the sense, not in appearance, but the behavior I'm referring to, because you work with them about 15 hours a day. Extremely useful. You can learn a lot. Remember, your consultant has worked with them much longer than you. So if you're bad, that information will be immediately transmitted to your consultant. I can recollect a situation years ago in our hospital when nurses lit firecrackers when that intern left the unit. So it can be as bad as that, but it's extremely rare. Don't worry about it, because they are very nice people. You learn a lot from them. But finally, remember, irrespective of whether you work in the ministry hospital or in a university unit, within the boundaries of that hospital, your director or the medical superintendent is the chief. It's not your consultant. It's your medical superintendent or the director. Everything comes under him. All of us go under him. So it's very important that you have to understand that medical director is controlling the entire system, and be good with them. And in return, you will get a lot out of them as well, because you need them for most of it. Finally, very quickly, I think I've just overrunning the time. I just want to tell you a few very personal points. The way you dress to the ward, not only during the working hours, but at night as well, creates the impression about you, especially about the doctors, to the patient. You should not go to the ward in slippers, t-shirts, ear studs, untied hair. I know some people, I've seen it, but it's not very good, because that creates bad impression on the patients. And even among your consultants, they will not tell you, but I'm telling you now, it creates a bad impression. Equally important, how you speak to the others, your body language, that's extremely important. Hospital is a place where professionals work. Their patients have a lot of respect to us. It is our responsibility to maintain that respect. Other point I have to tell you is, when you speak to your colleague in the ward, you remember everything you speak, the patients can hear. So you have to be careful when you talk in the ward, because it's a small space and everyone hears. And they discuss among themselves. I heard that doctor telling something else to the other doctor, and it may not be very helpful to you, to your consultant, to the unit, or to the doctors in general in this country. Professional communication is an important attribute and a very important call to learn and practice during the internship. And this is in a nutshell what I want to tell you. Remember, you have a long way to go to reach your life ambitions. And when you learn a professional setting, it will really help to achieve your dreams of your career. Equally, bad internship and developing bad habits will be a major obstacle to your progress. And it is a well-known fact that what we learn early in our lives tends to stay with us. If you learn bad attributes, it's going to stay with you. I worked with interns for about 40 years in this country and abroad. And just one thing before I finish, on reflecting my experience, I've had many good interns, excellent ones, not so good ones, but it's very, very rare to have bad interns, because they can be corrected. That's what I feel. And years after, when the patients come to see us, sometimes in the private sector, they used to ask, sir, how is that young doctor mentioning the name? And sometimes we have forgotten, but the patients remember, because the way you have treated them years ago. And when I recollect my thoughts, almost everyone who they mention has really reached their life ambition. They've become excellent doctors, and most of them are consultants and professors today. So patients are the best judges of us, best judges of our intern. Thinking back, it is the most important period in our life, which was my life. You learn the real art and craft of surgery. And if you do a good internship, all of you might be interested in doing surgery as a postgraduate career. And we have had many such interns who are doing excellent work as surgeons, not only as surgeons, but very empathic, compassionate, professional surgeons in this country. I wish all of you the very best for your future. Thank you.
Thank you very much, sir. That was Professor Mohan De Silva sharing the experience and the wisdom with us. So we have a bit short of time. So thank you once again, sir. So next up is another important lecture by Professor Alok Patrana on the theme of routine work for surgical interns. Over to you, sir.
Thank you. I hope you can hear me.
Yes, I can hear.
And I can share the screen, isn't it?
Can share, sir.
Okay. So good morning, everybody. I'm really happy that I'm able to speak to you all today. And I think this is the second time that the College of Surgeons is organizing this program of this nature. And I was also listening to Prof. Mohan's talk before this. And it took me also back to my internship days. And I almost felt like changing my topic today and talking about my experiences as well. But unfortunately, the time is limited. So I will confine my talk to the topic that is given to me, and which is what we expect of an intern during the surgical internship period. So as Prof explained, internship is a very important event in your life or a period in your life. And that's a period that which you can really gain a lot of experience and more than that, enjoy. So if I take my internship period, it was a tough internship. So we had only 2 interns. Our unit had casualties on Sundays, which meant that both of us had to be on call every other Sunday. So we had only 1 day free for ourselves, that is 1 Sunday a month, on which we were free. But still, we enjoyed work, and that experience is probably what led me to becoming a surgeon or selecting surgery as my specialty. So as Prof explained, the objective of the internship is many, and probably you could divide it into the legal objectives and personal objectives. So legally, you're expected to complete the internship satisfactorily in order to become registered as a medical practitioner in the Sri Lanka Medical Council. So this is a mandatory requirement. So unless you complete this 1 year of internship, of which 6 months would be in a surgical subspecialty or obstetrics and gynecology, and the other would be a medicine or pediatrics. So therefore, this mandatory period is essential, and you have to complete it satisfactorily. But I have not seen many interns, or I have only seen probably or heard of only a few interns who are not able to complete the internship satisfactorily. And even then, most of them were due to medical reasons rather than not being good enough to be a medical practitioner in Sri Lanka. So that's a legal requirement. But personally, there are so many pluses that we get during the internship. And Prof quite clearly explained most of these under different categories. So we develop confidence in managing patients, because until your final year exam, you're mainly worried about theory, getting through the exam. But the real management of the patients you learn only during your internship. And you learn to be, or you learn to deal with individuals of different categories, different professions, different educational backgrounds, because until your internship, you are in a comfortable environment with your colleagues and your teachers in school and in the university, and you have a limited interaction with the patients during your clinical training, but the proper interactions occur or start to occur during your internship for most of you. And this is also a stepping stone to develop an interest for specialization. And Prof explained, and even I told you that my love for surgery started during my internship. And most important thing is to enjoy this period and not to be too stressed about it. So if you enjoy, if you're happy, you're invariably going to gain as well, because a happy person learns or experiences more than an unhappy, complaining person doing the same job. So it is not the job that is important, it is the way you take it or way you respond to it that results in your ultimate happiness or contentment of anything in life. So it's a first job for most of you all, and it is stressful, no doubt, because we don't know what we are up against or what we are going to deal with during the internship. Expectations are unknown, but we don't know who our boss is going to be, and we have heard so many stories about different bosses, and Prof explained to you some may be not so friendly, but some may be friendly. So expectations of bosses also vary. Therefore, you don't know what you're expected to do or expected to be. Then interpersonal interactions, I told you, is a new entity for most of us. And not for you all maybe, but some interns had the long gap after the clinical exposure before they commence an internship. So the knowledge about the clinical knowledge also would wane during this period. So that is also a worry when you start internship. But that is the least of your should be the least of your concerns, because you will realize that what you learned in theory or what you learned for the exam is totally different from what you would be experiencing and what would be necessary. And remember, if you have learned something well, and if you have, especially if you have passed the exam, then it takes only a matter of a short time for you to recall the knowledge that is necessary. And also with current day availability of smartphones, internet, you are easily able to get the necessary knowledge in a fraction of the time. So it's big deal, I would say, because what is important is for you to know how to gain knowledge and not how to retain knowledge. So retaining knowledge is an automatic thing, but you will be able to, or you will need to access knowledge through the internet or the textbooks, mostly the internet, during your internship, if and when it is needed. So in the principles, it leads to registration, which is vital for clinical practice. And then it's the best opportunity for experience. So when you're selecting your internship appointment, select a unit with a good workload, because this is the place that you're going to learn. So without a good workload, the amount of experience that you will gain would be less. And give your best. As I told you, enjoy. And surgery, as Prof also mentioned, is an interesting field. And because probably I thought, why is it interesting? Because we get results fairly fast. So when you treat a patient surgically, you see that their improvement, their happiness, their satisfaction, which gives joy to us in a very relatively short period of time, unlike in most other specialties, maybe obstetrics and gynecology is the same. So there's a very good job satisfaction. So enjoy your internship in surgery if you are able to do it or if you want to do it. So there are some principles which will help you to gain most during your internship or for that matter in life. So I refer to these as the 3 H's. So you have to be humane, or you should have humane qualities. So what are humane qualities? What do I mean? That is being empathic, being kind to people, and always helping others. So these humane qualities are extremely important to be happy in life. Honesty, again, extremely important during internship, because during internship, your boss or your seniors are dependent on your honesty. If you convey wrong information, then definitely you're going to be looked down upon, and they will not trust you for any activity. Then the third H is to be hardworking. So that's a very, very important H. So without hard work, if you are lazy, you're unlikely to gain much from anything in life. So these three H's, being humane, being honest, and hardworking, are I would call them the hallmarks of a good individual who will definitely be successful in life. When I say success, I mean contentment and happiness more than anything else. So you can update your knowledge during the internship or whatever with your smartphone. So treat all your patients believing or imagining as they are your loved ones, that they're your mother or father or brother or sister. Then you're unlikely to do any harm to any one of your patients. Before you say something, before you do something, you have to think, okay, would I do the same thing if this patient was one of my loved ones? So if you don't, then which means you're not doing the correct thing. During internship, acquire all the skills that are needed and that are available to you. So in my talk today, I'm going to talk about three main aspects: the routine of an intern, that is patient clerking, ward rounds, and the clinics. So clerking patients, is it only for documentation purposes? Well, not only, but yes, definitely it's for documentation, because when you clerk, you document something, you write something, and that is taken as a legally valid statement or document. And also that is the information that you document at that particular time. So if it is documented properly, we believe that that was the state of this patient at the time that you saw this patient. Are you expected to diagnose medical conditions? Well, yes and no. And if you can diagnose, yes, very good. So you must make all the effort to diagnose your patients. So take a proper history, examine them properly, order the necessary investigations, because you get a personal satisfaction. As Prof. Mohan mentioned on his first day of internship, he saw this young man who was having a hemoperitoneum. Now, he was a very raw intern, day one. And I can't imagine the joy he had when he found out that his diagnosis was correct and that he was able to save this patient. Because I think it was the delayed rupture of the spleen, if I'm not mistaken. So that gives you a huge satisfaction. As you can see, after so many years, he still remembers that incident. So that is going to be the same for you as well. Are you expected to manage emergencies? Yes and no. Why? Because if you are the first person to see a patient and if you are the only person at that time, yes, you need to manage them efficiently until support arrives. Are you responsible for the outcome of the patient? Well, morally, yes, but legally, maybe not. Legally, it's your consultant who is ultimately responsible. But when you make a mistake or when you think that you're responsible for the outcome or a poor outcome of a patient, you're definitely going to suffer from it. So that is natural. That is a human nature for all of us. So always remember that you will strive not to make a mistake so that the patient's outcome is going to be poor because of an act that you have done. Are you held accountable for the morbidity or mortality? No, it is your consultant or the boss who is going to be responsible for that. But that doesn't mean that you are totally out of the picture, because you are also part of the team that has taken care of this patient. So clerking is important because, as I mentioned earlier, it is the time that you're documenting. How should you be responsible? Most important thing is legible writing. If you have documented something which nobody can decipher and even the person who has written it can't read, it is useless as a document. You have to write the date and time because, as I told you, it is the state of that patient at that particular moment. So it is extremely important that you write down the date and the time of your documentation and hold yourself responsible by signing at least a short signature with the legible name. So easiest thing that I practice is I write my name, time, and the date on the left-hand side of the bedhead ticket, that page, and start writing my notes and sign it at the end. So even if I know, when I look at the note, that okay, this is what I have seen at the time or that particular day of this patient. So it's very important to be responsible. So legible writing, date and time, and the signature. Accuracy of the information, there's nothing, I don't need to explain that, it's obvious. And if you clerk properly, you will know about the patient during your ward round. So that is another important thing, because you are better prepared for a ward round if you have clerked the patient properly. So ward rounds are of three types. You get business rounds, the decision-making rounds, which are the most important rounds for you. Grand rounds and stuff are mostly seen in teaching hospitals, these teaching rounds as well. So what are business ward rounds? A business means there is no anamana. I mean, you have to be to the point and only do things or talk about things that are really necessary. So if you are the house officer going with your consultant in a business round, you have to only mention the things that are necessary for the management of that patient at that particular time. So if it is a patient with a casualty admission with no diagnosis, you might need to give the history and the examination findings. And if a casualty admission with a diagnosis comes, then it's a management plan. Elective admission for surgery, you have to tell the consultant, okay, this patient has come for this particular operation or particular investigation for this reason. Post-op patients, of course, the post-op management with the surgery that was done. So information needed for a business round will vary depending upon the patient. So casualty admission with no diagnosis would be a summary of history, preliminary tests done, etc. I'm not going to go into detail. Patient with the diagnosis will need to be told about the anticipated problems and the plan. Post-op patients, what the surgery was, current status and complications. So what are the expectations or the job? What is the job of an intern in the clinic? Well, it depends on the availability of the other categories of staff in your unit, whether you are a surgical trainee, senior house officers. So depending on the seniority, the jobs or the work expected would vary in the clinic. Obviously, you are going to be the most junior person. So most of the time, the interns are delegated with seeing patients coming for the second visits or the subsequent visits. So that would, the most important thing is to see whether they have a problem and see whether they need to be seen by a senior person, or whether you think that the patient need not continue to come to the clinic, but you are not authorized to discontinue a patient. So if such a decision is necessary, it has to be done by a senior person. So what you need to do is to identify issues and to get the opinion accordingly. First visits are usually seen by the senior staff. So there, of course, you need to do the diagnosis, planning surgery, investigations, etc. And the other jobs of a clinic, so intern in a clinic would be giving their dates. So that again, you have to know how to prioritize patients for investigations and surgery. Okay, so that brings us to the end of my talk. If there are any questions, I'm happy to answer. There are 430 odd. So if there's nothing in the chat box. So due to lack of time, I will probably end my talk here. So in summary, I spoke to you all about the objectives of the internship and the 3 H's, which are very, very important: humane, honest, and hardworking. And I told you all the principles on how to achieve these objectives with specifics on clerking, ward rounds, and the clinics. In clerking, remember especially to be responsible to write legibly with your name, signature, date, and time. Okay, thank you.
Thank you very much, sir. That was Professor Lokapatirana giving a very important lecture on routine work for surgical interns. So thank you once again, sir. So next up is another very important lecture by Dr. Mahanama Gunasekara, Senior Surgeon, College of Surgeons, Sri Lanka, on the topic of administration of a surgical ward and a theatre. Over to you, sir. Manav, sir, can you hear?
Yes, I think I'm all right. I'm trying to get on with my slides. Yes,
See that we can, right.
you can see, but
Yeah, full screen, sir.
not the slide. Wait. What am I going to do? All right. Hope you all can share see the shared screen.
Yes, I can see. Yeah.
Okay, no problem. Shall I start straight away?
Yes, I can start this.
Right. I think first gather your thoughts. Having listened to Professor Alokapatrana's lecture, there is nothing much to add. I know that he has told you many things, but this is a little bit of a light lecture where you understand your environment and how to survive in this internship period. So rather than going into a lot of technical details of how to see a patient, how to write and various things, how I want you to see the overall picture of our intern as an administrator. Because when you become a doctor, whether intern or a medical officer or then later a consultant, there are other aspects other than the clinical management of patients, where you speak to the patient, diagnose, investigate, and treat, and they get better, and they thank you and go. However, there are other things that a doctor is involved in. One of them is to organize yourself and your surroundings and instruct others how to work. So, internship is the first time that you are going to do your administration, I suppose, unless you have done a lot of social work in your medical school and before that in schools. There is little chance for you to do administrative work. So this is the first time that you are going to do official administration. So firstly, that you must understand what are the things that you have to do as administrators in time to come. So therefore, remember, when it comes to administration, how to get rid of this. Yeah, when it comes to administration, firstly, you must understand during the internship, the entire focus is on you. So therefore, try not to lose marks because of others' insufficiencies, inadequacies, weaknesses, and various other obstacles to show your colors. So therefore, remember that you are the one in focus. Try to be the smartest person and try to work with all bad people in a difficult environment where the situation is not perfect, but you try to be perfect. You are the only perfect person. So therefore, don't try to blame others. Try to correct the system in a little possible manner that you can do that. That should be the attitude. And you may not be able to correct it immediately because you don't know the environment. So therefore, first learn the environment. Observe, be nice to everybody, but be very vigilant. Observe the entire system. What do you mean by system? That's a healthcare system that you are involved in. You are an intern house officer, where there's a small unit, where there is a consultant. Then, of course, you will have senior medical officers, various grades, maybe senior registrars, who's like another consultant, maybe or junior consultant, similar to a junior consultant. And then, of course, your registrars who are very keen to learn, they're knowledgeable, but may be less experienced. They may be like you, but in a different spiral. Then, of course, then you will see the senior house officers. They are very experienced in your all the events in your unit, but may not be very knowledgeable like you. You are fresh with your knowledge. Their knowledge may be little oldish, but they know how to work. They understand patients' problems, what happens in the ward, what particular behaviors of consultants and other doctors and the staff and the nurses. So therefore, you understand them. Of course, the most important group of people that you must understand and work with is the nursing staff, particularly the sister in the ward, as well as the nurses, and then of course auxiliary staff, which is there to help you out. So the sister, you have to remember, sister is in charge of the ward, not necessarily the consultant. Sister is in charge of the ward. She's like the mother in the house. And she takes care of all the equipment, furniture, allocation of various resources to patients, and looking after patients' personal problems, and their well-being is being entrusted with the system. So therefore, they have a lot of responsibilities. However, in Sri Lanka, you may have heard that there are a lot of hierarchy issues. Don't have this hierarchy issue with the nursing staff, particularly when you start your work. Be friendly and make yourself friends with them. That would be very advisable for you to show your qualities, because you are being assessed. I always tell you, the focus is on you and you are being assessed. So therefore, don't allow the system to ruin your ability to show yourself. So that is what I understood. I wanted to understand by learning the environment, the system, and the people. So remember that this, particularly the nursing staff system, there had been there for many years. The consultant had been working with them for a long time. If they have any shortcomings, inadequacies, inefficiencies, or something to improve in them, the consultant knows better than you, because he or she had been working with them for a long time. So when you go there, don't try to find fault with them, because probably everyone knows each other before you. So therefore, try to be smart and work with everybody. That should be your concern. That is one of the most important administrative skills that you learn, how to work with people. Then, of course, again, you should be able to communicate with everybody well, because the communication is so many misunderstandings, shortcomings, and of course, deficiencies which might lead to problems in the patient care. So therefore, first you know your intern colleagues, speak to all of them. You may be working in two wards, maybe male ward and the female ward, or one based in the theatre, but all of you should communicate well with each other. So the simple way of communication is the telephone. So when you start your work, immediately get their telephone numbers, get to know their names, and know your senior house officers, registrars, senior registrars, consultants. Everybody's names and telephone numbers should be known. Staff also, better to know their names and identify them as your ward staff or theatre staff. Then that makes life easier. And of course, you have to communicate with other departments, especially the Department of Radiology, Department of Pathology, Microbiology, and of course the labs in general, and outpatient department. So then, therefore, to try to have a kind of a healthy communication with them. I personally have noticed how you call each other. I think in front of the patient, be professional and address each other in a professional manner. Because why we address each other in a friendly manner, maybe your brother or sister or whatever it is, you call various names I have heard, that may be your personal convenience, and then that's the way you like it. But the important thing to understand in an office environment is you are a service provider. I am a service provider. I am a servant of my patients. So my intention is to please my customer, please my patient. please their relatives, not necessarily to please each other all the time. So therefore, when you address each other, that should be pleasant to our patients. So as a patient, I prefer if you doctors call each other as doctors. So I personally prefer, and I don't know, the modern cultures may change with time. I may look good when I say that, but as a patient, I prefer if you call each other in a professional manner. So that's one thing I have noticed. And always see what the patients want you to, how the patients want you to behave, rather than what you personally like. Then you have to communicate with your staff. So speak to the sister. Always learn to say good morning to sister when you come in the morning. That helps make the life much easier, not only for an intern house officer, even for a consultant. I have worked many years, and just about to retire soon, I have realized that, saying good morning to sister in the morning make life much easier than you think, because that way you come to know many things and very easy to handle whatever comes in your way in management of hospital wards. And similarly, with nurses, try to have a good communication system, understand their problems, what is called empathy. And when you ask for help or ask them to follow your ward rounds or whatever it is, please try to understand their issues also. They must be having a lot of work, they may be tired, they have other issues. So try to share the work with each and every person. When you're working place, particularly surgical units, but I'm sure the other units as well, we try to get together and try and sort out problems rather than try to fight with each other. The other places are that when you go, always go to other departments and speak to consultants like consultant radiologists, consultant pathologists, microbiologists, at least once. When you start your work, maybe may not have time in the first week, but maybe at the second week, third week, you can speak to them and get an opportunity to speak to them. See the slides of the pathology department and take an X-ray and go and speak to the radiologist and so on, like that. Get to know them. And another place that you often fight with is the OPD, particularly in the regional hospitals, where hospital is a small unit. Outpatient department, you might suddenly get patients which are inappropriate in your opinion to come to your ward. Maybe a medical patient has come to surgical unit, obstetric patient has come to surgical unit, or surgical patient has come to medical unit, and so on. So don't try to fight with them. Try and address a problem in a professional manner, official manner. And if you are unable to sort it out, always speak to a senior house officer or consultant and ask them to sort it out rather than you getting involved in the outpatient department doctors. Then organizing your work. I'm sure Dr. Aloka Patirana in detail described how to do that. But this is only an overview of the problem that I want you to understand when you're organizing. In the ward, there are a few things. That is emergency work and the routine. So therefore, two are different. So when you come to the ward, always have a habit. Whenever you come in the morning, go for a cup of tea and come again, go for lunch and come again, maybe come for the night rounds, whenever you come. First, remember, there are emergency situations. Always look into the urgent problems, emergency. One of the emergencies is pain. Just find out who are in pain and sort it out. That will help you in many ways in the long run when it is a habit and you just go through your ward once and it takes only about maybe 1 minute for you to quickly go through or say 5 minutes and just see whether everything is all right. Maybe in the morning, you need more time. Maybe after a cup of tea, you need only 30 seconds. Maybe after lunch, you need 1 minute to go through and find out who needs urgent care. Even when you're clerking 10 patients, 10 new patients have come, have a priority, but always give priority to people who need emergency care, pain relief, or somebody who is more ill should be given priority. And that is different. Routine patient, of course, you have to cover them. Routine patients are less ill patients who may have come, particularly in the surgical unit, who have come for a scheduled surgery, and they are less ill, but you will have to do your work for that day, because you have to prepare them for other procedures, maybe coming for investigations, maybe coming for surgery, and therefore you'll have to look into that, but always after. Similarly, plan for your future. That means just think about what are the things which comes in the afternoon, what are the things that are coming in the next day, and maybe for the week, what are the things that are coming in. So you must have an idea about the plan for the week, plan for the month, particularly plan for the week. And then, of course, before you go home, you arrange things for tomorrow, or next day, or next session. That will help you to not to miss various duties of yours. So with time, you will become a real professional with that when it comes to planning your work. Dress code, I mean, we used to ask doctors to wear like what I'm wearing now, with a shirt and a tie. But over the years, particularly after the COVID times, you know, the dress code of doctors have changed. But whatever you wear, it has to be clean, nice, and smart. And you are young doctors, and they inspire patients. And you must always be smiling, nicely dressed, whatever you wear. So I don't mind you wearing a doctor's overall, doctor's the uniform dress, but it has to be smart, clean, and nice. And particularly when you're going for very specific meetings, going to meet director, or going for a specific event, try to dress smartly in an official manner. May not be necessarily the ward dress, which may not be appropriate for all the places. So remember that your dress is an important thing. I'm not going to stress it a lot, but always remember your dress, tells a lot of things about you. So therefore, when you come to the ward, you must look like a doctor all the time, whether it is emergency, daytime, or night. I don't have to say about punctuality. Whenever you come to any event, anything, the punctuality is very important. So therefore, adhere to the hospital regulations. There are working times. So always try to be in your workplace during hospital working official times. But when I say time management, depending on your experience, you may have to have more time than others at the beginning. So therefore, I advise you as intern officers, at least when you are starting, you come in time, organize your work, maybe come half an hour, 1 hour before, and organize your work and get familiarized with your situation, with your problems that you have to face during that day. So that will help you to overcome a lot of problems and be smarter than others. Always then you find out what pathology reports, what investigations has come earlier than other people, which will make you smarter and an efficient person than others. So therefore, depending on your experience, in the new situation, decide when to go to the work. So once you are really experienced, you know everything, and you have organized everything, you know that you have done what is to be done in the previous day, probably you don't have to come very, very early, but initially decide how much time you need to organize your work. Similarly, when you get, always don't forget to thank people. That takes you a long way, and learn to thank your minor staff, especially they want appreciation. All the people like appreciation. So therefore, always remember to thank your minor staff, nurses, when you go to other departments, meet other unit doctors, and you share your work with other people. So help others. You won't get a chance to help another person all the time. You getting a chance to help another person is a blessing, actually. I always consider it as a blessing. And try to find chances to help others. That will always give opportunity for you later. And also, they also will be will be ready to help you whenever you need it, even without asking. So therefore, that way, you share your work with everybody and try to be a nice man, nice from the Taiwan. Dr. Alakpatirana in detail described how to do the ward rounds, clerking, and investigations, and running clinics. Here, what I am going to tell you is a slightly different one than what he said. What he said was your accurate documentation. But what I am trying to do is, when you're doing ward rounds, he told you what to do, but you must organize yourself. You carry a small notebook. You carry a pen. Don't write on your palms. So know the patient's name, particularly those patients who are going to be in the hospital for a few days, know their names. And decide what you need for the ward round to carry with you before you start. And sorry. And similarly, when you're clerking, organize your things and clerk emergency patients first. And then, of course, arrange your routine work. There are patients who are coming for various investigations, and make sure that they go in time. Make sure that all their required documents are ready. And similarly, write your diagnosis card, collection times all the time, and keep them ready. May not be able to complete the entire diagnosis card all the time, but make sure that you write your diagnosis cards when you are free. And similarly, arrange investigations. Write in your notebook what are the things to be done for that day. That helps you a lot, and then you won't forget. After sometimes you can do without, a lot of documentation, but initially make sure that you write down what you have to do. And similarly, night on call, when you're coming, you decide who are the patients during daytime who had problems, and see them, see the ill patients first, see the post-operative patients first, and then of course make sure that you speak to everybody before you go home. That will before you go to rest, because that helps you a lot. And in the theater, know your patients. So there will be a certain number of patients coming to the theater, so to know your patients and make sure that their investigation reports are ready, and bring all the X-rays and other images, and of course all investigation reports. Make sure that they have come with the patient, because otherwise, once the surgery starts, you will be looking for X-rays, and you may find that the X-rays are with the patient, or X-rays are at home. So therefore, make sure that they are ready. Always try to display the images when there is an image display, X-ray illuminator in the theater. Almost always it's there. And select even the chest X-ray in a thyroid patient, neck X-ray, CT scans, and all that. Make it ready and available, and display some of the images even before the consultant comes. Put the images in the X-ray. That makes you smarter than others. And follow the checklist. Make sure that all the things in the checklist are ready. And now you have what is called the WHO checklist that we read just before surgery. But you must go through the checklist. Maybe your own checklist, pass the WHO checklist before others go through it. And that way you know what are the deficiencies that has to be corrected before it comes to light. And know about the procedure. There may be many procedures that you have not seen before. So try to follow it and learn what they are doing. And when you are writing post-operative notes, make sure that you write it accurately. Whenever you are not sure, you always discuss it, particularly when you are writing a particular operation for the first time. Consult your seniors and write appropriately. After few operations which are done routinely, you will know what to write. Similarly, try and present in the meetings, particularly MDT meetings and mortality morbidity meetings. That gives you a lot of opportunity to learn how to present and get rid of your, if you have any fears for the stage. Very quickly it will go off. I can see my house officers, how they improve from day one, first day when you're presenting in the MDT meeting, and when they are finishing, they have become expert presenters. So therefore, always try look for opportunities for you to present in MDTs and MDTs. Then, of course, you can improve on your presentation skills by participating in various academic events. And of course, try and get involved in research work whenever possible, in particularly in hospitals where you have a lot of academic environment. You always get involved in the research, but even otherwise, even very small hospitals, you can get involved research even in a small way. For house officers, researchers are very useful in the future for other house officers to work on. And always be smart. Try to give your new ideas to improve the situation and give it gently. And once you are successful in introducing new ideas, the ward staff, even the consultant, nursing staff, system would like your ideas. So you present it in a nice way and you observe the system before changing. Then after that, you try to suggest small corrections in the system, and gradually you can be a real contributor to change the system to a better way. So be positive all the time, and people are ready to see you young people suggesting new things and coming out with new ideas to improve the system. So that's a good quality of an administrator, where they see defects. And most importantly, they know how to correct it. So therefore, always when you see a problem, when you see an inefficiency, when you see inadequacy, first think of a solution, then point out the inadequacy. So your solution is the most important thing rather than pointing out the problem. Thank you very much. If you have any questions, you can ask.
I think there are no questions, sir. If you all have any question, please type on chat box. Sir will like to answer them. So without a delay, we will go to the next lecture. Thank you very much, sir. That was Dr. Mahanama Gunasekara, Senior Consultant Surgeon at National Hospital, Colombo. Thank you, sir, once again for that very, very vital lecture. So next up is another good lecture by Dr. Dayane Kanayaka, Consultant Plastic Surgeon at National Hospital, Colombo, on the topic of wound care and burns. Over to you, sir.
It's not on burns, but I'm just doing this lecture for Professor Anil Fernando, who is actually retiring after an illustrious career, and he's one of the giants in surgery in our country, and is one of the key figures in this topic. But I'm going to share some of my thoughts and also his slideshow, which explains why we need to investigate patients, especially surgical patients, and the principles behind very basic principles behind investigating patients. So we will start by I just need to go through these fundamentals of history taking, because without fundamentals, you might not see why we investigate these cases. So how to investigate is based on your actual diagnosis. So we will see what happens in a patient. Now, when a patient like this walks in and sits in front of you, you need to make the idea is to make a complete diagnosis, sir, and investigate. Yeah.
The screen is not sharing, sir.
Oh, sorry. Can you see it now?
Not yet, sir.
It says you are sharing. About under what I have. Can you see now?
No, no, sir, no.
I'll share again.
Yeah. It says started sharing screen, doesn't come though.
It says post resume share. Can you see it now?
Not yet, sir.
It says you are sharing screen, but you can't see it. See?
No, sir, can't see.
I will stop the share. Andana passe ganna mal lecture එක. Now can you see my
Yes,
screen?
like Tamara started connection problem and then started screen sharing, but we don't see it yet.
We'll wait for a little while. Probably the data is very slow.
Slow, I think.
Not yet?
Not yet, sir. So quality color in the regular they can share, they can put the slides, you can continue, I think. It's easy.
Yeah, I'll ask them to share it. But it should work because then I'll just share the other slideshow and see whether it's working, because might be the file type. Can you see this one?
Same, sir. Sir, can I share a screen share?
Yeah.
Yeah.
Okay.
Does it become blue, no? When you have to click on it, and that becomes blue, and then you start share, sir.
That's how I done it.
Okay. Probably the connection, I think.
How about now?
Still the same, sir.
I will just
Yeah.
so I will send it anyway. I will talk through because slide. I need to show some photos. I'll just try while I'm trying. I'll just try to get the slideshow up.
Sir, I'm Chatusha here, sir, from the college. If you can send me the presentation, I'll share it, sir.
So you will have Prof. Ranil Fernando's PowerPoint presentation.
Yeah, we'll share that then. Okay, sir.
I will send another one also. I need to share that one also.
Yeah.
Yeah. Just share it because I'm just going to talk on his presentation. You can't see this, no? Still.
No, sir.
strange because I used to.
Can you stop the video and start? I'll share it. Sometimes then the data might be enough. Sometimes.
Video.
Then please start again, sir.
Yeah, I'll stop share and I'll share it again.
Okay.
Maybe the bandwidth is not enough.
Yeah.
Can you see it now?
Same, sir. Can't see.
Right. Anyway, Chatu, can you share the share Prof? Yeah. Can you see it now?
Yes, I can see. Yeah.
Okay. Probably due to the bandwidth. Can we move on? This is because yeah. So basically, we are when we get a patient in front of us, so we need to make a proper diagnosis first. So it's a history taking, examination. After that, you will always have a idea what is this patient presenting with. It means you have a tentative diagnosis. We call it the provisional diagnosis. So how do you plan out your investigations of this patient? Now, to do that, we must establish the sort of a narrow down the diagnosis. What we do first is to identify the anatomy of the patient. So anatomy of the diagnosis. That means when you write on the diagnosis card, you need to have the component of what is the anatomy. Then you have to have what is the chronology. That means whether it's acute, subacute, or a chronic problem. Next important thing is to have the etiology, whether it's there are several etiologies that you can deal with. You have to deal with sometimes it's infective, basically inflammation, infection, and congenital, and then you have trauma, malignancy, degenerative. There are disease categories, etiology. Those are actually macro etiology. That means when you take a road traffic accident is a etiology, but actually what happens is the exact etiology. It's whether it's a patient has graze abrasion, that means grazing, or the patient has actually impacted some anatomical point, maybe the wrist, maybe the thigh, maybe the knee joint, whether the impact. So it's an impact or a traction injury. So those are actually what has happened to that anatomical part. So etiology is important. Then you have the pathology. Sometimes you have whether there has been malignancy or these things, or atrophy, hypertrophy. So those are pathological processes that you will recognize. So etiology that leads to the pathology needs to be identified. Then you have to see whether there are complications. So with all these 5 components, you have a complete diagnosis. This is what we have been practicing all along. But that 5 component diagnosis is the key to your next step, which is investigating patients. Supposing a patient comes to you with a right abdominal pain, then you have a tentative diagnosis of acute abdomen or acute appendicitis. Then you have to direct your investigations towards that. So now if a patient comes with a twisted limb, you need to have a diagnostic investigation. So first line will be diagnostic. You will not be doing the hi-fi MRIs and angiograms as soon as the patient comes, unless it's the diagnostic investigation. So diagnostic investigation is the first one. So maybe the ultrasound scan is the first line of diagnosis investigation this problem. Then you have to actually first one is the diagnostic investigation. Second one is the staging investigation, which includes all the other baseline. Now, once you have got the diagnosis, narrowed down diagnosis, then you have to assess the disease and assess the patient. So that is where you have to assess the patient. If the patient is a surgical patient, suitability for surgery. So that some of these preoperative assessment. So now it comes to surgical. Now the patient needs to undergo surgical procedure and anesthesia needs to be administered. So there is something we call the patient, whether the patient can withstand this surgery. So the total, we need to consider several things: the total operative time, intraoperative blood loss, magnitude of injury or the surgery that we are going to do, and the effect of anesthesia on the patient, and also the post-operative degree of post-operative pain. So now we assess the patient, whether the patient is a suitable candidate for this particular procedure. Now we talk about metabolic and hemodynamic effects, and also the stress response. How is the patient going to? Then the person who initiates this process is the intern. Next slide, Chatu. Can we go to the next slide? Can we go to the next slide? Right. So now there are obligatory requirements. Now when we assess the patient, we have to assess the patient's suitability for surgery. So and also the disease process. I mean the staging of the disease. How bad is the disease? So that is also assessed during the investigation. So that we call staging investigations. Or then particularly in a breast cancer patient, we might do abdominal scans, chest x-rays, and sometimes we might, if the patient has headaches or something, might even need to do a CT scan of the head to see whether they are secondary. So that's called staging. Even in an infective procedure, that means if you have infection, you want to stage the patient, you might need to get some investigations like CRP levels and WBC-DC, and also that indicates the severity of the pathology. Now these are important. These are important patient and disease assessment investigations. Next one is the etiological investigation. When sometimes you have to find out what is the etiological reason behind this presentation. That means it could be a culture swab for microbiology. It could be a true cut for a breast cancer. So these are investigations that directs at the etiopathology. So you will get an idea about the etiopathology before surgery sometimes, or even after surgery, you will get the report and you will get the etiopathological investigation. So this is the process. So when the patient comes, you do the diagnostic investigations first, and you then assess the patient using the principles that I've talked to you, and also assess the disease that we have come across, and stage the disease using second type of investigation. Those are actually the staging type investigations, and then you go for the etiological investigations, where you are actually pinpointing what is the problem, and then you can actually plan your treatment according to the etiopathology. Now, next investigation type is the investigation for complications of the disease. Now, the complications, I would say, then you have to know what is a complication. This is something that might not have been taught to you. A definition of a complication. What is a complication? So you can't say pain a complication all the time. So if the patient comes with a fracture, what is a complication of fracture? So acute inflammation. What is the complication of acute inflammation? So something which is not in the disease process. That means we will have a natural course of the disease. All diseases will have a natural course of the disease. So there's a beginning and there is an end to that disease. So something that is not in that process is called a complication. So complication is something that you don't anticipate in a normal natural course of a disease. So if it is acute inflammation, resolution is the natural course of the disease. So if it prolongs, if the inflammation is prolonged and it becomes chronic, it becomes a, if there's abscess formation or a chronic inflammation, or if you have fibrosis, then that becomes a complication. Can you all hear me? I'm not getting any responses. Roshan, can you? Okay. Right. Now, next one is now when you do this investigation, now there are things that you need to do. Now when you are clerking, you need to, once you do these investigations, before I forget, there's 5 types of investigation. The last one you might not come across, that are investigations of complications of investigation. So that is the last type of investigation. There are 5 types, only 5 types of investigations in the world, according to a sort of a global view on investigation types. So the common example is that when you have a, say if you are doing a patient with a bleeding PR, if you do a flexible sigmoidoscopy, and if the patient, if suddenly you go into a diverticulum and perforate the bowel, you might need to do a chest X-ray to confirm whether there has been a perforation. So that chest X-ray, erect chest X-ray is not a direct investigation of that particular disease, but it's a complication of that of that investigation. So those are the 5 types. So diagnostic investigations, the staging investigations, etiological investigations, investigations for complications, and investigations for complications of investigations. So those are the 5 types of investigation that I would say that in order. That's how we do it. So once you get the investigation, there are few things that you need to do. This slide will show you what are the things that you need to do. So once you see this investigation, you need to inform anesthetist, and once you prepare the theater list, and if you see any abnormalities, you might need to work on some of the investigations and prepare the patient so the patient is suitable for particular procedure. So the next slide. Next slide, please. Next slide, Chatu. No, thanks. Right, move on. We have talked about obligatory requirements. Right. So that's what we have talked. So you have to take appropriate action if you have detected any abnormality in this investigation. So it's very straightforward. You will, if you see an abnormal so patient coming with RIF pain, you see a low platelet count, you need to inform your seniors quickly because it might be a dengue patient that you are going to operate in the theater. So this is a very important thing that you see the reports, and if you, it's a good practice to actually tick what you have seen. That's correct. Right. Can you move on? So better read on these things, because some of the investigations might not be actually that you have not come across. Sometimes you have not come across MRA, nerve conduction studies, and in your medical student career you might not seen these things. So, but you need to read on some of these things and to talk to your seniors regarding some of the investigations you have not seen or heard before. So there is the education requirement on that aspect. Next slide. Next slide. Right. So yeah. So basically, we have covered these topics earlier. So make sure what you have ordered is already there when you go to take the patient to theater. Remember that the patient must go to the theater with all the investigations that should be there. Next one. Next slide. Now, we are not going to talk about consenting because there is, I think, well, consenting is a big topic, but consent will need to improve your communication skill, and you need to learn the art of reassuring skills. And you might get patients who do not understand what you're talking about. So talk in simple terms. Sometimes you might need to talk to them several times, because with the investigations, you will have an idea how bad the situation is going to be. And the process of learning starts here, as well as you are also educating the patient, as well as the patient is also educating you in another way, because then you will have the opportunity to talk to another human being and take consent for a surgery. Surgery itself is a very serious business, because it's actually someone is giving a scalpel to you and asking you to cut himself, cut open and do something, which if you do it out of the surgical arena, you will end up in prison basically. So it gives patients do have enormous amount of trust in you. So the trust have to go on till you are discharging the patient, because this amazing trust that you are gaining from the patient, you have to respect that. And every time I touch a patient, I have that feeling that this patient has allowed me to cut that person, and I have that privilege to cure that patient. And it's an amazing amount of faith that the patient have put on me, and I respect that totally. So you need to understand, even at a surgical intern, the patient is actually putting a lot of faith, and the faith starts from you. Next slide. Next slide, please. So there is something called surgical checklist, and moving on, and we move on to the next slide, please. I have probably covered this one. So there are specific investigations and specific preparations for different patients. I'm not going into detail because these will be dealt in the next few lectures. Remember, if you don't know the preparation, just ask your seniors how to prepare this, or read about the preparation for this surgery, because there are subtle differences between surgeons, different surgeons in preparing for certain. Example is a stoma site. So some people prefer different stoma sites. I've worked with so many surgeons, and they each have ileostomy. Whether this, some people prefer ileostomy, some people prefer colostomies, and even colostomy site. There are subtle differences in different people, and you need to know your trainer or the boss to get the proper consent. Next one. Next slide. Right. We have talked about informing anesthetists. I'm not going to dwell too much on this one. Remember, the early communication is better, and if you feel there's discordance with the anesthetist team, that always better to have the what we call pre-operative discussion about the case, and make sure that make sure the surgeon himself is available during this one. So you are the key person and communicating between both parties. So make sure that you are on the target. Next one. Next slide. Yeah. So preparing theater lists. Make sure that you prepare the theater list and send it before the particular time that reaches the theater. So there's this archaic or sort of an old rule that all theater procedures should be endorsed by the director of the hospital or the authorized person, because it's a government institution. So you might need to verify with your boss, especially if you want to open a special theater, say send an emergency list, you might need to get the approval from the director or the person who is looking after the hospital at that time. It depends on the hospital to hospital, but make sure that you do the proper way and the theater list is an approved theater list. Next one. Next slide. Right. So now there is a rule that, you know, if you are postponing a case, you have to state what is the reason for cancellation. So a cancellation is not acceptable in current day practice. So cancellation, it means that you have not properly planned, or you have made into certain gone into a certain problem that you cannot you cannot avoid. But make sure that the patient is counseled properly, that why the case is postponed, and make sure the patient is not left in blank to know what's going to happen. And don't keep them fasting forever and ever. If there is you have to time your patients, so how much they are fasting, right? So some of the elderly patients might go into hypoglycemia. Kids especially, they go into hypoglycemia. So remember, communication is better, is a tool that you have to possess, and you have to anticipate that if you're anticipating some cases going prolong the anticipated time, then you have to get the other cases, might need to start a drip sometimes, might need to give a sip of water with the consent of the anesthetist. So those things have to be coordinated by the intern house officer. Next slide. Yeah. So research interests you. So this is something that is new because new for some people, but no, it has been done by interns all along. You need to research. That means it doesn't mean that you need to publish them. At least have an audit of what's happening to you. So formulate some research ideas, the cases that you have seen, and talk to your seniors whether you can be a part of the research, ongoing research, because that is something that will give you marks in future. Even if you go for any sort of training, you will be looked at, especially if you go to the academic sector where the universities, you will see that the opportunities you have missed during internship. So thank you. We'll probably stop there, and I will, Roshan, we can go to the next topic. I will see you probably. I will see you probably in the afternoon also, and I will give some links to some of the pathologies that some of the key topics that will be coming up in the College of Surgeons, and we'll give you the links to those things. Thank you so much.
Hello. Hello.
Yes, sir, we can hear you, sir.
All right. I shared my screen. Can you see my screen now?
Yes.
Okay. Right. I will start my topic, which is so good morning, everybody. The target audience is pre-interns, isn't it?
Yes, sir.
Right. So, good morning, and like you are now young, hopeful doctors, and you have a full life of full medical life in front of you, and you must be having a lot of hopes of becoming various prominent people in the arena of medicine. So all the best to you. And today I would discuss with you some very salient, important and simple points which will make your internship easier, because your medical life as a medical professional starts with the internship. And knowing these facts, especially your surgical internship, would be very useful. So I'm going to talk about acute surgical abdomen and scrotum. Majority of your acute surgical problems are in the abdomen, in general surgery appointment as an intern. So when the patient comes to the ward, as you learned during your your medical student days, initial resuscitation and assessment is the most important thing. So as you have by-hearted so many times, it's, airway, breathing, circulation, stability, and environment and exposure. I don't want to elaborate on that, because you have to first do this assessment to see that the patient does not have immediate life-threatening problem. So that then only after that only you go and assess various systems. So when an abdominal patient with abdominal problem comes, or emergency comes, abdominal scrotum, utmost importance is history. You have to get a very good history, right? So past surgical history, medical, dietary, medication, whether they have undergone, surgery before, any comorbidities. So history is very important, because then you go to because the history can narrow down your investigations, narrow down your diagnosis, and stop wasting time. Then always you have to keep in mind, a woman has a thing called reproductive system in their abdominal cavity. So you have to always think of whether when they come with abdominal pain, women, especially in the childbearing age, whether there is anything which is in the reproductive system is causing this. So how can abdominal emergencies can present at pain, guarding, rigidity, distension, constipation, vomiting, bloody diarrhea, fever and chills, loss of appetite, drowsiness and loss of consciousness, and shock with low blood pressure and tachycardia. Now, when they come with abdominal pain, because abdominal pain is the main symptom of abdominal emergency. When they come with abdominal pain, there is a rough way of deciding which organs will be causing pain or responsible for the pain by looking at the area the pain appears or pain mostly prevalent. So as you know, abdominal content divides mainly into single organs and paired organs. Generally, paired organs such as kidneys, adrenal, testes. So these paired organs usually cause pain in the lumbar region or on the side of the abdomen. But the single organs, which is formed usually from the initial gut tube, can be divided into three, as you know, into three groups like foregut, midgut, and hindgut. So foregut organs generally will present pain, foregut organs and the organs which bud from the foregut, like gallbladder, pancreas. They present pain in the epigastric region. And then the midgut, starting from the duodenum to the transverse colon, including the appendix, when it comes as a visceral pain or referred pain, as you say, that will be prevalent in the circumumbilical area. That is why the appendicitis, the famous example is the appendicitis, where appendix first felt, the appendicitis pain is first felt circumumbilically. So, and then the hindgut, which starts from the just proximal to the splenic flexure, descending colon, and the rectum, that will be prevalent. The bladder, that will be prevalent in the lower abdomen or suprapubic area. So when you have the pain, that is why you have to ask where the pain is from and the exact, and no, this comes in the history. Visceral pain is like that. However, visceral pain is beyond when the parietal peritoneum gets inflamed, like appendix. The parietal peritoneum is pain sensitive, as you know, but visceral peritoneum is not pain sensitive to injurious inflammation. So visceral peritoneum will have a preferred pain, while parietal peritoneum in the site of the where the organ is touching. So that is why when the appendix is inflamed, really inflamed, it causes tenderness and pain in the RI. It starts in the mid circumumbilically and then spread to the RI. All these things you know. Then abdominal pain present as 4 types of colics. Now, colic is as you know, is a intermittent, typical colic is an intermittent kind of pain where you get high, the peaks, and then troughs, where the lows. And these colics are usually, the colics usually occur from a hollowed organ. So what are the hollowed organs? In the abdomen, abdominal cavity. So you get ureteric colic where the ureter, from the ureter. Then you get intestinal colic. Then you get biliary colic, and you have this hollowed gynecological structures like fallopian tube and the uterus. So these colics, although they say colic, these colics differ from each other. How they present, that is also in the history. If you draw a pain threshold, ureteric colic will go high and then come down, but not to the base. Then again, it will stay for about maybe few minutes, about 20 minutes, come down, and then again it will stay not at the base, but slightly, but higher level. That means the pain is persisting for another half an hour, and then again it will go up. So ureteric colic will not touch the base, but intestinal colic, all of you have experienced intestinal colic. Unlike urinary colic, intestinal colic comes down to the base, goes up, comes down to the base. That is what you feel when there is stomach upset. Biliary colic is not a true colic. It's called a pseudocolic. That's how it appears. Biliary colic will go up, severe pain, and then there is a plateau of pain, very severe pain persisting. And that will be there for a few hours, and then slowly it will settle. So if biliary colic occurs due to the stones in the gallbladder or obstructed cystic duct, the pain will be like that. Gynecological colic, again, the pain will be low abdomen, and then patient will have other types of history like amenorrhea, and then again the pain will be persistent, will be there. So when you examine, you do a general examination first, examination of the abdomen, examination of the pelvis, which includes per-rectal and per-vaginal examination, and only when appropriate. Then you look at certain signs. Now this is, everybody has learned what this is. This is greater than a sign where the blood has tracked from the intra-abdominal or retroperitoneal spaces to the lumbar region. So this shows that there is a hematoma in the retroperitoneal or intraperitoneal. Then what are the, how do you investigate? Now when you as an intern, you can't investigate all, you can't do a CT scan at once. And being a poor country now and becoming poorer daily, we have to concentrate on investigations, doing the cheapest and the simplest, but most effective investigations. I have seen some interns where they just have a set of investigations. They will order all these investigations on the patient just to avoid blackguarding from the superiors, including the consultant. I think that is wrong. If you take a good history and if you do a good examination, you can cut down on the investigations. That way you can save money, time, and then also trouble for the patient, because all these investigations are going to trouble the patient. So when you are thinking of investigation, think about the simplicity, availability, time consumed. Will it identify life-threatening conditions? Is it going to change the management strategy? How safe is the investigation? How cost-effective is the investigation? And whether these investigations are reproducible? And I would add whether these investigations would help to decide on the natural history of the disease process. For instance, if you take CRP or C-reactive protein values, if you do serial investigations, you can decide whether this inflammation is settling or not. So I must add that to this list. Then what are the available investigations to you? As an intern house officer, you will be able to order all these things which are stated in blank. Others which are stated in red, you won't be able to order unless you get permission from your superiors. So you have to know out of these investigations what you have to order. Now, I will just come to now just some X-rays where you should not miss. One thing of the X-ray is, if you order an investigation, you must go and go after that and find the result. Because if you don't find the result, no point ordering the investigation, right? So this is something which is very important. This shows gas under the diaphragm. That means there is a ruptured viscera generally. unless proven otherwise, there is ruptured viscera. If you have gas under the diaphragm, then this has to be sorted very soon. This is again, right? There is gas under the hemidiaphragm, right hemidiaphragm. Then this has to be sorted because this can be rupture of some followed viscous in the abdomen. This is again erect X-ray where you can see the erect X-ray because of fluid levels, and this shows small bowel. Right? So these small bowels you get plizy. So and these things will go right across the bowel, and therefore you can identify small bowel like this. And if you see small bowel like this, there is a pathology definitely, because usually in a normal person, except a few places like duodenal cap, small bowel is not visualized. So if the small bowel is visualized like this, then there is definitely something wrong inside. Now this is dilated large bowel. It shows ostrations where you get only partial. These demarcations are partial. Right? So this is again dilated large bowel. So you have to know dilated large bowel and normal large bowel, because large bowel air is normal, but when it is dilated, it is abnormal. And on top of that, I think this large bowel shows some thickening and some fluid because of these lines. This is a pancreas. This patient has a chronic pancreatitis and she get lot of calcifications in his pancreas. Right. So when the abdominal pain comes, what are the high risk abdominal pains? You have to identify when the patient comes, high risk the abdominal pains with high risk. Those patients are the people, because you get a lot of patients, 101 patients, and then you have to identify who is the patient whom we have to have we have to give special attention. Old patients, patients over the age of 65, immunocompromised, patients who are alcoholics. Alcoholism, you don't call them alcoholics, you call them the people who abuse alcohol. Right? So you don't discard them as useless fellows. Right? Cardiovascular diseases, major comorbidities like cancer, diverticulosis, gallstones, inflammatory bowel, pancreatitis, renal failures. Prior surgery or recent GI instrumentation, risk of obstruction and perforation. Then early pregnancy, risk of ectopic pregnancy, and of course, risk of abortion. Then, according to pain characteristics also, you can see whether the pain is high risk. Sudden onset and maximum at onset and pain, then subsequently vomiting and very severe pain. Examination findings, tense or rigid abdomen, involuntary guarding, and signs of shock. So these are the things, these are the patients with features where you would be wise if you attend to them quickly and if you notify your superiors. Then what are the principles? Identify the problem, do not delay unduly, select the best possible investigations and treatment, do not hesitate to call for help, because these people are there to help. A drug is given only when it goes through the cannula or mouth. You can't order on the BSc and think that the drug will be given. Sometimes drug is out of stock and drug is never given for days. So drug is considered given only when it goes through the cannula, or if it is oral drug, when the patient swallows it. Appoint one responsible person to communicate, because a lot of people go and communicate various things in bad patients to best person to communicate is actually not the Intern house officer, at least a trained SHO or above.
registrar, SISR, or the consultant himself should communicate with the relatives. Because relatives will be very upset, you have to handle relatives as well. You have to pacify relatives and then tell them the story and say, otherwise you will be very unpopular among the relatives and there will be a lot of problems, especially in the case of children, pregnant mothers. Initial management is keep nil by mouth till decided by a senior. Have a good IV access. Resuscitate and correct electrolytes, fluid balance, doses, manage pain. Keep a close eye. That means don't keep your eyes closed, but closely monitor. And consider catheter, nasogastric tube, multi-monitoring when available and when indicated. Always have this as a checklist in your mind. If you don't have a mind checklist in the mind, you won't do it. Pitfalls are, especially think about pancreatitis, leaking, abdominal aortic aneurysms, ischemia and infarction of the bowel, undisclosed traumatic events where a patient has fallen some 3-4 days back and then comes with a perforation, small perforation which might mimic, which would have missed at the time of the fall. And these things we have seen. Abdominal pain caused by extra-abdominal pathology like myocardial infarction, lower zonal pneumonia, diabetic ketoacidosis, and abdominal migraine. So these things are the pitfalls. These the things I mentioned as the first 4 causes. Generally, you tend to miss. You tend not to think about that. So you have to make an active note in your mind to think about these things and to exclude once you get acute pain. Then I'll come to acute scrotum. Acute scrotum can be due to torsion of undescended testis or torsion of the testicular appendage. Torsion of the testicular appendage is not a problem, but it's very difficult to differentiate. Torsion of the undescended testis also can come as a pain in the groin or painful tender lump in the inguinal canal. Then infection, epidermolysis, infected hydrocele or pyocele or bleeding into the hydrocele. Then scrotal edema and infection, either allergic or animal or insect bite. Now out of all these things, it is very difficult to diagnose and exclude torsion of the testis, which is a time-sensitive issue, where if you delay more than 6 hours, that person is going to lose one of the testes. So therefore, sometimes you may have to, and you have to inform your senior as soon as possible when this occurs, and then he might have to and arrange theatre sometimes, because he might have to open, explore, and then untort it. So that is very important that you. So finally, I would say, they say abdomen is a Pandora's box, because this lady in Greek mythology was given a box by the god Zeus, and this box was, she was asked to keep the box closed, because however, out of curiosity, she didn't know what was in the box, and she opened the box, and then all the bad things escaped into the world, and then somehow she managed to close it halfway, and then some other good remained. So abdomen is also like that. Sometimes you never know when you open at a laparotomy what has been wrong with the patient. So it is like a Pandora's box, they say, right? And thank you.
Thank you, sir, for your lecture. Then we'll move to the next lecture by Professor Srinath Chandrasekhar.
Chatu, do we have Prof. Srinath online?
I don't see him, sir.
Can we give a ring and remind him?
Sorry, sir?
Can we give him a ring and remind him?
Yeah, sure thing, sir.
So I think our lecture panel has a problem in connecting because of certain few emergencies, and I probably will. Roshan, can I do the burns lecture now? Because then wound care, then it will probably cover a lot of area, and we can start the lecture.
Okay, sir. Okay, sir. I'm representing Dr. Rashan at the. Okay,
then
sir.
we'll,
You can continue, sir. You can continue.
We'll otherwise we are going to lose a lot of time.
Yes.
Can you see the presentation?
No, sir. Can't see the presentation.
So give me about 5 minutes so I can go to a better because it's done through my hotspot. I think I'm not sure why it's not recognized, but just
Okay, sir.
can you see now?
Not yet, sir.
It's not shown, no? The screen.
Yes, sir. Can you email the presentation, sir? Then I can put from here.
All right. It's probably a big presentation. Sure. What is the email? Oh, no. Can you give me the email address? Chatu, I have sent the email. So I'll send it to the college. It's easier. I don't have the email to you. Hello, Chatu. Can you upload the PowerPoint presentation? I just emailed it.
Okay, sir. You can post it through the college.
Yeah, that's what I'm doing. So just to give you some updates, what's going to happen. So I have I will give you a link. The training.
I didn't get the presentation yet, sir.
Only it came, I think. See whether it has come. So I have shared a link, Association of Plastic Surgeons link, which has these resources to burns. If you can, if our trainee, our pre-interns can actually join the group, and they will probably get all the updates on burns management and hand trauma management, facial trauma, and the updates on plastic surgical interventions on that. So that is one resource that I can share with permission. So you can actually join that. So I think we got the PowerPoint presentation. Oh yeah, thanks. So this is a course that was designed for managing emergency burns management in Sri Lanka, which is run by the Association of Plastic Surgeons. And next slide. Yeah. And if you get this patient, I got this patient. He's a 16-year-old boy coming with a burn, and he was unconscious and had this burn. So this is a water heater that is on the face. Can you see a full thickness burn on the face? Now I know that this patient is not going to die because of this burn, because it's a relatively a smaller burn. However, it's a major burn. So this patient's problem, now the problem that I'm anticipating is not only the acute problem. Now I have to face this, I have to treat this patient for next nearly 20-30 years. A lot of plastic surgeons have to treat this patient in his lifetime. So why we need to treat this patient? Simply because this deformity is not compatible with our normal human behavior and normal human acceptance. And this 16-year-old will have problems, will lose schooling, and will not be able to go to school and associate with his friends like normally what normally he was doing, because his face is deformed even after all these things are done. And even if we finally manage to send him to the society, it's very difficult for him to go for higher education opportunities, because his parents will have to lose a lot of money, and they will not be able to do it, and he will lose a lot of school time, and more likely is that he's not going to perform really well. And also, unless he does extremely brilliant in his academic work, he will find difficult to find a job. Then he will find a difficulty finding a suitable partner. That means he will not find a person who is usually what he wants. People want to marry a pretty girl, and this boy will want to marry a pretty girl, and then move on having kids and all those things. But he will find it very difficult. The parents will find it very difficult to give him in marriage unless they have to compromise always. And when he has kids also, the kids will not like to look at him because he looks different from other parents. The kids will not like to take him to his school events because he saw her parent looks different. So imagine this entire life is ruined in this patient unless you manage, it's very difficult to manage this patient, and you have to manage him psychologically also. So this is a big bit of a big social issue that you are facing as even a single burn. So next slide will show you how we manage burns in acute care. How we manage acute care is, go to the next slide. Now, when this patient comes, you have to manage certain things. Next slide, please. Yeah. So we have, like trauma, we have primary survey and secondary survey that will be taught in great detail by Dr. Abejiva in about another 1 hour time. So we start with the primary survey. I'm sure that you have already done this by emergency physicians, but what we do is bit different. We have a primary survey, secondary survey, and in between you have FAT. That means FATT. So primary survey is airways, spine protection, breathing and oxygen, circulation and arrest hemorrhage and IV access, disability, AVPU, or the Avpu scoring. I'm sure that everybody knows Avpu scoring, and you have to then go for pupil size and reaction to see the head injury part. Then you go for the exposure and environmental control. Can you see that it deals with all the life-threatening injuries at present, and only during the exposure you will start calculating the burn surface area and the depth of the burn. Once you are happy with the primary survey, only you will move to the secondary survey. But before that, you will have to calculate the fluids that you need to give for this patient and how to give it. Analgesia, because it's a painful condition, and tests. We recommend the fast scan in our setup, because we don't have X-ray facilities in the emergency resuscitation rooms. It's very, very unlikely that you have a mobile X-ray there in the emergency department or in the ward that you will be treating these patients. Or fast scan is probably the quickest way to get through if you have the ultrasonography in your units and you have a radiologist standby. And tubes, where tubes by tube is the NG tubes and ND tubes. Right. NG tubes, urinary catheters, those things. So now there are problems that you can help with this system. No planning possible, no trained personnel in usual or to train personnel. And this hampers fund allocation because the data is not available, how many burns are there. And if you don't properly diagnose the burn, you will have problems in the record keeping system. Record systems are pretty outdated and miserably inadequate. So might need to, when you are intern, you might need to put the diagnosis not as a burn, but actually you have to categorize it as a major burn or a minor burn, or with the percentage. So next slide. Now, you can go faster, I think. Right. The cost is also very, yeah. So go to the next slide. Next slide, please. Next slide. Next slide. Yeah. So these are the causes for burns in Sri Lanka. Now you will see adults. Accidental flame burns are common, but now it has been becoming some of the burns are becoming self-immolation or self-inflicted burns are becoming common in major burns, severe burns. Usually the females used to be the commonest group that is getting self-immolated, but now it has changed and it is mainly males getting the self-immolation or the don't call it suicidal burn because it's not, they don't have suicidal intent unless you have depression or something, but it's a self-inflicted burns. So now usually the burn accelerant or what they used to burn is themselves is also changing. We used to have kerosene oil. Now it's mainly petrol because the petrol is at home. Next slide. Now, what you do is what you call the first aid is stop, drop, and roll. So now, how it is done is shown in this video. And next one is to actually, actually the cooling of the burn. Remember, that is the first aid. First aid happens outside the hospital. When the patient comes to the hospital, you don't give first aid as the first thing. But you do the primary survey, and then you do the FAT, F-A-T-T. And if the patient is within 3 hours of the burn, only you give first aid. There's point in giving first aid unless it's a chemical burn. So don't jump into first aid when the patient comes to the hospital. So first aid is for your education, how to do it, but not, you don't do the first aid as soon as you get the patient. You don't send them to shower. You have to exclude life-threatening injuries. If the patient comes to you with shouting and pain and walking, you know that there are no life-threatening injuries, you can send them to you can put a cannula and put some check the saturation and the patient. After going through that checklist quickly, it takes only 2 to 5 minutes to complete that checklist. And if you have a team, you just put cannulas, get the nurse to put a cannula, maybe 2 cannulas like that, and we'll go through that later on. So how to do this stop, drop, and roll? I'll just can you play this video? Sorry. Just play button. So we will share with this video how to do the stop, drop, and roll. It's a very educational video. You will see that they are just chatting about how to do it, but how you do it like that. Stop, cover your face, drop, cover your face. Remember to cover the face and roll, because if there's a big flame, the protection of the face is the most important thing. So go to the next slide. Cooling the burn is usually done in the only the burnt area should be cooled, not the entire body. Right, next slide. Next slide, please. Right, now there is something called local and general response to burn injury. Go to the next slide. Now we know there is something called burns is not a 2-dimensional thing, it's a 3-dimensional thing. Usually you will have a depth to the burn. So we have a dead tissue in the center, you have a static zone where the blood circulation is stasis, and you have a hyperemic zone where there is hyperdynamic circulation. So this is called Jackson's burn wound model. So the first aid will determine whether the zone of stasis will become converted into zone of coagulation where the necrosis occurs, or it goes into the norm, it will survive the burn injury. So if you have maintaining circulation in this area, you will have the surviving cells will survive, and if your circulation drops further and this area becomes ischemic, the zone of stasis will undergo necrosis again. Go to the next slide. Right. So when you get a burn, it's not a simple burn, like not one burn. It will have different depths to the burn. You will have deep burns, superficial burns, and a mixture of this will have the burn percentage. Next slide. So this depth also changes with this. So now if you see a superficial burn today, it might become deep next day due to adequacy of first aid and adequacy of resuscitation. Now the burn is actually the actual stable burns. Burn becomes stable after about 3 days. So sometimes you might need to change your diagnosis of percentage and the depth around 3rd day, but you make a diagnosis first, but you understand there is going to change and probably change it around 3rd or 4th day. Have a look again, 3rd change. Sometimes you don't look because you have put a definitive dressing, but this is usually the theory behind how to diagnose properly. Next one. Now you will have understood this capillary the capillary exchange mechanisms called Starling forces. Starling forces are usually the ones that are governing the body fluid homeostasis. And the problem is we have the lot of edema. So how does this edema work? Basically, it is you have next slide. You will show that the slides are next slide. All right. So extravasation fluid and albumin both will go out of the circulation and localized and generalized edema will be there. Localized or generalized edema will be there, and the patient can go into hypovolemic shock. We call it the burn shock. Next one. Now, there's metabolic effect of this burn, starting with cortisol, catecholamines, and glucagon, which are stress hormones, and also suppression of anabolic hormones. So these have a lot of implication, and burn becomes a disease for that particular patient. Next one. Next slide. Yeah. So these are the other effects that you have, the cardiac suppression. When a big burn gets on the body, the cardiac suppression, the particular patient that I showed you initially had, when on admission, had a cardiac output about 30%. So there was global hypokinesia of the heart. So they can happen. And respiratory distress syndrome, because of the burns, the chemicals that are released to the body, the lungs get injured. Lungs will have a lung injury also. And immune dysfunction, because of this burn, the immunity drops down. That is why we are able to put cadaveric skin on the burns as a temporary dressing, and it will last for about 2 weeks. So till the patient develops immunity against the skin graft from another patient, another dead person. And also you have loss of gut integrity. You will have a lot of gut integrity and sepsis due to that one. And now we are detecting hormonal problems, especially male patients where their testosterone levels drop to very, very low levels, and they have psychological problems, depression, and we are now replacing even testosterone needs to be replaced some of the burns patients. So that's a new area that we are exploring to improve patient level. Next slide. Now, emergency examination and treatment is given in that emergency checklist slide. Go to the next one. Next slide. Yeah. So there are 3 categories of burns. There can be only burns masking other injuries, as well as burns presenting with other injuries. So masking other injuries and other injuries. That means there's a burn on one area, and there is another injury on another limb. But if the patient has a head injury with a facial burn, we could think that it's due to the hypoxia, the patient is not responding, but it could be due to an EDH or something in the head. Go to the next slide. So diagnosing may be difficult in some of these patients, particularly when they are intoxicated or they are unconscious, or they have psychiatric patients. So those are the categories we will have problems diagnosing other injuries. Next slide. Go to the next slide. Yeah. Right. Now, yeah, go to the next slide. Yeah. Stop, drop, and roll. Now, this is the first aid protocol before coming to the hospital. Stop, drop, and roll. Water for cooling in the periphery. Once the patient comes to the hospital, then you do primary survey, and that is how it's done. So this is burns first aid. Yeah. But when the patient is in the hospital, go to the next slide. It is again done through that slide. Next slide. Yeah. So you can take a screenshot of this one because this is one of the most important slides that you will come across. It will come again and again. It will repeat because the secondary service is also there, and we'll talk about that as we go on. Next slide. Right. Now, this is primary survey. We have already talked about primary survey, and these are the things that we will be doing: airway, breathing, circulation, disability, and exposure. And at the same time, we will be doing some there's assessment path, and also there's something we have to do. So if you think there's a cervical spine injury, you will have to control with the airway, and you have to give oxygen, high flow oxygen, and you need to circulation. You need to start IV line, start something like we use the fluid of choice is Hartmann's, or the we don't have Hartmann's in the country, but we have Ringer's lactate. We start Ringer's lactate, and 2 lines, start 2 Ringer's lactate in adults, and pediatric you need to start 1 Ringer's lactate. The other side is half normal saline, dextrose saline. So that is a maintenance fluid. So in the exposure only, we will be exposing the patient and calculating the burn surface area. Then we will be calculating the proper fluid in the next slide. So next slide. Yeah. So the airway is important because although the patient comes like this, in about another 15 to half an hour, the patient will look like the next slide. Next slide. Yeah. So the patient will look like that. So we will find it difficult to intubate even some of the burns patients. Next slide. Right. So how to insert cannula? Now insert through unburned tissue. Take blood for investigations like full blood counts, either molecular, random capillary sugar, and cross match because they will need some, and start Ringer's lactate on the same line. We will go to the disability. Yeah, disability. Then you check for, this is the AVPU classification of disability: alert, visual, respond to voice, respond to pain, and unresponsive. So you have to categorize according to that. And if the patient is not only respond to pain and unresponsive, you might consider intubation at this point, but better to talk to the ICU and the anesthetist team before doing it, or the emergency management emergency team. Next slide. Now exposure need to be done like this, and it should be a warm area, and patient need to be log rolled to see calculate the proper burn area. Next. Now we use the rule of 9 usually, and use the palmar surface of the patient as 1%. So that is easy to calculate. But in pediatric practice, the next slide will show that. Next slide. The pediatric practice, you have when they are born, the head is about twice the size of the body. So the limbs are usually 14%. Every year, the head size reduces the percentage. 1% is reduced, and 0.5% added to both limbs. So at age 9, it's 10, and around 1 year, we add that 1% to the perineal region, and that is the then becomes adult rule of 9. So this is pediatric rule of 9, and that is compared with the adult rule of 9. Now we can actually calculate the fluid, and then we will have to go back to ABCD, and then we do give the analgesics, do the X-rays, and put the tubes, or the other way also. You can put the tube and do the X-rays and tests. Then you can actually measure. You can actually see whether this X-rays are the tubes are in proper place. Next one. So this is the fluid calculator. I'm not going to calculate here, but this is the formula which is known as modified Parkland formula. Remember, this is a guide, and this should be calculated. Half should be calculated amount should be given half in the first 8 hours. Next half should be given in the next 16 hours. So the hourly rate should be actually calculated and given to these patients. And remember, the first 8 hours is calculated from the start at the time of burn, from the time of burn, not the time of admission. Remember that. If the patient comes very late, you will have to give boluses and correct the urine output, then actually calculate the hourly rate that is required and start the hourly rate according to that. So it's there's a bit of common sense has to be used in some instances. So next slide. And this morphine is the preferred, IV morphine is the preferred medication for pain because it's so painful. And we calculate the total dose and give a small frequent doses till patient becomes calm. So then you don't have to be afraid whether the patient is going to be respiratory arrest, because a painful condition will never, that means the pain is so bad, so bad the patient will never go into arrest because they will not sleep. Next. Right. So tests, the standard way to do is, these are available radiology, but we might not do them in our setup because if you don't have these x-rays inside the resuscitation room, you don't send the patient without any fluids and everything to the x-ray and wait toward half an hour to get the patient back. So our setup, we recommend the fast scan or the e-fast scan, and that will be give you rule out a lot of life-threatening injuries. Next. These are the tubes that we talked about. Again, you can put central lines at this particular point. If you can't find both upper and lower limbs are burned, and then you can actually think of a femoral line or a neck line. Next. So monitoring is the next important thing. You have to monitor the urine output, urine color, pulse oximetry, blood pressure, and respiratory rate. Some of them can be easily monitored. Especially the urine output is the most important thing. We have a target value of urine output. Next slide. So then you have to reassess the next slide. Yeah. So remember, respiratory compromise, peripheral circulatory compromise, neurological deterioration. These are the things that you might need to go back and reassess the primary survey. Go next slide. Right. Yeah, the secondary survey is a very comprehensive study. We have a comprehensive examination, history and examination. Once you do a comprehensive history and head-to-toe examination, and then this should be documented, and tetanus toxoid should be given at the same time for the patient. Right. Go to the next slide. Next slide, please. Yeah. So history is like this. You take the ample history. So this is something that we advocate in trauma situations. Go to the next one. So we ask some of the important things: the duration of burn and close space, and there's accelerant on the body and clothing caught catching fire, because some of them are important. And you because if you intubate and the patient dies in the ICU or with the tube and unconscious, you might miss. Some of the burns are usually homicidal, and some of the burns are self-immolations, and some of the burns are accidental. But true history is most of the time the true history is not given, but you have to record what the patient says. Some of the patients will tell you that the patient has been set on fire. This may be the last time that some human being is talking to this patient. So you better talk to this patient. So this is important in that sense. Can we move on next? Next slide. Yeah. So yeah, we talked about this one. So do a proper neurological examination. At this point, you can do a GCS examination if you think there is a head injury. Go on. Right. It's very important that you maintain records, because the now era of litigation is coming up very fast. You will be called upon to give evidence why you didn't do this, why you didn't do this. If you have actually done this, and then you don't have a problem, and the consent issues are sorted out, then you can The problem comes when there is a patient coming with a big burn, and the relatives want you to transfer the patient to National Hospital or another hospital. Now, you should not transfer a patient just because the patient relatives are pressurizing you. So what you need to do is either contact your seniors, but you can do this also, because you can contact the burns unit and ask whether they are happy to take over the burn. And if you still find the relatives are not happy to keep the patient, you get a call or maybe a video call to the burns unit, and they will contact me or someone who is here, and they will talk to, we should be able to tell the patient's relatives without resuscitation, we don't transfer, because during resuscitation, patients should not be transferred because the patients are not stable enough to transfer. That will be killing the patient on the way. And if you don't resuscitate properly before you send the patient, all patients are going to be acidotic, and the patient will usually die within a couple of days, because the hypovolemic shock will kill the patient. Transport is very difficult, especially long distance transport should not be done in a patient with a severe burn. Severe burn, in the sense, severe burn is a more than 20% burn is a severe burn. Remember that. So shall we go on to the next one? Now, some of the urine pregnancy tests and those things are actually you have to use your common sense and do them if you have the facilities. Sometimes you have arterial blood gases, very important. Sometimes in a big center, we go by the lactate levels when we resuscitate rather than even the urine output. We will go by lactate levels. Now these days, of course, we don't have even blood gases to do routine things, but those days we used to do blood gases and resuscitate them according to blood gas. Especially blood glucose levels are very important. Some situations. Next one. Right. Dying patients, I think dying patients are another problem that they have to give. You don't aggressively resuscitate a patient with 90%, 80% burn, but patient needs to be given proper, proper relatives should be counseled, and you have to be absolutely clear that they understand this. There's no way of resuscitating a patient beyond 80% burn in this country. Salvaging a burn more than 80% unless it's a child, because children sometimes do make it through. I have seen very rarely 80%, 90% burn surviving in kids in Sri Lanka, but in adults it's almost a no. So you have to talk to the relatives and explain it clearly, and you can actually take the call to the burns unit and explain the relatives through us also, that the best thing is to have the talking patient than a tube patient dying on the way. So give them morphine drip, and they can let them be in an isolated area where they are happy, and they might pass away quietly. So next slide. Now these are about unstable airways. It's the same thing as any airway issues. So remember, the airway sounds are very important when the patients are hunger for air. We'll have to take a note of that. Next slide. Right, intubation, these are the indications for intubation, but remember, these are for if you're transferring the patient, a stable patient, you might need to see whether there's a ICU bed available before you take the decision of intubation. Sometimes it's because most of the hospitals will have these high flow nasal oxygen, and you can use that instead of intubation some instances. But if you are intubating, intubate quickly, because if you intubate delayed, you might find intubation also difficult because of swelling that happens on the face. Next slide. Now, carbon monoxide poisoning, cyanide poisoning is also common in burns, where especially in-house burns. So you have even before this, the burn kills the patient, the cyanide or the carbon monoxide will kill the patient. How does cyanide come into play? So cyanide is usually produced by burning plastic. So cyanide is produced as a gas inside homes there where you have plastics that are burning. So the plastics can actually emanate, produce cyanide, and you can die with that. It's a different mechanism. I'm sure that you will know about this mechanism of death in these poisons. The next slide. Yeah, this is about carbon monoxide poisoning and the level of carbon monoxide poisoning that is that can cause death. Next one. And the burn depth assessment is important. We have five types of burns, where superficial burns, mid-dermal burns, and deep burns. These are the types of burns that you will get. I will just go through quickly what the burns are. Go through them quickly, Chatu. Thank you. Next slide. Yeah. So the epidermal burns, only the epidermis. It heals within 7 days. Next burn. Next one is actually the this, you can see it's in a white person, you may see it as a sunburn. Next one. Next slide. Yeah. Superficial dermal blisters, you will see blisters, and usually they heal with these appendages will actually grow and cover the burn. But remember to scrub this burn. So when you have to get rid of the burnt tissue for the skin to grow. Otherwise, you can't expect cells to grow into the burnt tissue and to re-epithelialize the burn surface area. So that's a very important point. Superficial dermal burns and mid-dermal burns, you need to clear out the burn tissue in the theater, not to cut, but to rub it so that all under general anesthesia, so the burn is rubbed off. So you have fresh tissue that can actually get re-epithelialized with the hair follicles and the sweat glands, and also the periphery. Next one. So these look like that. Next. So administering oxygen, there's a question, I'll answer it later. The mid-dermal burns, they usually sluggish capillary refilling is there. If it is not there, that means it's a deep dermal burn. Capillary refilling is not there, it's a deep dermal burn. So go to the next one. Next slide. Yeah, you can see that. So next slide. When you press it, you will see it. And if you don't see the capillary refill, it's usually a deep dermal burn, and it may become white, and you see some red patches. Sometimes they are actually extravasated blood, not really blood, the capillaries that can be seen. Next one. Yeah, you can see some of the areas. So full thickness burns are like that. So we go to the full thickness burns, and it looks like sometimes it can be like a very thick brown, something like dead, the artificial sort of a you get what you call Eshka formation, which is a thick Eshka and a brown Eshka. It's almost like dried up skin of a dead animal. So go to the next slide. And it changes with time. Remember this, sometimes it improves, sometimes it shows blisters, and blisters can rupture, and those problems are there. Next one. Next slide. Yeah. So this is another way to diagnose the burn, or what is the burn percentage area. Next. And urine output, these are the target urine outputs for adults and children. Remember that, maintain this, and you know that your fluid resuscitation is good. Next. Next slide. Yeah. So wound management, I will quickly go through the wound management. So this is a burn scrub. We take the patient to the theater. Remember to scrub the burn off totally, and then we have to actually put a either a definitive dressing or a temporary dressing. Usually we put a definitive dressing on some of the superficial burns like silver dressings, and it's usually done by someone who's experienced, or you have to put something like silver sulfadiazine and change it daily or every other day. So the patient, we expect that burn to heal. Next slide. Yeah. So remember that this burn, now these burns will need debridement. That means where it needs to be referred to a burns unit, or you need to cut this burn off and let the granulation grow. Let the burn tissue removed, and then we have to dress it for a couple of days, and then we have to graft these burns. Next. Right. This slide is the most important thing. I will probably stop there. And there was a question. I think it's 11 o'clock. I'll stop there. So there is a question whether we can give oxygen to a burn when patient face is involved. So I told you that there are two ways. Either you decide whether to intubate or put them on high flow nasal. Of course, the inhalational injury burns management in inhalation is quite extensive. It's probably 1 hour lecture. I'm not going to talk about that now. Inhalational injury will need to have a what you call a bronchoalveolar lavage. So you have to flush the bronchus with all the burn material has to be removed from the bronchus. Otherwise, they are going to get bronchial irritation and bronchoria. We call it bronchoria, and also cast formation. That's why the patients will die with obstructing airway obstructions in about 1 week time, because the airway is filled with fibrin clots. So I think there are a lot of please again I think the few earlier batches had a lot of experience in the chat box. You will see there's a link that I have provided, and just click it and join the system. If you click the system, then you get more information on this from the official book page of the Association of Plastic Surgeons. So this is and the other one on wound care. I don't have enough time to talk about wound care, but the wound care is also dealt in that the page, the association page. So you can actually go through and how to deal with wounds, how to get vascular opinion, vascular surgeon's opinion, general surgeon's opinion. So all those things are there in that, and the resources are there in that link. Thank you so much. Chatu, can we get Dr. Pinto is there?
Sorry, sir.
And do we have Dr. Kirti Abejiva? Is he available? Our next speaker.
Yeah.
Is that Dr. Abejiva? It says Kirti.
So I think Abhijiva says there. I just give a co-host. We'll see.
We'll ask him to start his presentation.
Hello. Hello. Hello.
Yes, sir. We can hear you. Yes.
All right. Okay. So how can I share my screen?
Yes, sir. We have made you co-host. You can share, sir.
Right. Screen.
So the green color button share screen on the.
Right. I'm sharing, right? Okay.
Okay, sir.
Can you see my screen?
Yes, sir. Just need, all right. Full screen. Yep.
Right. So, what was it heard as well, isn't it? Is this clear? Voice? Hello.
Yes, sir. We can hear you.
You can hear me, can you?
Yeah,
Thank you,
you can see
sir.
the
Yeah.
slides, yes.
All right. Okay. So I'll start my program. So
Yes, sir,
I'm Dr. Yeah. So I'm Dr. Abhay. I'm one of the general surgeons from the NHSL. I'll be talking to you on primary survey and basic things that you would need to do when you have to deal with a trauma patient. Some of you will be working in the major hospitals, and some of you will be working in the peripheral base hospitals and other units. So you may be the first person to sometime receive and treat some of the major trauma patients. So you have to be prepared unless you may be responsible for loss of lives. Now, next slide, please. Can I control the slides from here? It doesn't seem to work.
And so you just
Right, I can do it. Yeah, I'll do it from this end. So I'll just give a case scenario where a 35-year-old patient has been transferred to a ward from a peripheral hospital following a road accident. So he was a motorcyclist who collided with a truck approximately 2 hours back. And the motorcycle, so this will be a common occurrence in your ward. Some of you will experience this. So he has been brought by the ambulance team. So most of these patients are either brought by their own transport. There's no evidence of bleeding from external wounds. There is bleeding from a wound on his right leg, which has been bandaged. His blood pressure is 100/60 and pulse rate of 130. Oxygen saturation is 92 on 10 liters of oxygen. So at the moment, what you have to do, first of all, you have to protect yourself, whatever the patient condition, is the age of COVID and other communicable diseases. So first thing is to protect yourself, at least gloves, gown, preferably a visor as well. And then what you have to do is connect to monitors. So either you connect them to a multi-monitor like pulse, BP, respiration, saturation, or you get your, if you are lucky enough to have a nurse around, get that person to connect the monitor. So that's the first thing you need to do. So once that is done, you get a picture of the severity of the patient. So you have to confirm the numbers given by the bystander or the ambulance crew. You have to make sure it's the same pressure, or is it lower than that, or is it higher than that, and pulse, saturation, everything you have to record yourself. Then first thing you would do is stabilizing the cervical spine. This has to be done if this particular patient was brought in on a spinal board, if you can remember. So you keep the patient on the spinal board itself. If you have to return the spinal board, use log rolling and get him to your spinal board. He has not been on a collar, so you better have to use this type of what we call a Philadelphia type of collar, and you need to stabilize his head on head blocks. You can see these orange color blocks, and then if the spinal board has straps, you can use the strap to strap the patient, or you have to use something like elastoplast to stabilize the head blocks on the forehead. So once you've done that, you are satisfied that your patient's C-spine is stabilized. In any case, if you need to take off these, say, the cervical collar or the blocks for examination, someone should be manually stabilizing the head. You should never let the head be unattended unless it has been excluded by a senior, preferably a consultant. So once the C-spine is stabilized, so we'll look at the parameters. So your parameters, blood pressure is 100/60 and pulse rate is 130 and saturation is 92. So all three are, flagging red in front of you. Blood pressure 100/60 in a young man is not a normal pressure. So don't just ignore this blood pressure of 100/60. As you know, it shows a hypotensive phase. So that means the patient has lost considerable amount of blood, at least 30%. So I will show you the classes hemorrhage in a moment. So his pulse rate is 130. That means his heart is beating very hard to compensate for the losses, and saturation 92. Are you happy with that? Of course not. Young patient with 10 liters of oxygen should have 100% saturation. So all these marginal figures should not be considered as marginal, but quite a red flag signs which you need to act very fast. Right. So first we'll start with ABC. As everyone know, I don't want to re-emphasize this. Everyone knows we have to start the ABCD protocol or the ATLS protocol, starting with A, which stands for airway. You try to open the airway by sucking out secretions, open the mouth. If the patient can talk, you talk to the patient, introduce yourself, and if the patient talks, patent, and you have to get on with the next level. But if the patient is not responding, say he's unconscious or semi-conscious, then you may have to suck out the secretions and particular jaw thrust, or push the jaw from here forward like that. So your airway will open. And also in a child, you can put your finger like that and pull your jaw open anteriorly. So the airway will open. And then see whether oxygen saturation improves. If it improves, we have to go ahead and put an oral airway, something like that. You can see the oral airway. So you measure roughly the airway length from the angle saturating well. Here in this picture, if you notice, which should never been done. In trauma patients, you have to manage the patient without extending the neck. So you have to manually or mechanically stabilize the neck and put as it is without extending the neck. So if the patient has still oxygen saturation of 90 despite doing the oral airway, then what are the things that you are left with to get a normal saturation? So unless the saturation is 9900, you don't take it as a normal airway problem, airway or breathing issue. So if the saturation is still low, the patient, the air entry is not adequate, if you think the airway is blocked, you may have to go into advanced airway maneuvers such as intubation or surgical airway. Intubation is done with medications, and you have to get properly trained to that. You have to you can join one of these trauma programs like NTMC or even BLS or ALS program, which they teach you how to intubate, which is very, very important. If you can do that before starting your internship, that will be very good. You'll be saving some lives at least. So if the saturation is still low, you intubate. If you can't intubate, you have to get the airway. So once the airway is patent, you have to check completed. You get on to B. A, make sure that you, once the airway is patent, make sure that still the patient is kept on high flow oxygen. Right. So we'll get on to B. So X-ray was done by this one junior house officers like you all, and this was the X-ray. Anyone can see what are the problems in this X-ray? You can see that the lung fields, you can probably a tension pneumothorax. One thing, this X-ray should never have been taken because this condition should have been identified and treated before you sending for X-rays. Because the time you spent on taking X-ray on this patient, X-ray table, this happened in the past. So don't, unless what you have to check is you have to check the tracheal position, you have to check the percussion note, and check the air entry. And if any of those are compromised, if you suspect a tension pneumothorax, hemothorax, or even a pleural segment, you should not, then and there treat it and then think of X-rays rather than the other way around, which has to be decompressed immediately. What we do is first of all do a needle decompression, either in the second intercostal space in the mid clavicular line or in the safe triangle, which is the anterior axillary fold here, mid axillary line, and the fifth rib. So this triangle is a safe triangle. You can put a needle there and get the air out. So you may notice an immediate improvement in the oxygenation. Once you've done that, you have time to put an intercostal drainage tube. Again, this is a technique or maneuver that you need to master yourself, because you may not have time till your seniors come to put the intercostal drainage tube. The patient may go into cardiac arrest. So one other thing that you need to know, apart from endotracheal intubation, is how to put an intercostal drainage tube safely. Right. So once we assume that we put the intercostal drainage tube and there was air bubbling but not much of blood coming out, say about 300 cc of blood came, and a lot of bubbling and saturation improved up to about 96, 97 now. Now we took a blood pressure recording again, and the blood pressure slightly improved to 110 over 60, and still the pulse rate is quite high. Now again, this pressure is not a normal pressure for a 20-year-old. So this is something going on. Now we have addressed the airway, now we have addressed the breathing part. Now we need to get into the circulation to correct it. Right. I'll just recap this figure. These are theoretical values of classes of hemorrhage, not classes of shock. Shock is shock. If shock is there, shock is there. If shock is not there, it's not there. You can't grade the shock, but we can grade the hemorrhage. Right. So four classes of hemorrhage. Class 1, it is 15% of the blood volume loss, around 750 in a 60 kilogram man. Class 2 shock, again 15 to 30% of loss, approximately 750 to 1.5 liters. Class 3 shock, 30 to 40%, that is 1.5 to 2 liters. And then class 4 shock is more than 40%. So at class 1 and 2, you will see tachycardia, but when it's class 3 and 4, blood pressure may drop, pressure drops, and at class 4, there may not have a recordable blood pressure. So why is this patient hypotensive yet? So what are the causes? If there's now we have sorted out the airway, we have sorted out the breathing issues. So why is this patient hypotensive? Probably the most probable cause, number 1 is hemorrhage, number 2 yet is hemorrhage, number 3 yet is hemorrhage. So in a hypotensive patient, unless proven otherwise, it is due to a bleeding to some space or outside of the patient. So as you can remember, this patient had a large wound in one of the limbs, so that he may have bled from the limbs. So we say that there is 1 on the floor and 4 more. That means you can bleed outside, but you can see, and there are 4 other places that you can't see, but still bleeding can occur. Like example, the pleural spaces. Each pleura can hold up 1.5 liters to 2 liters. So if both pleural spaces or bilateral hemothorax occurs, you can lose up to about 4 liters. That's about 60% of the blood volume. So where else can they bleed? They can bleed into the peritoneal cavity. How much can they bleed? They can bleed basically the entire blood volume into the abdominal cavity. Where else? Chest, abdomen, pelvis. Pelvic fractures notorious to bleed, especially patients on antiplatelets, anticoagulants, and they can again bleed the whole blood volume into the pelvis, fractured pelvis, or even contused sometimes. Okay, so there are others. So we have talked about the bleeding into the chest, hemothorax, bleeding into the peritoneum, pneumoperitoneum, pelvic bleeding, which may be usually subperitoneal, and the limb compartments, the large long bones like the femur. Each thigh compartment can again contain about 1.5 liters. So if both femurs are broken, they can bleed up to 3 to 4 liters into the compartment without seeing from outside. But of course, it will be swollen and tense, though there's no active bleeding. Sometimes there are open wounds also, so you may bleed from to outside, and also it may bleed into the inside of the tissue compartment. So you have to look for any of the bleeding inside. So if you are diagnosed any of these, you can also do, if you are not diagnosed any of these, you can clinically diagnose some of them, but of course you can do a bedside ultrasound, what we call a fast focus assessment for sonography in trauma. Fast, everyone probably have heard this term, fast, FAST. It doesn't mean it's done very fast. It is called FAST, focused assessment in sonology in trauma. So once you do that, you may be able to see intraperitoneal bleeding. Sometimes you can see problems in the lung also, and then sometimes in the pelvis also. So once you have diagnosed bleeding, few things you can do. It's like this, you can see the picture. There's a picture of a bucket which is just hole. So how much you fill into that, you can't keep it filled as long as there are holes. Similarly, if the active bleeding areas, you can't, how much fluids or blood you give into the veins, you can't get the blood pressure up. So you need to simultaneously arrest the bleeding as well as fill the bucket. How do you fill the bucket? You fill the bucket by putting 2 cannulas, or fill the body intravenous compartment by 2 wide bore cannulas, at least 16 or larger. That means gray, white, orange, that sort of thing, antecubital fossa, and you give up to 1 liter of normal saline, or preferably Hartmann's solution, which is warm. Those 2 are crystalloids. You should never give colloids at this time, artificial colloids like starches, etc. You have to give only crystalloids. So you give up to 1 liter, and if it's not still picking up, you may have to start it quickly, send some blood for investigation, including grouping, cross match, and then start blood. If the patient is collapsed already, or we can use O negative blood, which we don't have to waste time on cross match, but there again, it has to be done only if it's in a dire emergency. Okay, that is one arm of the hemorrhage control, that is the bleeding control. So other arm is filling, that is the filling of the intravenous. The other arm is the stopping of the bleed. So these holes have to be stopped in the body. So how do you stop? There are 3 types of bleeding, 3 areas of bleeding. One is the limb bleeding, which you can use. Limb is upper limb and lower limb. So you can use direct pressure, bandages, wound packing, tourniquet, right? You can use a tourniquet properly. Don't use saline tubes or catheters. They stretch. Use sort of a very tough piece of cloth, like a folded bandage, 2-inch bandage, and twist with a pen to get a tourniquet effect. Before using the tourniquet, use the other measures like direct pressure and packing. But of course, use the tourniquet if it is uncontrollable bleeding. It's always a lifesaver. Apart from that, you can, it's a pelvic fracture, you can use a pelvic binder to, in the open pelvis, you can use a pelvic binder to get the pelvic bones together. Of course, if there's intra abdominal or intra chest bleeding which is continuing, we may, of course, you need to get the surgeon involved quickly. So that is also part of house officer's duties. You need to inform your seniors very fast, saying that we have given fluids, but patient is not picking up blood pressure. The patient may need surgery fast, and arrange the theater and inform your seniors immediately. So fill the bucket as well as plug the holes. Right. That is circulation. So this patient, despite 1 liter of his fluids, remains low in blood pressure. So what do? This fast was done, right? So this side you can see the lung feels still not very much, lung is not fully expanded yet. But if you can see on this right hand corner, the picture, this is the ultrasound picture, the heart. Usually you can see the pericardium around it, and if you can appreciate along my arrow head here, you can see there's fluid outside the muscle between the pericardium. That's a condition called cardiac tamponade. The blood is collected in the pericardial cavity. So if the patient is not responding to resuscitation, think of ongoing bleeding from, example, liver and spleen into the interperitoneal space, or think of other conditions like tension pneumothorax or cardiac tamponade. These are also part of primary survey to diagnose and treat. So if you see a cardiac tamponade, you need to put a needle. Of course, you need to get an expert advice on this. This is not a thing that you novice can do. Don't try to stick in needles if you're not being trained to that, because if you go through the heart, you will kill the patient instantly sometimes. So yeah, get your seniors involved quickly and attend to this. So if the blood pressure is not picking up, so one message is, any patients, once you get the hemorrhagic control, once you give the fluids, blood pressure should pick up. If it's not picking up, either it's ongoing bleeding where you can't see, or there's something else like tension pneumothorax or cardiac tamponade. So if this leg, the patient's leg, we told there's a large exsanguinating wound. So what we have done is we have put some packs, pack the wound and bandage the pain, and also use a splint so there won't be further damage to surrounding structures like the nerves and veins and arteries, which cause more bleeding. And also pain will be quite less once you put a splint in. Right. So we are talking about A, B, and C. Now we spoke about D. As a disability, when we take disability, we talk of the GCS, the neurological status. We have quickly looked at the neurological GCS status, pupils of the patient, and whether the ability to move limbs. So only these three things that you need to check in disability. GCS, as you know, there are 3 components. It's not very clear here, but I will say there's a eye-opening component, best verbal component, and best motor component. I don't want to go into details, but these charts have to be printed and kept wherever it's to be seen, because you may sometimes mistake, especially the motor response and all. So when you write the GCS, write the 3 components separately: E, V, M. E, how much out of 4, V, how much out of 5, and motor, how much out of 6. Make sure the dead person has a 3, GCS of 3. That means even a dead person will have response of 1 each. The best score is 15, so you have to write out of 50. Look at the pupils again. You can see the pupil here is dilated. Usual pupils dilate when there are intracranial hematomas developing. If you see one-sided patient who is deteriorating in conscious level having a dilated pupil on one side, there is a very dire emergency. That means there probably may be an intracranial hemorrhage, very likely. So you need to get the patient very quickly into a neurosurgical unit. If there's no neurosurgical facility in your hospital, you need to transfer this patient very quickly, but make sure don't transfer patients who are hemodynamically unstable. You have to give the blood and fluids, get the blood pressure to a reasonable level, and then transfer. Especially during transfer 2, you may have to accompany the patient, and you may have to give fluids and bloods further during the passage if you are taking a long time. Do not pack the patients into a ambulance who have unrecordable blood pressure saying that there's a head injury, because there won't be a patient remaining for you to treat at the receiving end, because they may collapse of hemorrhagic shock from some injury somewhere else. Head injury per se will not cause hypotension. One of the messages that you have to know. If the patient is hypotensive, there is some degree of hemorrhage somewhere else apart from the head injury. Right. So once you've done that, once the patient's A, B, C, D, E has been sorted out and if they're stable, you have to do exposure. That means you expose all the body, remove all the clothing, and look for any other major injuries that you have missed. Maybe there are stab injuries in the front that you have seen earlier, but there may be 2 or 3 stab injuries at the back that these things have happened. So you need to log roll properly using 3 people and to 1 person to examine. So log roll the patient and then have a look at the back, look at the spine, do a rectal examination in relevant cases. And of course, you need to carefully position the patient back into normal position and then cover the patient with a blanket, because most of our A&Es wards nowadays are air conditioned. Where we treat this patient, they can go into hypothermia, even a temperature of like 34. Normal temperature is 37.8, but a temperature of 34 may be detrimental to these patients. And also, at this point, you need to think of that the patient is catheterization, NG tube. If it is necessary, you may have to put them before handing over to the surgical team or before you sending to the normal ward or ICU. You may have to give antibiotics depending on the necessity, and maybe you need to give tetanus toxide or tranexamic acid, which we usually give if there's an ongoing bleeding. Right. Okay. So coming back to the patient. So basically, a patient who comes after major trauma could have any injury from starting from head to toe. Whatever the method of injury, the patients die in a very methodical manner. That means they die of airway problems first, then breathing problems next, circulatory problems next, head injury and disability next. So you go through A, B, C, D, E. You do the same methodology on each and every patient. While you do that, you go through each organ system A, B, C, D, E in that methodical manner. You find any issues. Then you have to deal with that issue before going to the next step in your, like if there's something in the breathing part, you have to sort that out before going to the circulation. So you treat as you find and state, and once the patient is stable and keep stable for few, say half to 1 hour. If the patient is blood pressure, saturation, everything stable for approximately 1 hour, then you can decide whether the patient can go to a ward, or the patient needs to be, if the intubator specially need to go to ICU, or you need to arrange transfer. So till that is done, your responsibility of a major trauma patient continues, and this is one area you can save lives even at your seniority. So don't wait for your seniors to come and do the primary survey. You start doing the primary survey yourself, and whatever measures you can do, learn the intubation technique, learn putting intercostal tubes, and then of course appropriate blood transfusions. You can no doubtedly save few patients during your 6 months of internship in surgery. I also further recommend you to do a course like the NTMC or the ATLS and basic life support systems, preferably before starting. Even if you after starting, speak to your consultant and say, I just want this to be done before it's very important for my management of patients. I'm sure the consultant will say, okay, you can go for 1 or 2 days and get yourself trained. So I strongly recommend all of you all to do that as well. Thank you very much.
Thank you very much, sir. That was Dr. Kirti Abejiva, Senior Consultant Surgeon at National Hospital, Colombo. Thank you very much, sir. If you all have any questions, you can ask in the chat box also. I would like to mention Dr. Keith Bejiva was the first person to start the pre-intern training in 2015. So thank you once again, sir.
Thank you very much. Thank you.
So next up is another interesting lecture by Dr. Narendra Pinto, Senior Consultant Orthopedic Surgeon at National Hospital, Colombo, on the theme of general surgical ward care of orthopedic patients. Over to you, sir.
Thank you very much. A very good morning to all of you. And I know that you all are excited to start this new career in medicine, and you will be called or addressed by the general public as doctors. And so you are going to be the main person in a surgical or a medical ward. So we are dealing with some surgical problems. So the objective of this lecture is to brief you about the management of common orthopedic problems. And now in hospitals, except in base hospitals, you get orthopedic patients being managed in the general surgical wards. There are in main hospital or the provincial hospitals, these orthopedic patients are being kept in separate dedicated wards. But generally, all trauma patients will be, most of the trauma patients will be in the general surgical wards, where you are the main doctor responsible providing 24-hour care to these patients. So this is to expand your knowledge to provide better care for the patients. And it's very important, you should know that even though you are doing a general surgical appointment, you these patients, don't consider these patients as outsiders. So if they are in your ward, it's your responsibility. So it's very important to provide your utmost care to these patients, especially in an emergency. So what is special about these orthopedic patients? Why they are different? Injuries, so when you consider the injuries, the musculoskeletal injuries are the most common problems in trauma. You know that the commonest reason for hospital admission in this country is trauma. And out of trauma, these musculoskeletal injuries are the most common. Then I will tell you a little bit more about the emergency care of these skeletal injuries. And then I will brief you on prevention of infection, because preventing infection is important for you, for these patients. Prompt and adequate treatment of infection, and then you will come across the POP casts, patients on traction, skin skeletal or external fixation, and some of these patients will undergo internal fixation and various processes and assistive devices and so on. So, a little bit about the emergency management of these trauma patients in limb injuries. And it is, I heard that Dr. Keith Bejiva emphasized on the saving life, and saving life in the case of a limb injury is to prevent bleeding. So you should know that the best method of controlling bleeding is direct pressure. Direct pressure on the wound itself, and then you can elevate if it is a hand, you can elevate it. If it is a lower limb even, you can elevate it after keeping the patient on a bed. Then as a life-saving measure, you can use a tourniquet. So if you use a tourniquet, if a wound is large and cannot be controlled by direct pressure, to save life, you can use a tourniquet, but you can apply some tamponade effect and control bleeding. In the case of pelvis, I heard this Dr. Abhiju mentioned, to reduce the volume of pelvis, you have to apply, you can apply a pelvic binder. And for this, I'm showing that this is an open book fracture, and this is the pelvic binder you apply. And sometimes these special binders are not available. What you can do is you can use a bed sheet across over the trochanters, and you have to apply tremendous force, especially if the patient is a well-built person. And this, you can see this person is manipulating the leg. You have to internally rotate the leg, so that will help to reduce this fracture. You can see this when this fracture is open book, the legs will be externally rotated, so it's easy for you to reduce this fracture by applying this traction. Then, in the case of limb injuries, earlier the control of hemorrhage is important to save life, and then once the life is under saved or there is no immediate threat, then you have to think of the limb-threatening injuries. So what are limb-threatening injuries? It's the ischemia. Ischemia, the main arterial, the blood supply, we have to make sure the blood supply is adequate, and for that purpose, you have to check the distal circulation, the distal pulses, and so on. But it is very important that there is another limb endangering component, that's the compartment syndrome. We will come to that. And then just an open wound itself is a limb-threatening injury, because you will find that if the wound contamination and if it is progressed to infection, the patient will, most of the patient will suffer for the rest of the life, and they will be disabled. So vascular injuries, extremity injury management, the control of bleeding, direct pressure I mentioned. And when you get an open wound of a limb, always it's very important for you to take a photograph and cover the wound with some clean dressing. This is to prevent hospital-borne infection, because even though the wound may be contaminated in the field, but those organisms are not, it will be sensitive to most of the simple antibiotics, but hospital-borne infection, these are multi-drug resistant flora, so you must prevent this. You should not open the wound to show the your seniors. You can show them the photograph you have taken. So it's very important, and then you have to splint the limb to prevent further bleeding and to prevent further damage to the other important structures. So thereby you can control the pain, but pain you can give, to control the pain you can give analgesia, provided if the patient has no other head injuries and so on. And then you assess the soft tissues and the nerves clinically. So it's very important, any limb injury, check and compare the distal pulses. It's a must. And you have to compare, because just because you feel a pulse, that doesn't mean that the circulation is adequate, because it may be an impending obstruction. Now, if the initial injury has damaged the intima of the blood vessel, it can form a thrombus, and eventually at the time of with examination on admission, the pulse may be there, but after when you send the patient to the ward and to the bed until the he is taken up for surgery, this clot can form and block the arterial supply. So therefore, it is important to monitor the pulses in vulnerable cases. Say vulnerable cases means there are certain cases. Say for example, supracondylar fractures of the humerus and supracondylar fractures of the even the femur. So these are, there's a dislocation of the knees also. They have very high chances of vascular damage. Then remember to check for compartment syndrome. Compartment syndrome, you check the consistency of the muscles, and the best example is the calf in the leg. These are the most important places where the compartment syndrome can occur. And you should never forget that distal pulses are present in compartment syndrome until the last stages. If the distal pulses become absent, then the whole leg will be, the muscles will be necrosed, because the muscles rely on the capillary circulation, where the blood pressure, the capillary pressure is 40 millimeter of mercury, whereas the artery is pumping blood at 120. So that's important, and it's very important to assess this clinically. You don't have to wait for any pressure studies. You feel the pulse, check the consistency of the muscles, and if there is any suspicion, you have to inform the authorities, the higher, the seniors, and don't wait till the morning occurs. And another important thing is, the main complaint is undue pain. Even though you have splintered the fracture, there can be, if the patient is still complaining of pain, and you can move the fingers to see, fingers or toes to see, there's some, if it is painful for passive extension and flexion, then you have to suspect as a compartment syndrome, and this needs urgent decompression. So the places to check the pulses you should know, and if you can feel the radial pulse, that means at least the pressure is about 80 millimeter mercury. And if the radial pulse is absent, and if only the femoral pulse is felt, so that means about 60 millimeter mercury. And the last pulse to be absent is the carotid pulse. If the carotid pulse is fairly, just palpable, that means at least the pressure will be about 40. These are clinical rule of thumb, so you can make the decision easily. These are the pulses, how to check, and it's very important to compare with the opposite side. And capillary filling and the clinical size, and it's important to monitor. I'm emphasizing this again and again, because if you practice these guidelines, you can save a lot of limbs. So if there is a vascular injury, the time period you can have is to save this limb is 6 hours. 6 hours start from the time of the injury, not from the time of the admission. Therefore, always it's important to write the time of the accident in hours. Say this happened at 6 hours in the morning, and that sort of thing, 6:30 and so on. But again, just because you have 6 hours, that doesn't mean you can delay it until you have your breakfast or whatever. So you have to act fast. Physical examination, Doppler checking, if it is available, you can check it, but just because the Doppler pulse is available doesn't mean that the limb is out of danger. So it's important to inform the vascular, the specialized care. About the open fractures, I said open fracture is an urgent needs urgent attention. It may not be urgent as a, say, bleeding abdomen or contaminated or ruptured bowel, this thing, but it has to be also addressed. You can't delay it more than 6-8 hours, because if a contaminated fracture means there is no infection. If you leave it like that for more than 6 to 8 hours, the bacteria will start multiplying and you can cause infection. It's very detrimental to the fracture. Just to mention about this Gustilo-Anderson classification, grade 1 is a small puncture wound and grade 3 is more than 10 centimeters. Now, if there's a vascular injury, it is 3C, and if you need plastic help, it's 3B. And only the orthopedic surgeon or a general surgeon can manage 3A fractures. So anything in between is grade 2. So then prevention of infection. Infection is important in orthopedic practice, because if you get a infected wound or the bone or a joint is infected, that can become, if it goes into a chronic stage, it can be lifelong suffering. So, and sometimes after you do any internal fixation or replacement surgery, sometimes you may have to remove these expensive implants and the patient will be in misery. So the infection should be prevented at all costs. So these are some of the points you should know about infection when you deal with these patients in the ward. So always separate the infected cases and from non-infected cases. So infected patients should be at a separate corner. Don't keep the fresh wound or after DHS or osteotomy hemiarthroplasty, these type of patients with those infected cases. There can be cross-contamination. When you are dressing a wound, get the nurses to start from the clean patients and then go for the infected patients. So these things you should know, and if this is not being practiced, you have to direct them. Then for these prophylactic antibiotics we use for cases where there are going to be internal fixation and so on. And if the patient is going for a, say, hemiarthroplasty or a major case, so you have to use antiseptic baths, Hibitane or betadine. Then shaving and painting. It's important. Shaving should be done that at the time just before the patient is sent to the ward, not the day before, because sometimes you can get small abrasions can be source of infection. And look for possible infective foci anywhere in the body and tell the seniors that there is a wound like that and so on. So if there is infection, then you should use IV antibiotics, appropriate provisional basis first, and then after the culture ABSD, the specific antibiotics, and monitor the progress clinically, and as well as ESR, CRP, and you should do some regular cultures. And for bone infection, the period should be prolonged, and sometimes we use antibiotics for 6 to 8 weeks. The plasters. So you should know about the various types of plasters, and the use of back slab is, you can use back slab for stabilization of upper limbs, but this back strap is not enough to stabilize a fracture of the lower limb. It's very important. You have to apply 3/4 straps. 3/4 strap means on either side also there are straps. Now there will be a strap going round that and from behind a back strap. So if it's a full plaster cast, these things you should know about the complications. So if the plaster is tight, you know that there can be external compartments in room, and the tight plaster can cause increased pressure and causing muscle damage. So if you suspect, if the patient is complaining of pain after putting the plaster, always think of this and move the toes to see. And even if the capillary circulation is there, it's not an indication, not a reassurance for a plaster is okay. So always, if it is a full plaster, you have to cut it from one end to the other end until you see the skin. It's very important. And then prise it open so that the patient will get immediate relief. So checking, then dressing through the window and closure is also important. And this is a 3/4 POP. And you can see this full plaster, and supposing if there is a wound, you can cut a window. When you cut a window, you should not cut a window just after applying a plaster. But you have to wait until this is at least 2 days. When the plaster is dry, you can cut it nicely. And when you open this wound and dress the wound, and it's very important to pack it tight. Otherwise, there will be edema at this point, and there will be delayed wound healing. Then about the skin traction, you should know about how to apply this sticky skin traction. But if it is what is available is sticky plaster, so in that situation you have to shave the leg and apply these things. Before that, you have to inquire from the patient whether they are allergic to plaster and so on. Then how to maintain weight, balance, traction is important. So usually after when you apply traction, you have to elevate the foot end so that there will be counter traction, and otherwise the patient will drawn to the edge of the bed. But you should avoid head-low position in all patients. In that case, I mean, you can prop them up from the hip onwards. So these patients should be given chest physio, and pressure areas should be managed and checked for any possible pressure source, and don't wait for the wound to appear in the legs. So check whether there is redness, and in that situation you have to apply padded dressing, padded glove, soft material, especially in this area and this area over the head of the humerus. In small children, you can see we apply this. These are specialized ones, so you don't have to worry too much about this. And skeletal traction. Skeletal traction, when we want to apply heavy traction, we apply these Steinmann pins through the bone so that we can apply more than, say, even 20 or 30 pounds. For skin traction, we can apply only about 10 to 12 pounds of weight. Nowadays, in commercially available non-stick traction kits are also available. So you can make use of them in the case of a, say, fracture neck of femur, applying temporary traction. Yes. Then the grade 3 or 2 fractures are being managed with external fixation. If the external fixation is applied, it's important to check for pin site infection and dress it or prescribe antibiotics appropriately. These are the external fixation for the pelvic fractures. Again, the pin site infection should be checked. Then the general care of traction patients, when they are tied to a bed, they get disturbed psychologically. So you have to provide counseling, speak to these patients, give chest physiotherapy. Abdominal constipation is important. Make sure that when you do the round, whether the patient has open bowel and so on, and prescribe appropriate laxatives or enemas. The urinary catheters are important. Bladder should be checked regularly, even though they say pass urine. You have to check the bladder, otherwise you will miss a retention with overflow. Then urinary catheters, you should check the bag. The bag should not be on the floor and it should be elevated on a protective covering. DVT prophylaxis, sometimes not every patient needs this, but applying pressure bandages and exercises important. And remember, UTI can cause confusion in old patients. So internal fixation, there are various types, iron nails, plate screws, and we use cement, so on. These are hemiarthroplasties, total hip replacements. So these things you should be familiar, and now it's very important after putting a plaster. If somebody says to discharge the patient, you have to make sure that you provide these walking assistive devices for walking and make sure that you train them on how to use these. It's very important to inform the physiotherapist to train them on walking. Otherwise, they will be bedbound at home. These things are important, giving toilet advice on going to the toilet and so on. So therapists are available, usually it's physiotherapists, but occupational therapists and social care workers are available in provincial hospitals. So you can make use of this social service person if the patient is a destitute and you can't, without any help, to provide some facilities, you can call them. It's important. So safe discharge and review is important. Just because if the consultant says this patient can go home, don't write discharge, and the patient doesn't know what to do. The relations come and ask the nurses. The nurse say that ask the doctor, and the doctor is not available for them to ask. So you have to give specific instructions. Make sure give the proper diagnosis card and so on. And it's important to fix the next appointment to the clinic. It's very important to ask the patient from where he is, because some patients are coming from far away. So don't discharge them and get them back to the clinic to remove the sutures in 2-3 days time. These patients find it very difficult to find transport and so on. The previous one is a developed country setup where they will arrange the ambulance even for the clinic follow-up by the hospital itself. But the story is different in our cases. They get abused and they had to pay bribes and so on at the clinic. So you have to be empathetic. Always think of patients' welfare. Priority should be patients' welfare and not doctors or healthcare workers' welfare. If there are 4 2 or 3 interns or doctors, all should be there to provide these facilities. Don't take turns. So it's very important to share the burden equally, respect patients, visitors, And you have to respect the fellow healthcare staff, the nurses, even the minor staff. If you respect them, they respect you. So all the very best. Thank you very much.
So thank you very much, sir. If you all have any questions, we can take 1 or 2 minutes to answer the questions. Right, that was Dr. Narendra Pinto, Senior Consultant Orthopedic Surgeon at NHSL. Next up is another important lecture by Dr. Duminda Ratna, Senior Consultant at National Hospital, Colombo, on a bleeding patient in a ward. So we start in a few minutes.
Good morning, everybody. Good afternoon, rather. My topic is to talk about bleeding patients in the ward. Certain components of this talk has already been discussed by Dr. Abhijiva and Dr. Pinto and so on. So it makes my life easy. So we will basically look at what the bleeding patient looks like and how, as house officers, blooding house officers, you all can make a change to the patient's well-being and survival. So let's start with the bleeding. In this forum, we are just going to concentrate on this talk primarily on bleeding following trauma and GI bleeding and post-operative bleeding. This is what you would encounter in the wards. There are two kinds of bleeding, very broadly speaking. Externally evident bleeding, where you will see blood pouring out of the patients from wounds as well as from natural orifices. In the case of hematemesis, you will see blood coming out, patient throwing out blood. And in melena, you will see the patient is passing tarry black stools. In trauma, of course, in most of the situations, you will see the blood being coming out of the wounds, traumatic wounds that the patient may have sustained. Sometimes, nevertheless, the bleeding is not always externally evident. Particularly in trauma, there are 4 sites where the bleeding is concealed or hidden. These 4 sites where the patient is showing evidence of exsanguination, but there's no evidence of bleeding externally. One has to think of these 4 components in the body where the blood can accumulate without manifesting externally. Inside the chest, in one half of the chest, in like one hemithorax, you can collect up to 1.5 liters of blood before it's manifested externally. Inside the abdomen, again, it can bleed in case of trauma with liver lacerations, splenic lacerations, and so on. The patient will have a lot of bleeding, but it will not be externally evident. Same goes for pelvis as well. Pelvis is a bony compartment. There's a pelvis plexus of veins which can rupture, and these are low pressure system, very difficult to control bleeding. That will bleed retroperitoneal, and you will not be able to see this bleeding externally. Same goes for long bones. In the fracture of a thigh bone, like a femur, you can bleed about 1 liter with very little or minimal increase in the diameter of the thigh. So this is what the 4 sites that you have to remember where the bleeding is not externally manifested. In GI bleeding again, before it is shown in the form of hematemesis and melena, a significant amount of blood can collect inside the bowels. So these will not be manifested until the patient will show externally evident bleeding. In case of hematemesis, the patients will vomit out blood, fresh blood with clots, or sometimes little altered blood, or coffee ground like blood due to being reduced with acidity in the stomach, or else per-rectally they will pass melena stools if the bleeding is quite big coming from the upper GI. If the bleeding is so voluminous, sometimes you may see fresh bleeding passing from the anus in patients even with upper GI. So bleeding from the upper GI can also not necessarily be melena, particularly if the bleeding volume is high, it will go as clotted maroon color blood. And bleeding can also occur from the gut from diverticular disease in the large bowel, Meckel's diverticulums, abnormal AV malformations, and so on, where the bleeding will be fresh coming from the rectum. So other thing, post-operative bleeding, it is very important. Sometimes it will not be shown on the surgical wound, but because the surgical site is generally covered with sometimes bulky dressings. So the bleeding is underneath the skin, and this site probably would be covered with a dressing. So unless you open up the dressing or feel around the site of the surgery, you will not be able to see this bleeding. Sometimes the bleeding may be intramuscular. For example, in a case of a mastectomy, it will be under the flaps, and you may have a pressure dressing over it. So you will not be, unless you remove this pressure dressings, you will not be able to see the bleeding inside. Same goes for intestinal operations, where the bowel operations, laparoscopic cholecystectomies, and so on, where the bleeding has taken place inside the abdomen, and it will not be really evident externally. Now here I have taken a picture of a hemothorax, where the hemithorax is filled with blood and a formal chest drain has been inserted. In a case of a thigh hematoma, this is a fair skin person. You can see it will only show as ecchymotic patches, indicating that there's bleeding underneath the skin. So what are the clinical features of a bleeding patient? This is very important from a house officer's point of view, because you will only be able to see these clinical features and think that this patient has bleeding somewhere, although it's not externally evident sometimes. Patient will be restless and agitated. Why is this restless and agitation? Is because low blood pressure as a result of bleeding would cause cerebral hypoxia. Cerebral hypoxia will make the patient restless and agitated. If you have a look at his skin color, it will be pale. Conjunctiva will be pale. Tongue would be pale. And if you feel the patient, it will be cold, clammy extremities. These are actually, all these features that I mentioned so far are features of a voluminous bleeding, a significant amount of bleeding. But the earliest sign would be tachycardia. A tachycardia coming from a post-operative patient, a trauma patient, until proved otherwise, is bleeding. It could also be as a result of anxiety. It could be also a result of a pain, but just make sure that you exclude bleeding in these patients. They also will have hypotension, and the blood pressure would be lost. They will try to take in more oxygen to deliver more oxygen with the little amount of hemoglobin that they have, and as a result, they will have an increased respiratory rate. And if you catheterize the patient, you will find the urine output is dropping gradually. This is a chart I'm sure you would have been exposed to during your medical student days. There are 4 classes of hemorrhages in physiology and pathology. I'm sure you must have been taught about this. The class 1 hemorrhage is where the blood loss is about 15% of the patient's body weight. Class 2 is about 15 to 30% of the body weight. Class 3 is 30 to 40% of the body weight. And class 4 is where at more than 40% of the blood volume of the patient has been lost. Now, in the first scenario where class 1 bleeding, 15% of blood loss is 750 ml of blood has been lost in the patient. This patient, mind you, would not show even tachycardia. If you remember, some of you may have donated blood. This is the amount of blood that you would donate, and roughly around that time, 400 ml or so, you wouldn't have had a tachycardia, you wouldn't have fainted, you wouldn't have had a blood pressure lowering or anything like that, or you wouldn't have been increased respiratory rate also, because this is something that the body compensates in healthy individuals. So these patients, of course, you can manage with crystalloids like normal saline or Hartmann solution. In class 2 hemorrhage, when the bleeding exceeds about 750, then only the tachycardia sets in. So it's very important for young house officers to remember that a person showing tachycardia is probably would have lost about 750 ml blood or more. So there, of course, you will have to think of giving him crystalloids plus take blood for grouping and cross-match and be ready to transfuse if the bleeding continues. The third component is where the bleeding has been more than 30 ml, and in terms of volume, 1500 ml. A patient who has started to drop the blood pressure has lost minimum of 1.5 liters from his system. So that is, you have to remember very, very importantly that these figures, that the person who is showing tachycardia has lost about 750. The minute the blood pressure starts dropping, the loss is more than 1500 ml. And if the patient is showing markedly decreased blood pressure and a tachycardia, significant tachycardia, is lost about more than 2 liters, and he is going to die within the next few minutes until or unless you replace his lost blood volume. So this is something for you all to remember, and it's very difficult for you to remember the entire chart, but just remember the facts. These are the facts that you have to remember. A patient can lose up to 750 ml of blood without even showing a tachycardia. A patient having normal blood pressure still can lose, would have lost 750, which is quite a significant volume. The tachycardia develops at 1500 ml of blood loss. So just be aware of these figures. When the blood pressure drops, the loss is, if a patient drops blood pressure, that means he has lost more than 1500, where you have to act very, very vigorously. A patient with rapid ready pulse and critically low blood pressure, I'm sure you will be exposed to such patients. You will have to act within next few minutes to save his life. So immediately in these kind of patients, you will have to go for blood transfusions. So how would you manage it? Now you have identified the bleeding patient. You have already diagnosed the bleeding patient, and you are aware of the fact that some of the bleeders are not going to show externally, but you go by your clinical parameters and suspect it. You take the pulse, BP, respiration, and so on, and then you can have a rough idea as to how much this patient would have lost. And then how would you manage it? Management is calling for senior help. You have to inform your seniors, your senior house officers. If there are registrars, you have to inform the registrars. If there's a senior house officer, you have to inform the senior house officers, senior registrars, and none of them is contactable. Immediately call the consultant. Don't hesitate to call the consultant in such situations. You can bypass all these channels and call your consultant direct, and no consultant will ever find fault with you for calling him on these circumstances, under these circumstances. So how would you arrest obvious bleeding? I heard Dr. Pinto was telling you to elevate and apply direct pressure. That is what you can do. You have to have good airway access. Make sure that his breathing is okay. You have to give oxygen via face mask. Give as much oxygen as you can. Don't give 20%, 30%, 40%. Give the highest volume of oxygen that you can give the patient. And very important to put wide bore cannulae into both forearm veins, not elsewhere, but to the forearms, because in the forearms, the delivery of fluids to the system is quite fast. So therefore, you have to remember that you give blood through wide bore cannulae. What are these wide bore cannulae? 14 or 16 cannulae, right? Into forearm veins. I will show them the color of those cannulae in the next slide. And then take blood for grouping and cross-match. Don't ask for 2 units, 3 units. Straight away ask for, if the blood pressure has dropped, ask for 4 units to 6 units. You take the blood for grouping and cross-match. Do take the blood for serum creatinine, serum electrolytes. And when you write these forms, particularly for grouping and cross-match, you write on the form to say life-saving emergency. You don't write as urgent, you write as life-saving emergency. Get somebody to call the blood bank and say that there's a life-saving emergency in the ward and I'm going to send you the grouping and cross-match. Please give me as urgently as possible the blood, right? So you don't need to run to the phone to do that. You can ask a nurse or somebody to do it for you, but make sure you fill up the form. Filling the form is your duty. You fill up the form to say, in red lettering, you write on the top of the form, life-saving emergency. Okay. So then until the blood is getting ready, you start with crystalloids, which is normal saline or Hartmann's. This is what the HO should be doing, right? So this is a picture of the airway, because unconscious patients who are collapsed as a result of hemorrhage will have their tongue falling back on them and causing airway compromise. People who snore at sleep, fellows who snoring at sleep have the same situation where the tongue falls back and the breathing gets compromised, airway gets compromised. So to prevent that, you put this what is called oral airway, and then you can give oxygen via face mask. These are the cannulae, right? So what I would want you to do is to remember these color code of the cannulae. Without looking at the cannulae, the literature on the back of the cannulae, you will see the orange color cannulae is the 14 gauge cannula. If you have a gray colored cannula, that is 16 gauge. If you have white cannula, that is 17 gauge. If you have a green cannula, that is 18 gauge. If you have a pink cannula, that's a 20 gauge. Blue is 22, yellow hardly ever used, unless in pediatric patients, it's 24. So in trauma patients, what you should try to use is orange or gray cannulae, right? This is what you should be trying to put in the patient into forearm veins, not elsewhere, into the forearm veins, right? And that is where the fluid delivery is the fastest. You have to put 2 cannulae into each forearms and simultaneously give fluids and blood. So these are the crystalloids, normal saline. This is how it would look. The Hartmann's packet would look like this. Okay. And then there's another phenomenon that I would like to tell you when you give blood transfusions and fluid transfusions, normal saline infusions. We don't raise the patient's blood pressure to his previous normal blood pressure. We always try to maintain his blood pressure a little lower than normal until his bleeding is controlled. In other words, if the patient is continuously bleeding until he's taken to the operating theater, we don't raise his blood pressure to 120/80. Because if you raise the blood pressure to normal levels, the blood vessels, the peripheral blood vessels which have contracted will open up and they'll start bleeding again. The clots will get dislodged and the patient will start to bleed again and again, and you will continue to give blood transfusions. And you will have all the complications of massive blood transfusion. Therefore, until the bleeding is controlled by what surgical methods or some other methods, you don't raise the patient's blood pressure to normal pressure, but you will try to make it at a systolic pressure of about 90. This is called hypotensive resuscitation. This phenomenon is called hypotensive resuscitation, where you only perfuse the vital organs. The vital organs are the heart, brain, lungs, and kidneys. This is a very transient period until the patient is taken to the operating theater. Therefore, this is within these few minutes, you try to maintain the patient's blood pressure at systole 90 until the patient's hemorrhage control is achieved, and then you can go back to his previous blood pressure levels. One small thing to remember here is that if the patient has head injury, then of course, nevertheless of this phenomenon, you will have to increase the blood pressure to his normal levels. Therefore, that is something that you have to remember. In patients, I told you like class 3 and class 4 hemorrhage. Class 3 is where the blood pressure starts dropping. The patient who is bleeding and dropped the blood pressure needs blood transfusion. He is not a candidate for continuous crystalloid transfusion. Any person who has dropped the blood pressure requires early blood transfusion. Class 4, of course, needs blood transfusion, and that blood does not necessarily be patient's own blood group. This blood could be, you know these patients, the universal donors, which are O negative. If O negative blood is not there, you give O positive. It's okay. You can just manage the transfusion reactions later. But if the patient's own, we have no time to go for own blood, patient's own blood group, in patients who are collapsed, you start with O negative blood transfusions and then try to get into his proper group when it is available, because blood grouping and cross-match takes about 20 minutes. These patients in class 4 hemorrhage, where the patient's blood pressure is dropped, is going to die within the next few minutes until you transfuse this lost blood. So always go for O negative blood in patients who have collapsed and markedly dropped their blood pressure. And then another few minutes about preparing for the theater is to inform the consultant, inform the operating theater, inform the anesthetic team, keep the patient cast in, do the basic investigations, and send the patient to the theater. And one drug that has been proven to be of value is tranexamic acid. Tranexamic acid is the only drug that has been proven to be of value in controlling hemorrhage. You have to give about 1 gram bolus over 10 minutes, follow it up with 1 gram infusion over 8 hours. That is the only drug that has been proven to be of some benefit in the bleeding patient, not any other drug. So when we talk about transfusions, we only transfuse red cells. We think about red cells, but how about the platelets? How about the clotting factors? The platelets survive only 3 days in storage. Clotting factors are depleted in a single day. So when you continue to give blood transfusions, we only give red cell concentrates, and the patient's clotting and bleeding control would be a problem because platelets and clotting factors are not being transfused. So patients will also have bleeding clotting problems when you give massive amounts. I will come to that in a minute. But again, other complication is hypothermia, because you are transfusing the patient blood stored at a refrigerator, or the blood which is at the room temperature. Patient's body temperature is 37. The room temperature is 24, even on a warm day, 24, 25, 26. So therefore, the patient will be pushed to hypothermia. They will have transfusion reactions, and heart failure patients will have fluid overloads, but not many will have heart failure. So it's in extremely life-threatening conditions where you give massive blood transfusions. In extremely life-threatening conditions, the patient's blood volume, that is 10 units, is given within 24 hours. If you give half of the patient's blood volume in 8 hours, that patient will fall into the category of massive blood transfusion. Here, they will have all the complications of transfusions, including coagulopathy, hypothermia, electrolyte disturbances, hypokalemia, alkalosis, and so on. So that is something that you have to bear in your mind, and you have to inform the blood bank doctors as the house officer that we are going to give a massive transfusion to this patient, and we are hoping to give a large volume of blood. So please activate the massive transfusion protocol. Every blood bank has a massive transfusion protocol where they will try to give you blood and platelets and FFP in separate boxes. You will give the red cells, along with that you give the platelets, and along with that you will give the FFP. The blood bank doctors will send you blood and blood products in separate boxes to be given. Give this box first, give the second box next. This is the third box, and so on and so forth. Until that is being done, as house officers in massive transfusions, you can give 1 unit of FFP, 1 unit of platelets with every single red cell concentrate that you transfuse. So make sure that if a patient with polytrauma and you are anticipating to, especially a patient in class 4 bleeding, you will have to inform the blood bank that this patient is going to go for a massive transfusion, and please activate the massive transfusion protocol. So few points about the upper GI bleeding. Esophageal varices, peptic ulcers, malignant ulcers. These, especially esophageal varices, occur in patients with liver disease, liver compromise, chronic liver cell disease. So you have to correct their coagulation. If the patient's on medication, which the patient's platelets are being depleted, you have to correct those and you have to work in harmony with your medical transfusion specialist, hematology colleagues. Start pantoprazole, bolus, followed by infusion, and try to maintain hemoglobin at least by 8 and prepare for upper GI endoscopy. Here are a few pictures you can see. These are these worm-like structures are the esophageal varices. That is how they look on the endoscope. These varices are no different to the varicose veins that we have in the legs. Only difference is that this is covered only with the mucosa. So it can easily get ruptured and cause torrential bleeding. In this image, you can see an ulcer spurting blood. So this is a spurting blood bleeding from a peptic ulcer. The ulcer has eroded into a blood vessel and that is spurting blood. So these situations can only be controlled by endoscopy, not by your blood transfusions. Blood transfusions and stabilization is in your hand, but definite hemorrhage control requires endoscopic evaluation. So this is the take-home message for you guys. Definitive treatment of bleeding is to stop the bleeding. Elevate direct pressure and pelvic binding, application of tourniquet. All these has been mentioned to you, right? Be aware of concealed bleeding or hidden sites of bleeding, as I mentioned in the first few slides, inside the chest, inside the abdomen, inside the pelvic cavity, and inside the long walls, around the long walls. Start fluid resuscitation with crystalloids through 14 gauge, that is orange, or 16 gauge gray color cannulae. Start early blood transfusions in class 3 and class 4 hemorrhage. Class 3 and class 4 will have blood pressure dropping. So whenever a patient with bleeding dropping blood pressure, which means it's a class 3 hemorrhage, when the blood pressure has been markedly dropped is class 4. These two categories of patients where the blood pressure has started to drop, you will have to give early blood transfusions. Your saline or Hartmann's is not going to sort him out. Aim at a systolic blood pressure of 90, I told you that is called hypotensive resuscitation, and until the patient is taken to the theater and some intervention like endoscopy or whatever where the bleeding is stopped. Until that is stopped, don't raise the blood pressure too much. Okay, that concept is called hypotensive resuscitation. This is a very, very temporary situation. If large volumes of blood are transfused, activate massive transfusion protocol, let the blood bank know that you are going to give a lot of, you will require a lot of blood, and they will activate the massive transfusion protocol by them. And the other important thing to remember as house officers, if the patient is not stable, please do not transfer the patient to a specialized center. That is something very, very important for you to remember, because a lot of patients die on their way to a bigger center. So you will try to stabilize the patient. Do not transfer until the patient is stabilized. You keep the patient in the ward, and if you can't stabilize, no transfer of that patient. Thank you very much. So there's a question, sir, what about we do if I'm working in a hospital without a blood bank in class 3 or class 3 patient came? Generally, house officers are appointed to hospitals where there are blood banks. Sometimes in peripheral hospitals, you will have a blood bank, but there will not be any medical officers attached to it, particularly at night. So all of you will be taught how to do grouping and cross-match. You will be given that exposure once you are appointed to those institutions. No sooner you start your internship. So most important thing is to try to get the group specific blood. Initially, you try to give O negative blood and try to do a DG. And if it takes time, you have to give O negative blood, particularly in class 3, class 4 hemorrhages. In this situation, if a patient comes with a massive blood loss, let's say a trauma patient or post-operative patient or a hematemesis patient, you don't run to the blood bank. You call your colleagues, probably in the accommodation or hospital or somewhere else. Please do come. There's an urgent requirement for blood. You go to the blood bank and get these bloods for me. So you don't run away from the patient. You get your colleague to go and do the blood. Every hospital will have a blood bank, and house officers will not be appointed to any hospital without a blood bank, to my knowledge. I think that's all about the questions. If there are any further questions, you can always send it us. We will try to reply you and wish you all the very best for a happy and successful internship. Thank you.
Thank you very much, sir. That was Dr. Dumitagata, consultant surgeon at National Hospital, Colombo. So the next lecture is by Dr. Mahinda Mallava Tantvi on septic surgical patient. Sir, can you hear?
Hello, I'm just checking my.
Yes, sir. It's working.
Yeah, it's working, right? Okay, let me share the presentation. Okay, are you clearly getting my voice as well as the presentation?
Yes, sir. We can see full screen. Yes.
Yeah, the thing is that the last time we have some problem with the video because this area it is not very good with the internet, right? So I'm using a mobile device, and so I will be switching on the video in case if there's a problem. I'll be switching it off again, right?
Right.
Is it all right?
Yep. We can start, sir.
Right. Good afternoon, everybody. It says that it's septic surgical patient because we are surgeons and we talk about surgical patients. But in your case, I think sepsis is everywhere, right? Whether it is a medical patient, whether it's a surgical patient, obstetrician patient, pediatric patient, there is no difference in this sepsis and its complications. So why you should know, because that you are the first contact person with the patient as well as the other staff and your unit doctors, including SHOs, registrars, your consultant, as well as your senior registrar. Right. As you see, with all the advances in surgery, all the advances in antibiotics, surgical equipment, still we have large number of patients getting affected with sepsis, and it's almost 1/3 of all the cases of sepsis that you see in a total number. Sepsis is the leading cause of morbidity and mortality among surgical patients as well. Like you have patients dying of heart attacks, you have patients dying of the other medical problems, but out of all, the sepsis carries about large number. And out of all these surgical sepsis, intra-abdominal infections are the main source of sepsis when you go for the numbers. And when you talk about the severity, you see the minor infections, you see minor wound infections, it may causing transient bacteremia, or it might go into the more severe status, what we call as sepsis or septic shock. So when you talk about sepsis, what happens? You get an infection, mostly it's bacteria, that it causes a serious body reaction, the body responds, and ultimately it ends with multi-organ dysfunction, and it's a life-threatening condition. So why it is life-threatening? Once you get to the extreme
condition of sepsis, there is no point of return. So much of organ dysfunction leading to death ultimately. So it's very important to identify early. You identify early means that it helps in management and a better outcome. So why me as an intern? Right? As I told you, you are the cornerstone. You connect everybody, the unit, the doctors, nurses, and the other staff and the other teams as well. So we should try and prevent as much as possible of a patient going into sepsis. So while in the ward, that is your responsibility. And when they come to the ward, they may not be in any problem. They are perfectly well. While in the ward, they get infections. After a surgical procedure, it may be a special imaging procedure, it may be a endoscopic, laparoscopic, open surgical procedure. Then you can get infections leading to sepsis. So you need to suspect, anticipate patients who have high risks to get infections and sepsis. When it comes to the sepsis and its treatment, it's quite complex. It includes a lot of teams putting their inputs in, not only the surgical team, anesthetics, maybe intensivists, microbiologists. Everybody had to put their inputs together to get a better outcome. So we need to give them adequate time to act. So we have a window of opportunity, or we call this as a golden hour in management of sepsis. So when you treat sepsis, you have to confirm that it's a sepsis. So you need to recognize it early. You need to confirm your diagnosis. And then you need to start your treatment very aggressively, doing everything possible to knock down, setting this patient into multi-organ dysfunction or septic shock. So when you get these things controlled early, you have enough time to act on the cause of this infection and sepsis. It may be a leaking anastomosis, it may be a collection in the pelvis, it may be a chest infection with some pleural collection. So all this will help you to get this patient stabilized for further management and act on the cause. So what are these causes for surgical sepsis? So it is not surgical. In other units also it's the same, right? You get chest infections, wound infections, urinary tract infections. They may be having a catheter or not. You get urinary tract infections. When patients come to wards, sometimes they don't take enough fluids. They are older people, right? Very easy to get urinary infections. They may be having existing problems like prostate enlargements, bladder outflow problems, right? So you can get collections following surgery, or maybe accidental injury to intra-abdominal viscera, which you have noticed, right? So it may be a perforated peptic ulcer. You get collection, leaking slowly, making infection around, leading to sepsis. So it may be deep vein thrombosis, giving trouble, or cannula site infection, or central line infection. So your patient, you need to see and then check whether they are having this. Check about everything. So it's easy to remember. There are 7 C's that you need to go through. So when to anticipate? As you have heard earlier lectures, right? Polytrauma, injuries with major blood loss, or operative procedures causing a lot of blood loss, and hypovolemic status, prolonged surgical time. Your unit doctors will tell you, your seniors will tell you, this has taken unusually long time. It was a difficult case, and then blood pressure went down. We had to go on inotropes, and then we had to pump fluid, blood, right? So you need to anticipate these patients probably will end up with sepsis. And then there are uncontrolled medical problems like uncontrolled diabetes, elderly people coming into hospital, malnourished patients, patients with immune compromised status who are on steroids, immune compromising drugs, patients who had transplants who are on drugs. So how to find the source? Where is the infection? So it then comes to the imaging and investigations. So you need to do your urine. If it is positive for pus cells, you go on doing a urine culture and ask for an antibiotic sensitivity test. You do a chest X-ray. You do various swabbing. If it is a wound infection, when there is a discharge from somewhere, you send that swab for culture and AVST. And you check for these operative site dressings. Also, you studying inside with imaging. Might have to do a CT scan or ultrasound scan. This will help you to find out collections, hematomas, and you sometimes might have to do a cerebral spinal fluid assessment by doing a lump puncture. Might have to do a stool culture, especially when there is a diarrhea, when there is unusual abdominal distension with bloody diarrhea. So you do investigations to find the cause, as well as you do investigations to assess the severity and effects of the sepsis on the body, the organs, the system. We do full blood count, CRP, blood urea, electrolytes, serum creatinine, liver profile, clotting profile, including PTINR, blood glucose. You do lactate levels, blood gas analysis. Lactate levels and blood gas analysis is very helpful for you to see the severity and then whether you need ventilatory support, whether you need any specific management in a specialized unit, high dependency unit. So apart from the investigations, how you assess the severity of the sepsis? So you have scoring systems. One is SOFA score, which is sequential organ failure assessment score from 0 to 4. We have another SOFA score, as you know, that between Sri Lanka and America. It's a military agreement. This is not that military agreement. This is sequential organ failure assessment. So here you see the neurological assessment that you check for the level of consciousness. You do assess the respiratory system, that is by oxygen saturation, respiratory rate. You do a cardiovascular assessment by doing mean arterial pressure, whether you are using inotropic agents. You do liver functions or liver profile, you do serum bilirubin level. And then in blood, you check for platelet count. In renal assessment, you do check urine output and serum creatinine. This is a very complicated assessment where you have multiple components involved. It has a lot of lab tests and it takes time. And this is good for specialized settings like ICUs and HTUs. So what you do in the ward, right? You have a way of doing what you call as QSOFA, that is quick SOFA assessment. It has 3 points. What you do is that you check for respiratory rate. If it is more than 22 per minute, you give 1 point. You check for the level of consciousness. If patient is not responding well, conscious, not drowsy, right? It's not doing well, you give 1 point, and you check for the systolic blood pressure. If it is less than 100 millimeters mercury, you give 1 point. So it's easy, it's quick, and you can do it at bedside without any specialized investigation. So any patient with a known or suspected infection who has a QSOFA score more than 2 should be investigated quickly, confirm whether there is sepsis, and then you need to initiate the management protocols with the communication with the other teams and your seniors. So it's very necessary to find this quickly. So this is the management outline. What do you do when you find somebody who has a QSOFA score of more than 2, right? You give oxygen, right? It's available in the ward. You give oxygen with a mask. If patient's level of consciousness is low, might have to use a oral ARV as well, right? You do blood gas analysis and discuss with the intensive care unit or anesthetist or your consultant who can read blood gas report rationally and quantify it and decide whether patient needs anything specific, maybe drugs, maybe some specialized ventilatory support. You start on IV fluids, you check on the urine output, check on the blood pressure, check on the peripheral perfusion, and you start on IV fluids, maybe initial bolus is 500 to 1000 milliliters, followed by fluid assessment with the urine output and hydration and the other parameters. You have to start on an IV antibiotic, which is life-saving if you suspect a sepsis, but you take blood culture before starting antibiotics. That is very important because you need to identify your organism which causes the infection. You check on urine output. If catheter is not there, you catheterize the patient. If patient is not very well, clinically unwell patient, can't measure the urine output, you catheterize the patient and you monitor hourly urine output. It has to be more than 0.5 milliliters per kilogram per hour. That means at least you need to have about 30 mils per hour adequate for your assessment. So it's very important to have a team approach. So you are the communication cornerstone and the person who acts at the team. You have a lot of responsibilities, right? Don't think you are the house officer, you know, I don't know much about everything, right? But communication is very important. Discuss with your seniors, ensure your seniors get involved early, and they will discuss with the other teams if necessary, discuss with the consultant immediately, and the other teams will help you to get over with the better outcome. And you have your nursing staff who takes the observations. They do chart blood pressure, pulse, respiratory rate, fluid intake, urine output. If there is a nasogastric tube, about these nasogastric output, if there are drains. So documentation is very important when it comes to a critically ill patient, and then do that adequately at desired intervals, maybe 15 minutes, maybe half an hour, maybe 1 hour. So while you are doing this initial part of the management, the rest of the management will take place with the discussion with the other teams, right? So there will be some specialized drugs like inotropic agents. Your nephrology team will suggest probably dialysis if there is some problem. And then the respiratory team, the anesthetist or the intensivist suggest probably the patient needs ventilation, intubation, various modes of ventilator support. So it's very important to check about the patient and then check again and discuss when there is a high degree of suspicion about a patient and communicate adequately and be dependable, and then listen to the other team members, discuss the problem over and over again. So it's always think and anticipate early for a good patient outcome with less morbidity and less mortality. So that comes to the end of this lecture. I hope that I have been able to pass the message. That means that you need to have high degree of suspicion and you need to know what are you looking for, and you need to communicate with the seniors and the nursing staff, and then you need to give very clear instructions. What are we going to do, and then how are we going to do, and then do the supportive investigations and documentation properly. And if you see this picture, this is a patient who was being shot from behind onto the right side, where a piece of liver is coming out through the exit wound. It's a high velocity injury. It's a soldier who was being shot, a patient that I operated some time ago. You see that abdominal wall is tense, distended, and there's a lot of things happening inside. And then if you see a patient like this, you need to anticipate not only the acute management, that is exploratory rhabdotomy, attending to bleeding, and the management of injuries. Once this patient come back to the ward, he has already bled large volume. He had massive blood transfusion protocols which have been initiated in the theater or maybe in the battlefield, and then they will be definitely end up with sepsis, where we anticipate and start on broad spectrum antibiotics, looking for any deterioration and then picking them up for a better patient outcome. I think that comes to the end of the lecture, and thank you very much for your patient listening. Any questions? Do you have any questions? Any questions, please?
Thank you, sir, for your lecture. They can type the questions in the chat, sir.
Yeah. So in case if there's anything, just ask them to communicate, and then we can give them adequate explanation or anything, right?
Yes, sir. Yes, sir.
Okay.
Yeah.
Thank you very much then. Good luck for your internship, and then hoping to see you all soon. Thank you very much.
Thank you very much, sir. The next lecture will be done by the Professor Bhavanta Gamage.
And it's Professor Bhavanta Gamage's birthday today.
Thank you very much for that comment.
Many happy returns, Bhavanta. I had already posted my message.
Thank you. I got it. Thank you so much. It's I'm so happy to deliver the lecture today. So thank you very much for all your wishes. Hope you can hear me well. Can you hear me?
Yes, sir. We can hear you.
Okay. Now the topic today is, my topic is to teach you all something about perioperative observation, pain relief, and post-op plan, what is to be given to the patient. So this is a very, very important area because what we have found in most of the time, the patients are not given proper advice when they are discharged. Now, you have already, I think, discussed about the importance of the pre-op assessment and consenting. All those things have been dealt with. Now, this is also very important because don't think once the patient is operated, that's it. No, patient needs proper follow-up. That follow-up is should be communicated to the patient very well. Otherwise, all what we have done up to the surgery will be lost if the patients are being not followed up properly. Once the patients come out of the operating table, the perioperative care, we can call it post-operative care, definitely matters the outcome. We don't have to reiterate that. And during your medical school days also, your teachers would have told you about importance of post-op care. Now, one important aspect of post-op care is post-op pain management, right? Now, don't try to write these things down. Purposefully, I have not included any slides because now during your medical student days onwards, you have been writing down the notes from the what you have heard from lecturers. So if you want to search and learn, there's many more material available online. But try to listen to what I'm saying and just try to remember few things as take-home messages. So why post-op pain management is important? If somebody asks why, can anyone answer? I want some participation from you all. Why post-op pain management is important? Are you all now? One problem in this online teaching is we don't know what people, listeners are doing. They may be sleeping or so we want some active participation. Anyone? Yeah, okay, quick recovery. One has said quick recovery, yes. For quick recovery, post-op pain management is important. Now, for example, if you don't manage the pain properly, what are the problems that can happen? Let's say after a major laparotomy, the patient is brought to the ward. As a good house officer, what the consultant would expect you to read what has been written in the operation note. That is the first thing you should do. Now, in our practice, we have seen the patients are brought from the theaters by the orderly staff, and the nurses will get the patient onto the bed. And after that, nurses will just sometimes measure the vitals, and you may not be seeing the patient for few hours sometimes. Don't do that. If a patient after a major operation comes to the ward, whatever the things you are doing, you have to stop that and go and see that patient. Because during the process of transferring the patient from theater to the ward, there can be many things happening, right? Patient may be desaturating, patient blood pressure might drop, drains may be dislodged, catheters may be dislodged during the transfer, because we don't have the ideal transfer facility also from theater to the ward and to the bed. So therefore, it's vital for you to see the patient, see the note, what has been written, what are the advices given, what was the surgery done. Sometimes the surgery may be completely different what was decided pre-operative, right? So don't think the same surgery would have been done. Surgery may have been slightly different. So you have to know what exactly has been done to the patient. And then comes to the post-operative management. One of the most important things I have told you is pain management, right? Why pain management is important? If you don't manage the pain properly, patient, because of the pain, when the patient becomes conscious, the breathing can get affected. Patient may not breathe properly, right? So if the patient doesn't breathe properly, patient's oxygenation will be reduced. Not only that, as you know, proper breathing is important for many other reasons. One is during general anesthesia, one of the complications they can have is their basal lung alveoli will collapse, and subsequently it will lead into atelectasis. And atelectasis is one of the main reasons for post-operative fever, right? They get high fever spikes, right? Post-operative pyrexia. So patient's breathing in and out is important to open up the alveoli. Otherwise, it can lead to chest infection. Not only that, you know, you may have learned in your anatomy that there are two pumps that are important in venous return. One is the thoracic pump, other one is a muscle pump, right? So when the patients are bedridden or mobilization is delayed after major surgery, the muscle pump is not working. And because of the pain, if the patient's breathing is also not there, the thoracic pump is also not working properly. When the patients breathe in well, you know, the negative intrathoracic pressure will drag the blood into the chest, right? So if that is not happening, the venous pooling is aggravated and more patients are more prone to get DVT, right? So that is number one. Another reason why the patients are more prone to get DVT is when they are poorly mobilized. So mobilization is also affected if the pain relief is not adequate, right? Then the other thing is, as we all know, when the pain is not properly managed, their sympathetic overactivity causes tachycardia, and tachycardia, as we all know, can lead to ischemic cardiac events. Because why? Because the heart muscle gets perfusion during the diastole, and when tachycardia occurs, in physiology you would have learned during the cardiac cycle, the diastole is compromised. Diastolic time is compromised during tachycardia, and because the diastole is becoming shorter and shorter, the myocardial perfusion is going to get less and less. And if their coronary arteries are already compromised, they can get ischemic cardiac events. So all those things are related to improper pain management. So therefore, proper pain management is very, very vital. Then, what are the other most important things in post-operative or management? So during the surgery, there can be post-operatively, other thing they can have is post-operative bleeding, which can sometimes be lethal to the patient if you haven't detected properly. So what are the important things, or how can you detect a patient is bleeding or concealed bleeding? These are all concealed bleeding we are talking about. If the bleeding is obvious, if it is bleeding outside, but after laparotomy, after thyroidectomy, there can be concealed bleeding. So what are the important things that you have to monitor in a patient to detect this concealed bleeding? The common answer the students give is their blood pressure will drop, right? Now, as a good house officer, you should be able to detect concealed bleeding before blood pressure drops, right? That's why the post-operative note will tell you monitor this patient's urine output hourly, right? Because one one thing that is going to get compromised when patient becomes hypovolemic is renal perfusion first. So if the urine output is dropping and pulse rate is going up, sometimes there may be drains which drains blood out, right? But these drains sometimes can be misleading because most of these tube drains that we put, they are easily get blocked. When there's bleeding, blood can be clotted inside and the drain can be blocked. So don't think nothing is draining from the drain, therefore it cannot be bleeding inside. Don't think that that is correct, right? So, but you have to, don't depend on one parameter to decide, right? So if the patient is bleeding, patient's urine output is gradually dropping, patient's pulse rate is rising. If you examine the conjunctiva of patient, it looks pale. So all those things tells you, even though the bleeding is not obviously visible, there should be some sort of a blood loss is going on. So you have to act immediately. So that's why these parameters, monitoring these parameters are important. And also, remember, once the patient is recovering, other important thing is the mobilization of the patient. Patient should be encouraged to mobilize as soon as possible. Ask them to come out of the bed, then walk around the bed, and then gradually increase the mobility. Same time, the physiotherapy should be started. Patients' breathing exercises, intensive spirometry meter will give them breathing exercises. And then other important thing is start early feeding. Now, when we were medical students, we were told, okay, once you have bowel operations or laparotomies, patient should not be given oral feeds until the bowel sound starts. That thinking is now, with many evidence, it has been shown that you don't have to wait till the bowel sound starts to start feeding. You can easily start giving oral fluids to the patient if the patient doesn't have any nausea and vomiting and abdominal distension. Because as we all know, in normal physiology, the gastric secretion for 24 hours in a normal person is about 2,500 to 4,000 ml, right? So after surgery, it might get slightly reduced, but if the patient doesn't have abdominal distension and if the patient doesn't vomit, that means whatever the secretion that is accumulating inside the stomach is going down. So the bowel is started to function. Unless there's gross peritonitis, and if you handle the bowel, lot of time if you handle the bowel during the surgery, then of course there will be paralytic ileus post-op. Those patients you have to be careful, or those patients will have NG tube most of the time. So those patients, the feeding liquids and solids has to be delayed, and you have to monitor according to the patient's daily status. But otherwise, simple, for example, bowel resections, anterior resection, or hemicolectomy, or any other intra-abdominal operations, early feeding is advised. Early feeding, what I meant was not to give full diet on the day one, but you can start giving liquids if the patient is tolerating the liquids, if the patient doesn't vomit, if the patient is not uncomfortable with abdominal distension, you can gradually build up. And as you know, early feeding will improve the gut blood supply. It will keep the gut mucosal barrier intact, which is very important. Otherwise, as you know, when the gut mucosal barrier disrupts, the bacterial translocation can occur, and that can lead to a deterioration of the patient. So early feeding is advised, and the mobilization, right? Then, as we know, if the early feeding cannot be given enterally, then you have to think of giving some parenteral nutrition to the patient, right? So that is, of course, always enteral feeding is better than parenteral feeding, but parenteral feeding, nutrition is support you have to take. Now, most of the hospitals will have nutritionists. If not available, always you can calculate the parenteral nutrition. This is not the scope to discuss that this lecture, but early feeding, whatever the way, should be encouraged, because as we know, after the operation, there is significant amount of muscle mass loss. We call it sarcopenia. So to minimize sarcopenia, you have to start early feeding, as well as we know, we have to pre-operatively take measures to minimize sarcopenia. Pre-operatively, glucose loading for non-diabetic patients, it has been shown with evidence. Pre-operative carbohydrate loading will minimize post-operative sarcopenia. In the same time, post-operative early feeding will minimize sarcopenia and the muscle mass loss. All right, so that can be minimized. So those are the important things. Then, what about the discharge summary and writing a proper diagnosis card? And that is one of the most important things that all house officers should be taking care of, and you should be responsible what is written in the diagnosis, because all of you should understand the diagnosis card is a legal document that is given to the patient. So it has to be accurate. Now, I know I have seen sometimes the diagnosis cards are written by medical students. When you are medical students, I'm sure some of you all would have written diagnosis cards, because house officers, they are overloaded with work. They delegate this duty to other people. Right? That should not be done. If that is inevitable, all house officers should observe what has been written and whether it has been written properly. And other mistake I have seen is that diagnosis cards after surgery, what is written in the BST, the post-operative or the operation note, you don't have to include everything in that note into the diagnosis card. So I have seen some diagnosis cards, laparoscopic gastrectomy or laparoscopic thyroidectomy or anterior, each and every step is transferred to the diagnosis card, which is not necessary, because diagnosis card is important for somebody else to see it and understand what has been done, what was found. So findings of the surgery Hello? Yeah, sorry. Can you all hear me now? There was a bit of a disruption. Hope you can hear. Yeah?
No, we can hear, sir.
Yeah. So, what should be included in the diagnosis card is, if it is after surgery, what was found in the surgery. For example, laparoscopic or let's say anterior resection, whether the liver is normal, whether there are peritoneal metastases, whether there are any free fluid in the abdomen, right? What is the tumor location, right? No one is interested how the dissection was done, how the artery was ligated. No, because no one is going to perform an operation by looking at your diagnosis card. But that is important in follow-up. When the patients are followed up, what was found in the operation is important. So don't try to write everything in the BST in the diagnosis card. Most important is finding of the operation and the post-operative management plan when the patient should come to the clinic. If there are sutures to be removed, when those are to be removed, when the histology needs to be traced, right? What are the drugs that were given to the patient post-operatively, and whether there are any allergies that has to be clearly written, probably with a different type of ink, whether there are any allergies, right? So those are the important things that has to be written in the diagnosis card. And patient should be given proper advice when to come. Now, I have seen in some units that the diagnosis cards are written and the discharge plan says, okay, patient needs to be reviewed in the clinic in 3 weeks time with histopathology, right? And the patient takes the diagnosis card and the next clinic date is given by the nurses. The patient takes the diagnosis card and goes to the nurses station because they have to sign the bed head ticket before they are being discharged from the ward. And the nurses tells the patient, this is the clinic date. Now, clinic dates when they are given, some of the units, because of the patient overload, they have restrictions. So for one clinic on one particular day, 150 patients numbers will be given. Now, if your patient goes there, who's after a bowel resection and needs the histology be reviewed in 3 weeks in the clinic, when the patient goes there, that third week is not free for the number, right? A number 150 has been given. Fourth week also may not be. So the date may be another 6 weeks time. And the patient comes to the clinic after 2-3 months because there was no date available. Even though you have written it to be reviewed in 3 weeks, the patients get a date in 3 months time. This has happened. And this is worse when there's a excision biopsy for histology, right? Because that biopsy report is vital to decide on the definitive treatment for the patient. So if such patients are discharged, because as doctors we know, you should be knowing when we should see this patient. If these patients should be seen before 2 weeks or as soon as possible, you should instruct the nurses, don't give the routine follow-up days. This patient needs to be seen on this particular day, especially after procedures like endoscopies and colonoscopies. We do colonoscopy and discharge the patient and we take a biopsy and we want to see the biopsy report as soon as possible. Sometimes these patients comes 2 months after to the clinic and it's a malignancy. So what is the, imagine what, how much the delay, right? So those things should be avoided. So you should be aware of these things when you become good house officers, right? So, and then always you should talk at the time of the discharge or when the discharge decision was made during the ward round. Consultant will decide this patient is going home today, and then after finishing the ward round, you should talk to the patient and explain this is what has been done. This is so your follow-up clinic is very important. Or if you have referred this patient to some other specialty for oncology clinic, as a good house officer, always explain why you should go to that clinic, because all that has been done surgically will be of waste if you don't follow that, right? Because if it is a tumor, it can recur. So that knowledge has to be given. So those are the important things in follow-up, I have to say. And then I think if there are any other questions, I can answer. So post-operative pain management, monitoring the patient, why it is important to monitor. And as a good house officer, you should always, if you are told about the post-operative complication by a nurse in the middle of the night or early morning, you should come to the ward. Don't try to manage these patients from your quarters, right? Because you are the primary responsible person who's encountering this problem first. Nurses will detect and tell you, you should come to the ward. Come to the ward and see the patient, and then you should convey the message to your seniors about the exact situation, right? Without seeing the patient, don't assume things and advise the nurses. One other important thing I want to highlight is when you are doing a ward round, it doesn't matter whether it is pre-operative or post-operative, you should document the date and the time and with whom you are doing. If it is your ward round, you write down, or if you are accompanied by your SHO, registrar or senior registrar or consultant, you should write who saw the patient and what were the decisions that was made, right? Don't write we have seen, continue same. Nothing like that. Should not be written. No. If the VS says, or the registrar or senior registrar says, continue the IV augment, IV coamoxiclav or IV flucloxacillin. Why? If there's a cellulitis patient, whether there's any abscess formation, is there any risk of developing necrotizing fasciitis? Is there any risk of developing compartment syndrome? Those things has to be written properly. So the documentation is very, very important. Okay, that's all I think I have to say. If there are any questions, I can answer. Okay.
Thank you.
So wish you all the best for your future, and I hope you all will be good house officers. I'm sorry, I have to excuse a medical clinic and come and conduct this lecture, but I hope you have gathered something. Thank you so much.
Thank you very much, sir. The next lecture will be done by Dr. Channa Pereira.
Hello.
Hello.
Can you hear me?
Yes, sir. We can hear you.
Yes. Good afternoon, all of you. And it's a different kind of lecture. So today I'm going to talk about the medico-legal management of a surgical patient in the surgical ward. And as you know, actually you may not know. So what I want to say is, unlike the old days, now we work in the medical profession in a medical defense society. So you should be always keep in your mind that when you work, if you make some error judgments, the society or the patient or the next of kin could sue you. So therefore, you may be a very good doctor, very good medical officer. In future, you will become consultants. So you should know to avoid and prevent these kind of unnecessary encounters. So what I want to say is, you may be a very good driver, but if you do not know the road rules, you may get into trouble. Similarly, though you are a very good, skillful, knowledgeable doctor, you do not know the law of the land, at least in relationship to the management, medical management, you may get into trouble. Therefore, you should know the legality of the management of patient. That is the introduction that I want to give you. And also, you should know that this area of legal aspect is grossly neglected. But if you do not adhere to the basic principles of medical legal aspect, you may get into trouble. So we have become doctors with the greatest difficulty. we will become doctors even more difficulties as consultants. Though we have spent a lot of time becoming doctors and becoming consultants, if you do some kind of a mistake, your medical council registration may get erased within seconds. So we have to be very careful when we work as medical officers and as consultants in the health sector. So I hope that this lecture will give you some eye-opening as to how you should manage during your new career as medical officers, internees, medical officers, and consultants. Okay, medical legal aspect has two broad aspects, that is the management of death and management of living. So first of all, let me speak of the management of death. So you manage a patient in the ward, and if you encounter a death of a patient due to various means, people can die due to natural causes, people can die due to unnatural manners such as accidental, suicidal, homicidal complications. So then, of course, you should be able to certify death initially. So you have been taught how to certify a death, but just to remind you, when you go to a patient, you should initially check for pulse, check for heartbeat, check for spontaneous breathing. I emphasize on that spontaneous breathing, and check for, you should take a torch. Now there are torches in your cell phones, mobile phones, you can use that and put on the eye of the patient and see whether the pupils are reacting to light or whether they are fixed and dilated. Upon that, if you have decided that the patient is dead, then you should put the date and time and write as follows. So no pulse is absent, no heartbeat, no spontaneous breathing, pupils are fixed and dilated and not reacting to light. Then you put your signature and certify it. Once you have certified the death, then of course the next question is whether you can release this body to the relatives. So if the person has died as a result of a natural cause, if the cause of death is known, then of course you can write the death declaration form and release the body to the relatives. The death declaration. There's a book in all your wards where there's a government form called death declaration. So you fill the name, age, address, cause of death, and so forth. It's a very simple form. And then by doing that, you can release this body to the relatives. Only if the manner of death is natural and if the cause of death is known. If the cause of death is not known, or even if the cause of death is known, if the manner of death is unnatural, such as accidental, suicidal, or homicidal, you cannot write the death declaration form and release the body to the relatives, but you should request for an inquest. So what you should do is, again, you should put the date and time and write to the head of the institution. It may be a director, it may be a medical superintendent. You have to write address to him, you have to write that requesting to authorize an inquest. Then once the inquest is authorized by the head of the institution, it will go the inquest procedure, and the inquiry into sudden death will get involved with the police, and then that person will decide whether to refer this body for a post-mortem examination or not. So upon a death of an unnatural nature or unnatural manner, you have to request the institution for an inquest and also inform the hospital police post that death requires an inquest. That's regarding the inquest. So when it comes to the unnatural deaths, inquest can be held by principally two officers in the government, that is the inquiry into sudden death and the magistrate. The inquiry into sudden death can inquire natural deaths where the cause of death is not known, because if the cause of death is not known, though it is natural, you cannot write the declaration of death form. So if the cause of, if it's natural, when the cause of death is not known, in cases of suicides, in cases of accidents, the inquiry into sudden death can hold the inquest. If it's suspicious and homicidal, especially mainly homicidal deaths, the inquest must be held by the magistrate. So that actually will be decided by police, whether to refer it to the inquiry into sudden death, the so-called coroners, or the magistrate should get involved. There are exceptions. If there's a death in mental hospital, mental asylums, leprosy camps, under custody, irrespective of the manner of death, whether it's natural, accidental, suicidal, or homicidal, the inquest must be held by the magistrate. For example, if it's a mental hospital, the National Institute of Mental Health at Angoda, the death has occurred, even if the senior consultant physicians know that the death has resulted as a result of a heart attack or acute myocardial infarction, the death must undergo an inquest. The inquest must be held by the magistrate. So the other thing that I want to say is death. So what you certify in the ward is the somatic death, absence of pulse, absence of heartbeat, absence of spontaneous breathing, and checking the pupils for reactions. That is called somatic death. And the death will continue as a molecular death when the cell death takes place. What I want to tell you is there's another phenomenon called brain death, which is extremely important. So that's why I told you absence of spontaneous breathing. There can be situations where, especially the young individuals who meet with accidents, may get brain death conditions and brought to you. They may have been intubated and ventilated and fixed in ventilators. These patients will be definitely in intensive care units, not in ordinary wards. So then, of course, if the brain death is confirmed, brain death need to be certified in a proper way. How to certify brain death? Brain death is not certified the way that I told you as an ordinary ward death. So there are several components which is mentioned in the Organ Transplantation Act. You don't have to know this act, but it's the Act number 48 of 1987, which denotes to the organ transplantation, and it says how to certify a brain death. So apart from this, you have to check. I mean, the patient is now intubated. You should check for vestibulo-ocular reflexes. You have to check for gag reflex. You have to check for corneal reflexes, and you have to do the apneic test. And you have to repeat these tests half an hour later. And the persons by two medical officers, preferably consultants, but even medical officers is okay. And the certifying medical officers of this brain death should not be involved if this body is going to be taken for organ harvesting, for organ transplantation. That is something in addition, but brain death is a different kind of a type of certification of death. And also you should keep in mind, there's another phenomenon called suspended animation. Suspended animation is not a condition of death. In case of suspended animation, the person is still alive and his physiological functions are occurring at a very low level. You may not be able to feel pulse. You may not be able to listen to the heartbeat. You may not see spontaneous breathing. And So people may think that this person is dead. I think we have the last incident we had in Sri Lanka was during the era of the peak of COVID, about 2 years ago. Person came to the outpatient department at General Hospital Negombo, where the OPD medical officer certified death, and the body was sent to the morgue, and the person stood up in the morgue and walked home. So these are not stories. This has really happened in Sri Lanka about 2 years ago. What has happened was the patient was in a state of diabetic coma. Patient, the medical officer could not feel pulse. There was no heartbeat. There was no spontaneous breathing for the medical officer to see. But unfortunately, I assume that the medical officer, if checked the pupils for reactions, he or she would have spotted that the pupils react. And then, of course, the body would not have gone to the morgue. So that's why you have to check the pupils for reactions to light, whether it's fixed or dilated. So this condition is called suspended animation. Suspended animated persons may live, well, I mean, they will live because they are not dead once they recover from this state. That also should be kept in mind. And also regarding documentation. Now, when a patient comes to the ward, as I told you, you may have to deal with a dead body when they are dead, which we discussed in brief already. And the patient may be a patient who comes with a medical legal importance. You get patients in the surgical ward following assaults, following accidents, following injuries due to suicides. And you should know how to manage these patients. If the patient has survived as a result of an attempted suicide, then of course, it has no medical legal importance. Earlier, the law was if the patient has survived even following attempted suicide, the medical officer in the ward or intern medical officer or the consultant should refer this case to the police to get an MLEF issued, that is a medical legal examination form, it's also called the police ticket, to be issued to be examined by a JMO, which is not required anymore. So attempted suicide is not a criminal offense, but if this person had been assisted by somebody to commit suicide, even if the patient has survived, it requires a medical legal examination because there'll be a case against the person who assisted for suicide. That you should keep in mind, but otherwise, attempted suicide is not a criminal offense. And if it's not assisted by a third party, medical legal examination is not warranted. But in all the other accidents and assaults, you should inform the police to get an MLEF issued. As I told you, you know MLEF, that's a medical legal examination form to be issued, and for the JMO to be seen. If not, what would happen? Now you are in the surgical ward. There's a patient following a road traffic accident or an assault. If you have not informed the police to get a medical legal examination form issued, the JMO has not seen, then once the patient is discharged, there'll be a court case and the court requires a medical legal report. And there's no way of the court getting a medical legal report because a JMO has not seen the patient. So what will happen is the patient will produce his diagnosis card to the police or court, and if not, once the court will get to know that the patient was admitted to a particular hospital in a particular ward, the summon will come, summon from courts will come to the ward head, that is, in your case, to the consultant surgeon to submit a report. And the patients are not being, these kind of patients are not being examined in wards for medical legal purposes, and injuries, I'm pretty sure, is not being recorded, neither by the medical officers, neither by the consultants, neither by the intern officers. So how the consultant is going to write a report? If the consultant will not submit a report, it could be warranted. To overcome this, the easiest way that you can do, or the medical officers or the consultants can do, is in relevant cases to inform the police to get a medical legal examination form issued and to be examined by the JMO. In that case, the police will know that he was examined by a JMO and the summons will come to the JMO. So there won't be unnecessary problems to the consultant surgeon to submit reports to courts. This is not a very rare occurrence. The consultants at National Hospital, in other hospitals, get summons when the patients are not being examined by a JMO, when the ward has not referred these patients to the police to get medical legal examination form issued. That should be kept in mind. That is in relation to examination of patients and also the documentation. I think I had the opportunity of listening to some of the lecturers, because though I told you good afternoon, actually it's very good morning to me, because still it's 2:30 in the morning to me. I'm in the beautiful island of Jamaica in West Indies, Kingston. So I had the opportunity of listening to some of the lecturers. They mentioned of the importance of documenting the medical legal, surgical documentation, the documentations for surgical purposes. We were taught that the BHT should be treated before the patient. Well, partially I agree with that, but certainly you should treat the patient and the BHT as well. If you do not treat the BHT, if you do not make proper endorsements, the bedhead ticket, then of course the administrators and the court will not know what you have done to the patient. And then of course, there could be even issues of medical negligence against the medical staff. Therefore, you should make your proper surgical endorsements, and in relation to the medical legal aspect, you are bound to make endorsements in relation to the medical legal aspects, that is to record injuries, at least in brief. You can't say that I am not a JMO, the consultants can't say that I'm not JMO, the medical officers can't say that I'm not JMOs. The original injuries should be and must be recorded by the admitting officer of the ward, of the OPDs, and particularly in the wards, the SHOs and so forth, and the house officers. If they have abrasions, contusions, lacerations, stab wounds, firearm wounds, and all these burns, injuries, all these should be at least briefly recorded. Because the injuries may be examined by a JMO in a subsequent day, and if the injuries are altered, then of course the JMO will have difficulties in interpreting. Now, the best example, as I told you, currently for a short period I work as a consultant forensic pathologist in Kingston, Jamaica, and we have a lot of gunshot wounds. And when these patients get admitted to wards, they undergo surgery and the gunshot wounds are being altered. And if the original wounds are not recorded, then of course we as the forensic pathologists encounter greatest difficulties in interpreting these wounds. So the person who see these wounds are the ward doctors. So original wounds must be recorded, irrespective of the nature. Maybe a small abrasion, maybe contusion, laceration, stab wound, cut wounds, burns, explosive wounds, firearm injuries, or whatever the injury. The injuries should be documented by you in the bedhead ticket. And also, the other important aspect is examination for endorsements in relation to consumption of alcohol and illicit drugs. Certainly, you're not expected to examine, to perform all the tests like we do to examine and confirm whether the person is under influence of alcohol, but you should make endorsements on admission whether this person is smelling of alcohol or whether he is grossly under influence of alcohol. Because if the patient will get admitted today at 6 p.m. to your ward, By the time the JMO examined on the following day, the patient, if the patient was under influence of alcohol, or if he had smell of alcohol, following day, none of these features will be there. So we take all these features, all this information from the deadly ticket. So you should smell, if you think you should smell for alcohol, whether they are smelling of alcohol, whether he is under influence of alcohol. But I must tell you, currently, due to these issues of COVID pandemic, you should take precautions of smelling for alcohol, because it will invariably, if the patient is infected with COVID, you have a high chance of getting COVID. So you have to take your precautions. You have to consult your consultants in your relevant hospitals and to get advice what to do in these kind of situations. But it is your duty to make endorsements of smelling of alcohol and uninvasive alcohol. Apart from this, drug toxicity, illicit drug toxicity is very high in Sri Lanka, even in the other countries, particularly in Jamaica. So I'm talking to the internees in Sri Lanka. So we also have a lot of patients who have consumed drugs and get admitted to surgical wards. Sometimes it's very difficult for us to diagnose whether they have consumed ganja, heroin, or whether ice, or whether any stimulants, or any narcotics. But in Sri Lanka, all the JMO's consultants in the consultant units are equipped with the Ministry of Health with a device called multi-panel drug kit, where you can test 12 drugs, including alcohol, by using a sample of urine. It's similar to the pregnancy HCG test, like the strip test. It's also a strip test where you have several panels in the strip kit. So if you suspect medical legal issue with drug toxicity, drug abuse, you promptly inform the relevant JMO. The JMO, if he has these drug kits, by using urine. So what you need is urine to dip this strip, the multi-panel strips, and check whether he has these illicit drugs in his urine. That is in relation to the drug toxicity. And lastly, I would like to tell a little bit of consent and medical negligence if I have time. I hope I have some more time. So you can't do anything without the consent of a patient. The right of the management, medical management, is vested on the patient, not on the doctor. So the doctor should always obtain the consent from the patient for any kind of treatment. So the simplest way of obtaining consent is implied consent. The patient implies and may come to the OPD for treatment, and you're not going to take any special consent. That is called implied consent. Implied consent is the simplest, most way of consent, which can be used for things like OPD management. But if you are going to do some kind of vaginal examinations, anal examinations, and invasive, you have to obtain informed consent, informed written consent, informed written witness consent. So for example, when I examine patients of sexual assaults for medical legal purposes, I always obtain the consent from the patient. If the patient is a major who is above 18 years, the patient is below 18 years, or if the patient is not of sound mind, you have to obtain the consent from the parents or the guardians. Or sometimes you may have to resort to obtain even a court order for the purpose of examination. So you have to have some kind of a consent depending on the case. For surgical procedures, implied consent is not valid. You should obtain informed written consent, and informed written witness consent is more valid. So I think you have been taught about consent in your medical education in your medical faculties. So if you have any questions, you can ask me, but let me talk a little bit of medical negligence as well. So medical negligence has two aspects. One is the civil medical negligence. Other thing is the criminal medical negligence. There are a lot of paper articles in relation to, the journalists' views of medical negligence, but all these cases are not medical negligence. There are 4 components to fulfill medical negligence. First of all, there has to be a doctor-patient relationship. There has to be a relationship between the medical relationship in relation to treatment between the doctor and the patient. That is number 1. Number 2 is when you have a doctor-patient relationship, when you have a medical relationship with a patient, you are bound to exercise a reasonable degree of skill and care. So second component is if you have failed to exercise a reasonable degree of skill and care. The first component is doctor-patient relationship. Number 2 is the failure to exercise a reasonable degree of skill and care. Number 3, by failing to exercise a reasonable degree of skill and care, there has to be a damage. Damage is the number 3. But that is not sufficient. The damage, 4th component is the damage has to be due to a direct result of your negligent act, your errant behavior. So those are the 4 components. So doctor-patient relationship, failure to exercise a reasonable degree of skill and care, damage, and the damage as a direct result of your negligent act. That is in civil medical negligence, where the patient can sue you in civil courts, that is in district courts, and once he will make the complaint, he has to have his own lawyers and file a case in civil courts, district courts, and it's decided only on the balance of probability. Balance of probability, that is 50% plus. So it's an advantage for the patient because patient's lawyers require only 50% of plus probability for him to win. It's like the general election, 50% and 1 vote. And if the patient will win in district courts, then of course the court will award compensation. So you'll have to pay compensation, monetary compensation. So you'll have to pay money for the damages you have caused. The patient is dead, you have to pay this money to the next of kin. So it's serious. It's more serious when it comes to criminal medical negligence. In criminal medical negligence, apart from these 4 components, the other component is the act of negligence is due to a result of so the patient, the doctor does not have, the doctor is absolutely disrespectful for the life of the patient. That is the 5th component. So in that case, of course, if these 5 components of criminal negligence are fulfilled, once the patient or the relatives of the patient complain to the police can even arrest a doctor. But now, of course, there's an agreement by the Ministry of Health with the Attorney General Department that if a doctor is going to be arrested for this kind of a criminal negligent act, they should initially consult the Attorney General before arrest. But earlier there were instances where the doctors were arrested. But the police do not need to obtain Attorney General's consent if it's if it's a crime. But I'm referring to the criminal medical negligence. And of course, before arresting a doctor, they should obtain the concurrence of the Attorney General, but still they can arrest. So in criminal medical negligence, when there's absolute disrespect to the human life, causing the damage to the patient, then of course the doctors are being sued in criminal courts, initially in the magistrate courts, and then subsequently in high courts, and will be if In that case, of course, the case has to be proven by the prosecution, that is from the patient's party. In this case, of course, it will be the Attorney General Department that will prove the case beyond reasonable doubt, without any doubt, like in any other criminal case. Then, of course, if you lose, you'll be remanded and imprisoned. That's why I said that just by becoming good medical officers, good consultants is not enough. It's like becoming a good driver without knowing the road rules. So you should have the knowledge in law. I mean, I'm not asking you to learn the law, at least in relation to the medical management, what we tell you, and have a safe medical career. All the best. And if you have any questions, I can ask. I think there was a question regarding multi-panel drug kit. So multi-panel drug tests are being performed in persons if we suspect of drug abuse, and what you take is urine to be tested for this purpose. And it's like the urine, the pregnancy test. It's also some kind of a strip test, but it's only a screening test. For the confirmation, you have to send blood and urine to the government analyst for confirmation. And thank you. So the moderators, am I done, or do you expect any other questions?
Yes, sir. Thank you very much, sir. That's Dr. Channa Pereira, consultant JMO, on that vital information and lecture on managing death in surgical ward. So if you all have any questions, please ask, sir. You can take 1 or 2 minutes to answer those.
Yeah, what I want to say is I am the consultant judicial medical officer permanently to IDH and Mullaria hospitals. So if they have any questions, of course, when I come back home, they can ask me, or I mean, they can contact me at any time. And so even they can contact any other consultants in this country, they will definitely advise you.
Also, we'll have another lecture on the medical legal aspects, a separate one from the college also. So I think.
Yes, that's right. Yes.
So BSc writing and all that also. Right. So in absence of questions, we thank Dr. Channa Pereira. So thank you very much. So we go to the next lecture by Irukshan Javir, consultant surgeon on head injury patient and general surgical ward. So Dr. Nirukshan Jayavri will join shortly. So until then, have a few minutes a break. Few minutes.
Hello.
Yes, sir.
Yeah. Am I ready to go?
Yes, sir. Please start. Yes. You have given the instructions.
Yes. Can I share? Am I sharing my screen?
Yes, sir. You need to make it full screen. That's all.
Okay. Thank you very much for having me here. Let's start with management of traumatic brain injury. Okay. All these are pre-interns, I suppose. Am I correct?
Yes, sir.
Okay, so now these pre-interns, when you go to your wards, so how do you know these patients are having head injury? So they might just walk in, right? Maybe complaining that they had a head trauma. So you know that they had some kind of head trauma. Probably they can have a head injury. And sometimes they can come with evidence of head trauma or with a wound or cut injury or gunshot injury like that. So that you know there's a head trauma to head. Or sometimes they may come with following road traffic accidents, as you know, is a polytrauma. Yeah, obviously you can suspicious of head injury in these patients. Sometimes without any evidence of trauma, they can come unconscious. So you never know, you cannot check a history. Probably you have to suspicious of having a head injury. Right, so there are some cases I have given here. A 45-year-old man, a motorcyclist, knocked down by a container, brought by the 1990, multiple injuries, so the polytrauma, and he's unconscious. Obviously, you guys are in the ward, you can think of, okay, this, in addition to whatever the trauma, these people have a head trauma as well. So the case number 2, another 56-year-old man, fallen from a coconut tree, under influence of alcohol. So bogey mass over the right parietal area. So this right parietal area bogey mass indicates some kind of head trauma. Obviously, he's fallen from very high, and he's maybe screaming in pain, localized to pain. He opens to either to assess his GCS. And another 18-year-old rugby player, following a rugby match, he had a head trauma while playing. So he again comes. So these are histories. So then you know these people can have a head injury. So you should know these head trauma patients. So they are most of the time they are unconscious or subconscious. So sometimes they cannot make complaints. And as I mentioned before, can associate it with polytrauma. So you have to act quickly because with the head injury, with obvious significant head injury, very limited time of limited time. So limited margin of error. So time critical. So you have to act fast. So you act fast. So now I know that you must have gone through ATLS program. So with that, you airway, breathing, circulation, ABCDE. So same thing done here. If somebody is suspicious of head injury, just quick assessment and optimize the conditions. So this is very simple. So then you know that patients can have a diagnosis of or suspicious of head injury. So you can go ahead with your management. So just introduction of basics. So what is head injury? We consider it as any trauma to skull or brain considered as head trauma or head injury. So this is a bruise over the head. Obviously, when you see this kind of patient, so you know there's trauma to head. And this is a degloving type of scalp. So you know they can have a head trauma. And this is a boxer who is having a subgaleal hematoma following boxing match. So trauma to head. These are the skull. When you do a skull X-ray, you know, obvious a fracture, trauma to head, skull. These fractures could be depressed fracture or comminuted depressed fracture. So these kind of head injuries you might come across. Again, this is another one. Is another one with a open wound. So another kind of head injury. So basic management protocol, when you see a head injured patient, it's a basic life support, ATLS. So you have to position the patient and you have to protect the cervical spine because, you know, most of the time head injury can be associated with cervical spine injury. You have to always keep it in mind, cervical spinal injury along with the head injury. So as in basic life support, stop bleeding, urgent transfer, medical care. So then when it comes to advanced life support, ATLS protocol, APCT, so do the appropriate investigations and then for the definitive neurosurgical management. So what are the information you need to get? You as a house officer in the board, you need to know the information. So as in ample history, you have to take ample history. So any allergies, medications. So sometimes nowadays, most of our patients, they are on aspirin or antiplatelet drugs or clopidogrel, or sometimes they can have a bleeding tendency, hemophiliacs or warfarin. So these patients are very likely to get hemorrhages. So they should get this information. It's very, very important. And in addition to that, whatever the past illness, pregnancy, coagulopathies, as I mentioned, right? And then very important is the event, the environment, time of incident. You as a house officer, it's very important to find out how to, at what time, the mode of or mechanism of injury, the road traffic accidents or fallen or gunshot injury, and any further details. Right? Any other the victims is a polytrauma. So how much time to rescue from the scene, and what, and after that, what did they do in the other peripheral centers if they are going to. Right, and in addition to that, you should know that this patient had the post-traumatic seizures or cardiorespiratory arrest, because all these things are contributing to the final outcome of the head injury. And if somebody has started a head injury observation chart, obviously you can go through it and find out how he has deteriorated over time. So how else you can get the information? Most of the time patient is unconscious, you cannot get the information. So then definitely there would be witnesses around. So you get the information from the witness, relatives, or sometimes the police is the only one who brought the patient to the hospital. So you get the information. So nowadays we have our transport group, ambulance services, so you can get the information from them, or the medical notes transferred from the other hospitals. So classification of head injury. So I'm telling you these basics. So these are the information you need to gather. So whether it's a blunt injury or penetrating injury, because the mechanisms are different. So blunt injury, which gives a low energy kind of trauma. So it could be fallen from RTA or assault. So RTA, you got acceleration, deceleration. Actually, it's a high energy transmission. Even though it can cause significant injury. And penetrating injuries. So low and high velocity, stab or gunshot injuries. So in the head injury observation, your assessment and monitoring is very important. So you will need to assess the head injury observation chart. Obviously, you must have seen there's a Glasgow Coma scale there, and pulse and BP goes together, and you assess there in the pupillary size and reaction and neurological status of the patient. So these are basically head injury observation that anybody should go. I will go through during my lecture how to assess all these things. And this is the Glasgow Coma scale. You should know in and out of this Glasgow Coma scale, because this is a universal language. It's a very objective way of assessing the patient's level of consciousness. So it's very important to you to remember this, how you give these marks. So the best verbal, best eye, and best motor response. So I will not go into detail of this, but you should remember how to assess the Glasgow Coma scale correctly. And when you examine the patient, the position, posturing. So first picture shows the decerebration rigidity, extension, and abnormal flexion, decortication rigidity. So these are the posturing. Motor posturing is this head injury patient when there's severe head injury. These observations are very important. And you can see sometimes when you're observing the behind the ear, this sign, what is called the battle sign. So you should identify this. So this indicates the skull-based injury, middle cranial fossa. And sometimes you might see this kind of the eyelid edema. This is called the black eye. So you should not mistaken this from the black eye from the raccoon eye or panda eye. So I will show this now. This is again the black eye. So this is a raccoon eye or panda eye. This is raccoon eye. So this is a difference you can appreciate. This basically this edema on the eyelid, right? But when you look at this, eyelid looks okay, but around the periphery, this changes. So this indicates actually the frontal skull-based injury. So blood tracking around the orbit. But when it's black eye, usually the direct trauma to the forehead or the eyebrow or the so making the swelling on the eyelid. So this is a black eye. And look at the conjunctiva, right? So you should be able to see the posterior margin of conjunctival hemorrhage. So this is due to the direct trauma to the conjunctiva. But here you cannot see the posterior margin. So blood tracking from behind. So it indicates the skull-based injury. All right, next we'll move into the anatomy of head injury. So you know this co and contra injury. So you can have the impact from front, right? But when you do the CT scan, it might show the trauma in the back of the brain. So that is because this is a contra injury. So impact the brain, the skull suddenly moves backward, but brain is lagging behind. After that, brain goes and hit the back of the skull inside within. So it causes the contusions there. So if you do the CT scan here, so they are the external wound with the fracture and the fracture hematoma and the EDH. And opposite side, you can see the lot of contusions. So without any evidence of external wounds. So this is the contra injury, co-injury and the contra injury, which you can see on the CT scans. This is a picture of a gunshot injury. The bullet has traversed through, dissipating a lot of energy. Even though this is cracked, but in further away, you can see the severe cerebral edema. You cannot see the sulci-gyri or corticomedullary demarcation. Severe cerebral edema because these bullets carries the very high kinetic energy which dissipate the brain, causing distant injuries. So very severe injury. Sometimes you can have stab injuries. So it can cut through the scalp, bone, and the brain and blood vessels sometimes. So it can goes into like that. So you should know the scalp layers, right? The skin, subcutaneous connective tissues, aponeurosis, loose areolar tissues, and then comes the bone and right pericranium. The bone is usually diploid bone, outer endosteum and exosteum, and then you get the dura inside. Right, dura has two layers in the sinuses. It separate and have the dural venous sinuses, and inside that pia and arachnoid mater, and then comes the brain. So these layers, you should know the anatomy of this one. And again, you should know what are the bones that make up the skull. Frontal bone, parietal bone, temporal bone, and occipital bones. These meets at the suture lines. So you should know where the suture lines, because when there's a fracture, sometimes when you do X-ray, you might mistaken it from a fracture. Therefore you should know where the suture lines are, how they looks like. And you should know the skull bases, because the skull base is a ragged surface in the frontal skull base, and there are so many foramens which traverse the blood vessels and the nerves and the middle cranial fossa. So this ragged the surface skull base causes the significant can cause significant contusions on the brain when it moves. That's why the brain contusions are more common in the anterior skull base and the middle skull base, right? And again, you should know the cortical representations, the primary motor cortex, where the primary motor cortex, and the sensory motor cortex, where the visual cortex, right? And Wernicke's area, the Broca's area, right? And these areas, because when there's a damage to the brain, you know what are the expected neurological deficits when you know these representative areas. The left side dominant, right side dominant, right? And again, you should be able to appreciate a CT scan. Right? You do a scan, no point of doing a scan if you cannot appreciate it. So CT scans are taken multiple slides from skull base, from the foramen magnum to the vertex here. So at various levels, it shows the different structure of the brain. So at the foramen magnum, you will see on the brain stem came from the foramen magnum here. And when it comes up, you can see the part of the cerebellum is appearing, right? Go further up, cerebellum, right? The pons here, the pons, then here the fourth ventricle here, right? And same time you can see the both eye globes, and then the middle cranial fossa here. So go further up, anterior cranial fossa here, temporal lobe, the temporal area of the brain, and this is still you can see the posterior, the posterior cranial fossa, right? And the cerebellum. So go further up, the anterior lobe, temporal lobe, and now it appears the occipital lobe, right? So you should be able to appreciate this space here. These are called the basal cisterns. But when there are severe cerebral edema, usually these basal cisterns disappear. And again, you should be able to appreciate the sulci gyri pattern. So sulci gyri and the ventricles. So in the normal CT, you can see the sulci gyri clearly. But when there's severe cerebral edema, you cannot see the sulci gyri because it's so tight. Right. And then other thing is I could mention now in the CT scan, the white is the bone, right? And this black is air. And in between gray scale is the brain, and you can see the CSF is also black, but it's different from the air. So this CSF, the brain matter, and then the bone. But when there is acute blood, it also looks like white or hypodense. So head injury, as I mentioned before, it could be the skull and the brain, right? So skull fractures, when it comes to skull fractures, you can have the linear skull fractures or comminuted fractures or depressed, right? Sometimes it can be simple, that is there's no communication with the exterior, or compound when it's open, right? So with the skull fractures, you should see whether this patient is having autoria or rhinorrhea. So which indicate the outer area is communicating with inside. So therefore CSF leak, definitely there is a dural injury. So high risk of infection. And it also indicates the pneumocephalus. If you look at the CT scan, it might indicate drops of air in the brain. So that means again indicate they communicate with the exterior. So there are the skull fractures. Skull fracture can associate with the hematoma. So extradural hematoma. So if it's common in the middle meningeal area, because this blood vessel middle meningeal artery can get damaged by the fracture, so can bleed into the extradural space. So this is a compound depressed fracture, right? So depressed, how you look in the X-ray. So skull. So when it comes to intracranial injuries, so we see the hemorrhages. So extradural hemorrhage, right, is biconvex shape, extradural hemorrhages. So this is a subdural hemorrhage. It's a crescentic shape. It gives the outer surface, get the bone of the bones of shape of the bone, and it's spread over the brain. It is usually associated with significant brain injury. You can see the midline shift. Midline has been shifted to opposite side because of the significant cerebral edema there. And the subarachnoid hemorrhages, commoners is following trauma, but usually this kind of subarachnoid hemorrhage you can see after rupture of aneurysms. The interventricular hemorrhage, you can have it after trauma. And this intracerebral hemorrhage, usually you see in spontaneous hemorrhages, but still it's possible to see after trauma. So brain injuries could be contusions, lacerations, cerebral edema, diffuse brain injuries. So as I mentioned before, these are the contusions, multiple hemorrhagic areas. So hemorrhages looks white and intermingled with the brain, contused brain. So cerebral contusion. The laceration, brain has cut through a stab injury. So this severe cerebral edema. So you cannot see this more or less a ground glass appearance, a homogeneous appearance. You cannot see sulci gyri, you cannot see ventricles, you cannot see basal cisterns. So it's more homogeneous, severe cerebral edema. And this is a MRI scan of a diffuse brain injury. So diffuse brain injury, sometimes CT could be normal, but still you can have multiple hemorrhages in the corticomedullary interface. So where the axonal and the cellular interface, you can have a tiny shearing effect, tiny hemorrhages due to shearing effects. So previously we mentioned, or we told it as diffuse axonal injury. Now we say it's diffuse brain injury. EDH. So this is a large EDH. So what is the source of bleeding in EDH? How can it bleed into EDH? Usually blood from a fracture can bleed into the extradural space, causing a EDH. Or sometimes there are emissary veins which traverse through the skull, can cause the bleeding into the extradural space. So dural sinuses can bleed, and middle meningeal vessel, the commonest in trauma, middle meningeal artery can cause the bleed. So this is shape of the extradural hemorrhage. This is how you see in the surgical specimen. Outside the dura, in between the bone, you can see a blood clot. So extradural hemorrhage here. This is subdural. You can see subdural crescentic shape. Usually following again can cause after dural sinus injury or bridging veins or cortical vessels can be in subdural space causing the crescentic type of bleed. So this is how you have to open the dura during the surgery. Then you see the subdural blood on the surface of the brain, the blood clot, and under the dura. Again, subarachnoid hemorrhage. Usually you see the traumatic subarachnoid on the cortical surface. So this subarachnoid hemorrhage fill in the sulcus of the brain cortex. The ventricular hemorrhages is how you see the CT scan. Filled with ventricles are filled with blood. Again, severe cerebral edema is a homogeneous appearance. You cannot see the basal cisterns, cannot see the ventricles. This again, this is a CT scan. This you can see tiny hemorrhages in the cellular axonal interface, right? So these are the diffuse brain injury, multiple hemorrhagic spots. So now this one, if you apparently it looks normal, but if you look carefully, you can still see tiny hemorrhages here and there. So this is evidence of diffuse brain injury or diffuse axonal injury previously. So again, you should know that was the anatomy. So this you should know the pathophysiology of brain injury. So brain, probably you must have heard this Monroe-Kelly doctrine, which says the total intracranial volume is constant, which contains the brain and CSF and the blood. So the normal is about 80% is the brain and the blood 10% and CSF 10%, and intracranial pressure is about 10 millimeter mercury. So these are normal states. So when there's a trauma, a mass appears. So it takes some the volume. So when it takes volume, initially it compensates. So to compensate, something has to go out. So it sends the blood and CSF has gone out. So it maintains the pressure around 15, but mass is getting bigger and bigger. So it's uncompensated state. So the lot of blood and CSF has gone out and mass is getting bigger. Then is only thing is left with the brain. So you have to send the brain out. So this is what happened. So when the mass is getting bigger and bigger, so already compensate the intracranial pressure, ICP, by reducing the amount of venous blood and the arterial blood and the CSF inside the brain. Now the brain is shifting. So you can herniate to the opposite side, causing midline shift, right? Or you can have the central herniation. The central part of the brain can herniate to the tentorium, or sometimes you can have the uncus can herniate to the tentorial edge, Sometimes brain stem can herniate through the foramen magnum, or tonsils can herniate. So when this happens, it's critical. So you should not wait till this stage because this is the volume pressure curve, right? So intracranial pressure on this side and the volume of the mass. So when the volume increases, the brain compensated by shifting the CSF and blood out of this intracranial volume according to the Monte doctrine. It compensated, but at some point it cannot further compensate. It rapidly rises. So brain start herniating. You should not wait till you find this point. So you have to act on this. That is why monitoring is very important in the head trauma. So this equation you should remember: cerebral perfusion pressure equal to mean arterial pressure minus ICP, because CPP, cerebral perfusion pressure, is the one favoring to maintain the cerebral perfusion, right? So ICP is against that. So you have to maintain the mean arterial pressure for some extent, have the adequate brain perfusion. So at least you have to maintain the cerebral perfusion pressure of 70 millimeter mercury. So to maintain the cerebral perfusion pressure of 70 millimeter mercury, so usually we consider as the highest the ICP which can tolerate is 20 millimeter mercury. So the mean arterial pressure or MAP should be at least 90. So 90 minus 20, 70. So we maintain the cerebral perfusion pressure. If the ICP goes further up, so you with the MAP of 90 you cannot maintain. So it's very important to maintain the mean arterial pressure to have the at least cerebral perfusion pressure of 70. So this you should remember when you are managing head injured patient. It's very important to maintain the blood mean arterial pressure to maintain the cerebral perfusion pressure. But this is for a very limited short period because this chart. So until you reach this point, if the ICP goes further, you cannot do anything. So you have to act during this period. Right. So again, head injury has been classified according to the Glasgow scale for the management purposes and predicting the outcome. So minor head injury is the GCS is less than more than 13. The moderate head injury is between 9 and 12, and severe head injury is the GCS is less than 8. This is just for classification purposes. Right. And head injury could be primary head injury and secondary head injury. So primary head injury, you cannot do anything about that. It's already happened. You got occur at the time of impact. So as I mentioned, all this time it could damage the skin, bones, meninges, brain, blood vessels. It already happened by the time it comes to you, but you cannot do anything, right? The only thing is, what our main target is to prevent the secondary insult, secondary injury to the brain. This can occur by expanding hematoma, EDH, SDH, so it needs surgical evacuation. Brain edema, so again, increased intravenous pressure, you need to manage the edema. So hypoxia, ischemia, or shock, so you have to manage the shock in this polytrauma patient. You have to prevent hypoxemia, right? And later on, the latter part of the head injury, so sometimes fever, infection, electrolytes imbalance, so all these are causing secondary insults. So you should prevent this. That is why very important to monitor the suspected head injured patient or diagnosed head injured patient and manage accordingly to prevent the secondary insult to the brain. So our goal of management is to prevent secondary brain injury. Right. As I mentioned before, the 10% of the head injured patient can have cervical spine injury. So you should remember you have to protect cervical spine. This is the correct type of collar. It should prevent the flexion extension within the collar or rotation. So if you look at these collars, right, this does not prevent the rotation. So these are useless. And again, when you're handling the head injured patient, you should remember the proper transporting, proper handling, because they can have a spinal injury. So log rolling, you should know this, how to do the log rolling. I'm sure that in the ATLS lectures, you must have learned this one. So when you suspect of a head injured patient, then you have to decide whether you are going to do a CT scan or not. So how you decide? These are the indications. If somebody is presenting with a GCS of less than 13, so you need to do a CT scan. Right? Or sometimes they can come with GCS 13 or 14. But then even after 2 hours, if he remain the GCS 13 or 14. So then you can do. If he improves to GCS 15, that's fine. You don't need to. But if the GCS drop or remain 13, 14 after 2 hours, then there's indication. Or when the suspected open or depressed skull fractures, yes. And evidence of skull-based fractures, yes. Post-traumatic seizures, obviously any neurological symptoms or seizures, then you need to do. And post-traumatic amnesia more than 30 minutes, right? Usually the anterograde amnesia, not the retrograde amnesia, right? Retrograde amnesia. Past, if he has forgotten the past more than 30 minutes, then you have to do the CT. Sometimes with the concussion, they have the anterograde of after the event, they can sort of have a period of amnesia. But more important is the retrograde amnesia. And if they have persistent vomiting, right? And any coagulopathy, those who are having coagulopathies like hemophilia or factor deficiencies, or any if they are on any medication, antiplatelets or anticoagulants, so there's an indication. And whatever, without anything, the significant mechanism of injury, yes. And always with that, I would say better to do a cervical spine CT if the patient's GCS is not 15 or less than 15, and if you cannot exclude clinically by examining. There should be any midline tenderness, free cervical spine, the movements. So then you don't need to, if you have any suspicious, you have to do cervical spine CT also. So how you would prevent the secondary brain injury? So ICP control, so intracranial pressure. This is what is very important. After the head trauma, our main problem is the rising intracranial pressure. So you have to manage that. So how do you manage the intracranial pressure? So positioning of the patient. So at least head end up, 30-degree prop up the patient. So which maintain the easy draining of the CSF and venous blood out and increase the cerebral perfusion. And you have to give oxygen and if needed ventilation. So and you have to do the hyposmolar therapy to get rid of cerebral edema, the mannitol or hypertonic saline or fusimide. More or less the effects are same with the hypertonic saline or mannitol, but mechanism of action is different. Sometimes when the hydrocephalus is there, you can put an EVD, external ventricular drain, or sometimes the hematomas, the EDH or SDH or blood clot. So it's rising intracranial pressure, you have to evacuate them surgically. Or sometimes for cerebral edema, you have to do the decompressive craniectomy. The management. So which prevent the secondary rising of ICP, preventing secondary insult. So obviously, as I mentioned, hypoxemia, ischemia. So airway protection, so basic is ABC. Airway protection is very important. Prevent aspiration, intubation when needed. Usually JCS less than 8 cannot maintain the airway, definitely need intubation. So you have to give oxygen if you think of giving oxygen. Sometimes hyperventilation is advantageous in the initial stage of managing the cerebral edema, but it should be taken by a consultant because hyperventilation can cause cerebral vasoconstriction, which ultimately leads to cerebral ischemia. And you have to maintain the appropriate volume replacements. So maintain the blood pressure, right? As I mentioned, maintain the mean blood pressure more than 90. So electrolytes imbalance should be corrected, prevent control of seizures. So anti-epileptics, but I usually don't start anti-epileptics prophylactically unless there is evidence of seizures. So it's controversial and use of anti-epileptics. And you should prevent the hyper or hypoglycemia, especially the hypoglycemia following trauma is detrimental. An infection, you have to take maximum precautions to prevent infection. You have to correct coagulopathy. Nutrition is also very important in the latter part. So at the end, so your take-home message is a head injury management is timely management. It's very time critical, right? So very important history gathering. So which gives you a lot of information of head injury. So history is very important. You have to protect cervical spine. And intubation is a must if GCS is less than 8, if they cannot maintain the airway. And when to do the CT scan. And if you are in a peripheral hospital, when you're transferred into a tertiary care center, very important for the communication with the neurosurgical units about the patient before you transfer. And you have to arrange the proper transfer mode. And then for the definitive treatment. I think you got some basic idea of head injury. So how you see this head injury patient when you are in the ward, and how you recognize them have a head injury. So basic things about anatomy and pathophysiology of head injury. And when you do the investigations, how you see on the CT scan, what are the EDH, SDH, and some idea about how you manage the intracranial pressure and hyposmolar therapy and positioning of patient, how you protect cervical spine. So I think you have some basic idea of head injury management. Any questions? Any questions? Right. So shall I conclude my presentation here?
That's fine.
Okay. So in the absence of any questions, I will conclude my presentation here. Thank you very much for listening.
Right. Thank you very much, sir. That was Nirukshan Jayavira, consultant neurosurgeon at RHN Hospital. Thank you very much, sir.
Thank you. You are welcome.
Next up is limb ischemia by Dr. Resmi Kasim, consultant vascular surgeon at National Hospital, Colombo. Over to you, sir.
Thank you. Can you hear me?
Yes, I can hear.
Okay. Thanks, Nirukshan.
Thank you.
Now make a So, in the next few minutes, I don't want to take a lot of your time. The basics of acute and chronic limb ischemia I'll be talking about. Now, first we'll talk about ischemia is lack of blood flow, and we are talking about the lower limb lack of blood flow. Now, what we need to know about this is it's important, because acute ischemia, if you miss the diagnosis, so let's talk only about diagnosis and not a lot about treatment. Then there is a chance of losing there is a risk of losing the lower limb within a day. Basically, in about 12 hours, you lose that leg if you wrongly diagnose. And chronic limb ischemia, if you misdiagnose and do not take the necessary action, then what will happen is you can eventually lose that limb over weeks, months. So both these has a threat of losing limbs, right? So now, what is acute ischemia? Acute ischemia is abrupt interruption of vascular supply resulting in threat to viability of the limb. So the limb starts dying. Now, so we know the pulses are there in the lower limb. You have the femoral, the popliteal, dorsal species, and the posterior. Suddenly, the two pedal pulses may be lost depending on where the sudden block is. It can happen in the popliteal area. It can happen in the femoral area. So the pulses below will be absent. So both pulses will be absent. What are the causes? So the thrombosis and embolism. So thrombosis is what happens is when the clot forms in that site. Whereas embolism, the clot has formed somewhere else, either in the cardiac chambers or in a aneurysm proximally, and it gets embolized and lodges here. Now, the difference between this is embolism, the pain, the burst pain comes suddenly. It is it comes on very fast, whereas thrombosis on minutes, hours, it gradually increases. as the thrombus load increases. So that's how you can. So these are intraluminal causes. These are the common causes. Another cause that can happen is intramural is dissection, aneurysm, that thrombose. But then again, this is part of thrombosis. If the wall is damaged, like in the road traffic accidents, if the popliteal artery gets damaged, then there is a thrombosis of that. So then you can have a sudden ischemia. So extramural is where there is ischemia, even with a pulse, because the compartments in, pressures have gone up. For example, you have ischemia, perfusion pressure gets less. So that is because the compartment pressure has gone up. So that can happen in circumferential burns and blunt injury. So how do you diagnose compartment syndrome is the passive movements of the toes causes pain in the leg. So then you know that, and there is one of the first signs is between the first toe and the second toe, there is paresthesia of the foot. So these are the causes of. So what are the how do you diagnose? Now we all know the piece of you have paresis, paralysis, paresthesia, anesthesia, and wholeness. Now there are several stages. Stage 1 is mild ischemia, that is you have no sensory loss, no motor loss. But whereas when you lose the leg, you can never, that is total anesthesia and total paralysis. So that means it's stage 3, you have lost the limb. After 6 hours, this is what you see. In between, you have stage 2, when then the sensory loss gets worse, but the motor power is still there. In 2B, there is weakness, that is muscle weakness, paresis is there, and paresthesia and anesthesia is more. So, in the if you have a patient coming with sudden paralysis, always feel the pulse. It may not be a stroke or a nerve problem. It may be a arterial ischemia causing paralysis of the legs. So always the message is check the pulses. So how you diagnose? Like I said, you feel for the pulse, absent pulses, lack of movement, paresthesia, then you know there is ischemia. So investigations you don't do generally. Why? Because it's a clinical diagnosis. Pulses are absent. So then what do? You have to get consent for fasciotomy, because that will give you some time. This is extreme pain we are talking about. So diagnosis again, loss of pulses or with the presence of features of ischemia of the leg, that is paresis, paralysis, paresthesia, pain, and that the limb may be cold. So no investigation, and you give pain, and the first thing you have to do is give heparin 100 units per kilogram. So for a fully grown man, roughly about 5,000 to 6,000, followed by an infusion of 18 units per kilogram every hour, and then prepare him for emergency embolectomy or thrombectomy. So basically, the secret is diagnosis of acute ischemia. So if a patient comes with sudden severe pain in the leg, or sudden paralysis of the leg, or sudden paresthesia of the leg, and with absent pulses, that should be a diagnosis. Okay, and then there you give heparin, pain management, consent, and theatre. So now, what about complication? Now you reperfuse this. You can have, as a house officer, you can have ischemia reperfusion injury. So what happens is, following your revascularization, there can be all the bad anaerobic metabolism products that were there gets washed into the system. So then you can have renal impairment, you can have the cardiac contractility getting less, and have low blood pressures, you can have ARDS, respiratory symptoms,
And locally, you can have swelling of the muscles and compartment syndrome as a complication of this. Does anybody have questions on acute ischemia? Okay. In the absence of questions, then let's go to the next set of things. So remember the P's: paralysis, paresthesia, pain, and perishing cold. So this is it's a clinical diagnosis, remember. Chronic limb ischemia, sometimes it's easily missed. So there are three different ways the chronic ischemic limb can present. It can present to the clinic or to your surgical ward or to a medical ward with intermittent claudication. There may be pain in the thigh, buttock. Now let's talk about intermittent claudication. The pain is mainly in muscle group. It is brought on by walking. It's not there in the first step. And after walking a certain distance, the pain comes on and it's virtually impossible to walk further. And when you stop, the pain is gone within minutes. So that is intermittent claudication. On the other hand, rest pain, you have pain at rest. The severe forefoot pain, unbearable, even strong analgesics won't take it away. It is worst at night. And when you hang the leg down to sleep, in the nights, it's worse. And when you hang the leg down, pain will get slightly better. It will never go away because of the gravity helping. Then we have finally, because the ischemia is so great, tissue loss. That is, a wound has happened and it's not healing. That can be due to gangrene or any ulcer that is not healing. Gangrene, I'll show you some pictures where you have totally the limb gone dead. There are two types of gangrene: dry gangrene, which is very dry, so there is no threat of infection. Then you have sepsis. So like we said, pain on walking, no pain at rest, the pain in the first few steps. So what happens when you get this pain only after walking for a small distance, and the distance is reproducible. So now, what do you do for a patient like this? You have to give them aspirin, atorvastatin, and you must get them to walk. So walking exercises. So if the patient is disabled, then you need to revascularize. Disability means what the patient cannot do now because he was doing earlier due to the disease. Now, let's say the patient has severe pain and the patient is not working. If you ask them why they are not working, if he's retired, then because this generally comes in old age, then you won't be revascularizing. But if the patient cannot go to work because of this problem, then you will revascularize. If not, all of these patients need aspirin and atorvastatin or some form of statin. So that has a survival benefit for these patients. Now, rest pain, on the other hand, is severe forefoot pain for more than 2 weeks, not responding to strong analgesics, and it is reduced by hanging leg down. Here you have to do something because they just can't go to sleep. It's severe pain. So then therefore we have to revascularize. Now, ulcers and gangrenes are tissue loss due to various other causes, maybe neuropathy or maybe trauma, but it doesn't heal. Or gangrene is where the ischemia is so great, suddenly the tissue got black. Now, in the history, what are the things you're going to ask? First, ask about the causes, because all these you have to control. If not, the ischemia is going to get worse. Whether they diabetes, hypertension, whether there is diabetes, hypertension, dyslipidemia, smoking, go into that history. Then whether there is complication, whether there is ischemic heart disease, strokes in the past, mesenteric angina, that's of course rare, erectile dysfunction, whether all these things are there. Next, you examine the pulses, whether the femoral pulse, popliteal pulse, dorsalis pedis, and the brachial pulse. Another thing you can do is assess the ankle brachial pressure index. Because if you compare put a cuff and see with a Doppler the pressure at the systolic pressure of the dorsalis pedis or the posterior tibial, whichever is higher, comparing it with the brachial pressure, and then it should be 1. So, but as the ankle pressure goes down, then it's a percentage. When it comes to about 0.4, 0.3, we call it critical limb ischemia. So in rest pain occurs in 0.3, 0.5. Tissue loss is generally seen in 0.3. Also, most of these patients have diabetes who in Sri Lanka who get this problem. Think of sepsis, because the decision to revascularize will depend on a lot of factors. Sometimes with moderate ischemia or mild ischemia, the wounds will heal without revascularization. So what are the other factors that will determine whether you're going to revascularize or not? The level of sepsis, local sepsis, systemic sepsis, the degree, the size of the wound. If it's a big wound, you may need to revascularize. If it's a small wound, you may not need to revascularize. Okay. Then you do all the basic investigations like full blood count, HP, and the platelets, the serum creatinine and serum electrolytes will be done, and you'll do arterial duplex, and then sometimes if it's that most of the time is enough, but if sometimes you can get a CT angiogram or a MR angiogram. So these are the things that can happen. You need to be doing. So you image to see where the blocks are with either a duplex or a CT angiogram or MR angiogram or even a conventional angiogram, or you will not if you're proceeding for revascularization, see fitness for surgery, like doing an echo, lung function test if necessary, full blood count, serum creatinine, and serum electrolytes. Then what do we do when you find such a thing? So this is a classification. Stage 1 in chronic is asymptomatic. Stage 2 is they have claudication. If it's 2A is greater than 200 meters, 2B is less than 200 meters. Stage 3 is rest pain, mostly in the calf and feet, mostly the feet. And stage 4 is necrosis and gangrene of the limb. So management of content 2 is graded walking exercises. What do you tell them to do? Hello? Anybody asked a question? So they should walk for 1 hour a day. That is, then they'll say they cannot walk. You must say, no, you walk as much as you can. Say, let's say you're stopping at 100 meters, stop at 100 meters when it's impossible to walk no more. And then when the pain disappears, walk again, stop again when the pain is there. At a stretch, do 1 hour. And do 3 days like that. Then you start an antiplatelet like aspirin and a statin and good foot care so that they don't get any wounds. If they get, due to bad foot care, they get a wound, then we are compelled to revascularize if it doesn't heal. So what is foot care? So these are basic foot care which you will be telling any patient with diabetes or ischemic legs. All the time they have to wear slipper shoes or sandals. They should not go barefoot unless it's essential, like in a place of worship. Cut the nails straight, don't cut the corners of the nails. Whenever they wash the feet, they should dry it. Don't wait with a wet foot, especially between the toes. Put some sort of moisturizing cream. It can even be a baby cream to the dorsum of the foot and the plant aspect of the foot. You can don't every day, so that keep it moist. And finally, daily they should be looking at their feet. Any slight change, they are supposed to come and tell us. Okay. So how do you manage Fontaine 3 and 4, disabling claudication? Either with the angioplasty, it's not bypass. Bypass is one word. Bypass is an alternate route. So these are the things that we can do for these things. So the most important thing is diagnosis. So if there is a wound in the foot, or patient coming in the foot pain or rest pain or pain on walking, always examine the pulse. That's my message. Make a diagnosis of ischemia. When the patient comes acutely with leg pain and paralysis or something, it may not be a stroke. Feel for the pulse to see whether there is any there is acute ischemia. So the diagnosis is pretty simple. All you need is the skill of examining for the foot pulses. If that is absent with acute symptoms, it is ischemia. If you know that much, it's more than enough for the moment, and then you start managing this patient. Any questions? Okay, in the absence of questions, I'll give it to the next speaker. Thank you.
Thank you very much. That was Dr. Husni Kasim, consultant maxillary surgeon. Thank you, sir, once again. So we come to the last lecture for the day. Next is Dr. Mihira Bandara, consultant surgeon on patients needing transport and transfer. That's also a very important lecture because most of the peripherals hospitals, they should transfer for tertiary care services. So please listen to this lecture also very carefully. Okay. So Dr. Mihira will join in a few minutes. So please stay tuned. Also, we will take the attendance in few minutes. So please join. Okay. So we have given the instructions, so you can start.
Right, okay, thank you.
Thank you, sir.
Right, good evening, everyone. So I think this is the last topic for the day. Transfer of patients. As a house officer, you will be invariably involved with so many transfers during your appointments. So I'm going to touch on very important principles you have to adhere during and preparing transfers. Right, let's look at a case scenario. 21 years old motorcyclist admitted after road traffic accident with head, chest, abdomen injuries and right femur fracture. Vitals, blood pressure 90/60, heart rate 120, respiratory rate 36, saturation 85, GCS 30. So initial investigations revealed fast scan, small amount of free fluid in the abdomen. Chest X-ray showed right-sided pneumothorax. X-ray pelvis stable, trami fracture. So by looking at this case scenario and the vitals given, and also the certain investigation results, what do you think? What you should be doing first? Obviously, this patient is a bit unstable. So because tachycardia and the low blood pressure and saturation is low, so we have to resuscitate according to the ATLS protocol. So airway, breathing, circulation, disability, and exposure. We have to follow that order. So initial management included giving 100% oxygen with cervical collar and starting IV fluids, crystalloids, and to relieve the breathing, difficulty, chest tube for the pneumothorax, splinting of femur fracture, and the pelvic binder for suspected pelvic fracture. Once the initial treatment is initiated, patient responded well. BP came up 100/70, pulse reduced to 105, saturation 96%, GCS still remained 13, and the IC tube drainage only 100 ml of blood, and the fast scan only the small amount of free fluid. So if you are managing this patient in a surgical unit where there's a general surgeon, but with limited radiological facilities like X-ray and ultrasound, but no CT scan available. So will you be able to manage these patients at your institution? What do you think? So patient had some bleeding, responded to initial management, and had chest injury managed with the IC tube, and there's some fractures, those were splintered, but his GCS remaining 13. That is some minor head injury category, but you need to obviously image these patients to exclude any intracranial hemorrhage. So you need these patients CT scans to be done. Therefore, if your institution doesn't have that facility, once you stabilize the patient, you need to transfer this patient to where there's a CT scan facilities. So once you decided for transfer, and there's another indication, not only CT brain, CT abdomen too, because the positive fast, although patient responded to initial fluid resuscitation, you need to rule out what is going inside, what is happening inside the abdomen, whether it's a liver injured, whether it's spleen injured, whether something else injured. So that can only be really demonstrated with the CT scan. So how do you arrange transfer? So these are the priorities and principles. The patient stabilization is the highest priority. So you have to a certain extent, you should try and stabilize the patient before transfer. And at any time, you should not delay for arranging transfer, because the certain injuries are evolving, and the certain injuries may develop to become life-threatening injuries. And the arranging ambulance and a staff to accompany, that you have to initiate early, because in a hospital there are limited facilities, limited staff, and limited ambulance. The arranging ambulance at a particular emergency may be difficult. So you have to initiate, communicate very well, and prepare equipment. What are the equipments you need to prepare? Because this patient may deteriorate during the transfer, may need to resuscitation to be continued. So obviously certain IV fluids, sometimes blood should be carried with, and the oxygen supply, there should be additional oxygen supply, and the facility, the equipment needed for in case of you need intubation, you should be able to intubate. So laryngoscope with PT tubes, and the additional bandages, gauze, all those are necessary, and additional drugs, the sedatives, pain relief, those can be carried with. And you need to document very well what has happened in the emergency department. What is the presenting problem, and then the initial injuries, and how did you manage, what the treatment given, and any results of investigations, particularly radiological, and any blood investigation if done. And it is very important to communicate before transferring. You need to contact the receiving end, the staff, relevant surgeon. If you are transferring this patient, particularly for CT brain, then the neurosurgeon should be contacted. But both CT brain and CT abdomen, then better inform the general surgeon as well as this neurosurgeon. Then they will know and they will prepare and expect problems, and they will be ready by the time patient reaches the destination or the next tertiary care hospital. So that has to be done, and it should be documented as well. So when to transfer? First priority, you should stabilize the life-threatening conditions. What are those life-threatening conditions? Any obstructing airways, the breathing difficulties due to the pneumothorax, so with intercostal tube, and any bleeding, external bleeding, you have to control with the pressure or hemostatic suturing, splinting, and you have to arrange the transfer. What do you mean by transfer arrangement? Things will not occur spontaneously. So you have to prepare everything, informing the ambulance crew, nursing staff, other staff, and getting ready with the blood products if you need, and the other equipments, emergency drugs, and emergency items. So you have to arrange those things and inform the receiving and surgeons or clinicians, and the proper documentation of about the patient's injuries and management. And importantly, don't do any unnecessary investigations. What do you mean by unnecessary investigations? Time-consuming investigations, like certain imaging, CT, the contrast studies, angiograms, or the X-ray, various X-rays for detecting fractures. So, which may be unnecessary. Therefore, you have to minimize investigations in critically injured patients, so that will prevent any delay. And during the transfer, continuously you should be monitoring. So the monitor should be attached to the patient. You should be looking at vital parameters, pulse, blood pressure readings, saturations from time to time, being sensitive to the alarms for any changes in the vital signs. And sometimes you may have to continue the stabilizing measures continuing the IV phase, continuing the blood transfusion and giving oxygen, and need to monitor whether those are functioning well. Sometimes during the transfer, these tubes, whatever the tubes, even the saline tubes, EP tubes, or intercostal tubes, it may get dislodged, it may block, it may kink. So, and because patient may struggle, patient may turn, patient may pull out the certain tubes. So you have to be careful. And you should intervene any such things happen. You have to correct immediately. So kinking of IC tube, you have to correct, and the blocking of IC tubes, you have to correct. And in certain times, you may have to intubate even during transfer. Sometimes if you decided to trans and if you expect deterioration, sometimes and the longer transfer distance, then better intubate and send rather than trying to intubate while in the ambulance. But all those should be communicated with the clinicians before transferring. Documentation and communication is very important. You have to write the clear indication for transfer. Why are you transferring? For certain investigations, maybe CT abdomen, CT brain, or specialist neurosurgical management or neurosurgical intervention, or specialized orthopedic procedures like that, and or vascular surgeons opinion or management like that. You have to clearly indicate the need for transfer and history of the problem, mechanism, and what you have given as treatment, investigation done, any special events like developing even the episodes of respiratory arrest or cardiac arrest, or if you had to do the cardiac massage, or if you witnesses spurting blood initially, and if you witness the talking and the alert patient initially, then deterioration like that, you have to, any special incidents you have to document. So this is the transfer form which is used currently in the government hospital. I think this is very, very inadequate information. So you can use the other side of this paper to give much more details regarding the injuries and your treatments and any other particular incidents like that. Right, any questions? I'm happy to answer. So it's a very straightforward topic, but very important. Why I'm saying like this, because I have been working several years in the NHS accident service. We have received so many patients coming without stabilizing and deteriorating. The moment patient admitted to the hospital, patient deteriorated and deteriorating, and sometimes even mortality. So the reason is not taking adequate preparations before transferring, and also the very poor documentation and very poor communications. All these were happening, and therefore I want to stress it is very important to give much of your attention to properly transfer patient, properly optimize and properly communicate in document.
I would like to thank Dr. Mihira Bandara for that excellent presentation on the transfer protocols. And thank you so much. Roshan, I think we have come to the end of the program, isn't it?
Yes, sir. So I would like to thank Dr. Gayan Ekanayaka, consultant surgeon, for organizing the pre-intern training for this successful year. So also, sir, we will be having a common MCQ for all the interns, and they will get a certificate as previous years. So that's all from our side. So we have NLS program that's tomorrow at 8 a.m. So please don't by it. We will also have a final, at the conclusion of the program, there will be a speech by Dr. Asayala Gunawardena, DGHS of Sri Lanka, and plus with the college representatives also. So that's on the last day of the pre-intern training. That's from our side. So thank you, sir, for organizing the training program for the pre-interns.
Yeah, thank you so much. And I have shared for interns, pre-interns, I have shared the link again for resources in plastic surgery. So especially burns, facial trauma, and hand injuries. There will be continuous education coming through the our social media page. So you can actually, because this link will go off after we finish this program, and I would like to post it now. Probably you should be able to get the link and become members. We just give them about 1 minute so they can actually connect. The link will go off, and hopefully we will see you through that platform also. Yes. Thank you so much, and hope to see you as interns pretty soon. Yes. Thank you. All the best.
Thank you very much.
Thank you.